Ann Lyons. Number 7, Nori Vega. How about we go to in person? Is Emily Gianquinto here?
Good morning. I wasn't expecting to go first. Thank you for having me here and for holding this hearing. My name is Emily Gianquinto. I'm president-elect of the Connecticut Bar Association, and I'm here to speak in support of HB 7079 to be amended to include legislation that would allow trade associations like ours to pool members for purposes of securing health insurance. Association health plans have been a legislative priority of the CBA for several years. We have approximately 8,000 members who are located across the state. About half of our membership are solo practitioners or firms with 15 or fewer employees, and nearly 2/3 of our membership have 50 or fewer employees. So most of them qualify as small businesses. Unsurprisingly, we hear from our members that health insurance is their single biggest cost and the single biggest barrier when it comes to growing their businesses and taking care of their employees. Small firms are dealing with that expense in several ways. Some have been faced with a decision to offer no health insurance at all to their employees. They struggle to hire and retain talent. They struggle to grow their businesses. One solo told me that when she started out, she was paying very high prices each year for high deductible, low coverage plans via the exchange. She couldn't offer insurance to employees, and so she was faced with a revolving door of employees that she would train and then would leave in a few months because they could secure jobs that had benefits. She ultimately was faced with the decision to secure coverage for herself, to cut down on her practice, and started working as a state employee as a hearing referee. She would prefer to be working only on her private practice, but that's a decision that she had to make in order to ensure she had coverage just for herself. Some firms are handling these expenses by offering no insurance, but instead providing employees with bonuses that are intended to pay for them to secure plans on the exchange. Those firms are faced with the same issue of paying out higher and higher bonuses to their employees each year while knowing that their employees are getting less and less for that money. Some firms, to their credit, are continuing to offer the traditional employer-sponsored plans, and they're shouldering those expenses, but they look at it as a recruitment tool. Even those firms who are really dedicated to trying to make this work for their employees tell me that those insurance costs can be a quarter to more than a third of their annual expenses. At some point, it's just going to be unsustainable. There are the firms that do continue to go that traditional route, try to shop for the best deal each year, but they've found that increasingly challenging. For example, a 6-employee firm has for the past several years had only one employee who needed insurance coverage because the other employees had spouses that they could be covered under their plans. Every single year, that firm has fewer and fewer options for providing that coverage. They used to use Cigna. 2 years ago, that cost increased by more than 13%. They went with that plan anyway. Last year, Cigna stopped offering that plan. They were left with 2 options for healthcare plans. And then one of them would only work if they had 2 participants.
Your 3 minutes are up. If you could please summarize.
They only had 1 participant, so they effectively had no choice of company or plan. Allowing associations like ours to leverage our membership numbers to secure large group plans would have a significant and pretty immediate positive impact on the economic health of thousands of small businesses throughout the state and on the physical health of their employees. We urge you to address this issue in this session by adopting legislation authorizing association health plans. Thank you.
That you're here, and it's very refreshing, to hear that you are asking us for other options, because some of the bills here today are actually taking away additional options for small and medium-sized businesses. So I'm glad that people are here to hear your perspective, that we really need to do more in this space, and we should be having hearings that say we're going to offer additional options for small and medium-sized businesses. We're going to do this, lower the cost of care. we're going to do this to address rising insurance premiums, but those are few and far, between. Can you share with us what kind of plans that your members are using now? Are they putting people on the exchange? Are they going to the private market? Just share with us some of the options that you've heard from your members.
We don't have exact numbers. So like the examples I just gave are anecdotes from talking with some of our members, and we are working to get members to submit written testimony so you can get some of their personal stories directly from their mouths. Larger firms, and I'll just note, this is a problem. I focus my testimony on our smaller firms. Larger firms are facing the same problem. There will be written testimony from our president, Tim Sheeran, who couldn't be here today. He's at a firm that has more than 100 employees. They have the same problem because even when there are 100 employees, you just don't have the buying power to get more options for your employees or to leverage to secure the kind of plans that your employees want. My impression is that the vast majority of our solo and small firm practitioners are working off of plans on the exchange, which means they have been increasingly limited each year. Like that example I just gave where effectively there was no choice. They only had one employee who needed insurance. And so they had one option. They had to go with Anthem. There were literally no other carriers apparently that were offering plans for just one employee. I think I've gotten the impression that there are also a significant number of firms that are doing kind of the bonus or the reimbursement option also for their employees to secure plans on the exchange. And I want to make clear, this association health plans has come up for several years. We've obviously been advocating for this for several years. I know that there are concerns that there was some language in some previous bills that people were concerned was going to allow association health plans to discriminate or to eliminate people with pre-existing conditions. We don't want that. We're lawyers. We don't want to be discriminating against anyone. We're not looking to get some advantage by allowing this pooling to happen. We just want to be able to offer more options to our small firm practitioners in particular. It's a tough economy. It's always been a tough economy, but this sole expense is forcing people, and I know this is not limited to attorneys, but it's forcing our members to make choices between staying in their solo or small firms or going back to large firms. It's limiting people's ability to grow their practices, as you heard by the example of one of our members who had to take a job as a state referee so she could get insurance for herself. Just myself, I'm currently at a large regional firm, but I was a solo practitioner for 5 years. I would not have been able to afford that without having my husband's health insurance coverage. And it's a really common story. So I think many of our members are seeking plans on the exchange, and it's the options have just become so limited that it's untenable.
Thank you very much for being here today. Any questions? Representative Pavlock D'Amato.
Thank you. And really, I appreciate your testimony because as a solo practitioner, I feel like I'm not part of a big firm. I am trying to get help all the time, assistance, and I can't offer, a health plan that I think really would allow me to draw probably somebody who's full-time or permanent, like a big firm would. And I think I asked this in the past, but do you know the makeup or as far as small and solo firms, the gender breakdown, whether is it more male, more female, or have any idea?
You had this question last year, and
Yeah.
I know we submitted a supplemental submission. I have it in my bag, but I think our numbers, at least for last year, and reporting gender is optional, but I think something like 85% of our members, when they sign up, do report it. So I believe that our makeup it's more than 50% women in terms of members. And I think in our solo and small practice, if I'm remembering correctly, I want to say it's about 40% women who or at least, who are identifying themselves in those informal surveys. But I'll get that submission in and try to update it with our numbers for this year. So you have that information.
And either way, it's still I think for small and solo, we are constantly, whether it has to do with raises for state employees or in other contexts, I feel the comparisons are always in comparison to, I feel like, large firms. And because I know the salaries that they're talking about, I'm like, well, I never received that when I was working for another attorney. Even now as a solo with business expenses, it's very difficult. And this just adds on another hurdle, I think, in running a practice and really for any small business owner. So I do appreciate speaking on behalf of the attorneys. I really do.
Thank you for having the hearing.
Representative Meskers.
You almost didn't want to give me the floor. I want to thank you for your testimony. I think for the general public, as we talk about this, it's not an issue specific to small legal practices, but it's a generic problem, which is that small businesses are always at a competitive disadvantage. And now the insurance becomes one of those competitive disadvantages as well, because a firm with 1,000 people can pool, or their risk is de facto pooled to the 1,000, and therefore the actuarial estimates and all on the loss ratios, the premiums, there's less concern about a bad case or a good case related to cancer, any medical issues, because the assets are pooled. And so the insurance companies price it where it's a hit or miss with two people. If someone gets sick, will my premiums ever cover? Will your premiums ever cover the risk for that insurance policy? So without association health care plans, I think the problem is, I sit as co-chair of commerce and I sit on insurance. Without association healthcare plans, we're putting small businesses at severe disadvantages to larger businesses, and we're stifling their growth. We're stifling their survival, right? Or they're going to survive and strip their employees of any kind of insurance coverage, which is problematic. So I appreciate what you're saying there. I just wanted to let people know it's not endemic to small bar association members. It's endemic to small businesses if they can't form associations. I think that's the most important thing. And the only issue is that we're comfortable with the pooling of risk. And I think we've addressed those issues multiple times in our iterations. And we're still open to iterations, but pooling of risk, reducing the costs of insurance is something we've been trying to achieve on this committee for a while. So I thank you for your testimony.
Thank you. And I suppose like, we acknowledge this is a statewide issue for businesses. I'm obviously here advocating for my members who are attorneys. But I mean, it affects our clients as well. And I think your point about the competitive disadvantage is just the key one. I mean, people cannot afford, they want to grow their firms, they want to hire employees, they want to do right by those employees. And it's just become so cost prohibitive that is harder and harder every year. And so that's all we're looking for, are more options.
And that's, as it spills over into general business, it's the entrepreneurial spirit in the country, is for people to be able to start up businesses and grow the businesses, sustain their businesses. And we're compounding at 7 to 10% a year, somewhere around there on insurance costs. And it's not on insurance costs per se, but medical costs are compounding at 7 to 10% a year. It will be unsustainable. And the pooling is at least a good stopgap measure to try to contain those costs and offer people an alternative. So I appreciate. And I think importantly, we don't all want to be working at Amazon. Don't dislike Amazon. We all don't want to be working at Home Depot. There's a lot of entrepreneurs, restaurants, et cetera, that a pooling of risk would ease the burden and reinvigorate our small businesses, which I think is important. So thank you.
Thank you.
Emily, thank you for being here. We're gonna go back to the top. First, we have Comptroller Sean Scanlon. Welcome, Sean.
Good morning, everybody, and it is, as always, great and weird to be back in front of this committee, having previously chaired it and served with many of you in that capacity. But As always, happy to be here, and I would brief because I know you have a long hearing ahead of you. I am here to testify in strong support of SB 10, but specifically because of the provisions within SB 10 regarding mental health parity. When I had the honor of chairing this committee several years ago, I worked on a bipartisan basis to pass a very big law in 2019 that remains one of the things I'm most proud of passing in this building. And that bill has, I believe, made a big difference in our state with regard to ensuring that everyone in Connecticut gets access to the mental health care that they deserve. But I do believe that in the intervening 6 years, there have been reasons to improve the law. And that specifically comes down to two things, one of which is to enable the public to access data specifically about their insurance carriers. And two, when these carriers are found, if they are found, to have committed a parity violation, that the insurance commissioner have the discretion to impose fines as a way to bring some justice, in my mind, to a violation. So I'm here again on behalf of people in the state who constantly come up to me and say that they feel like they need to get more help. I know that all of us realize that, and I hope that this bill is one of the ways this session that the legislature will work to try to remedy that. Thank you.
Thank you, Comptroller. You had, just to go back to your first statement, are you supporting the entire bill or just the mental
I'm
health
here just
parity?
today to testify on that provision of mental
Okay.
health parity.
Okay, great. So is the insurance department not issuing fines?
My understanding is right now that they, with this bill, would have the ability to put forward much larger fines that perhaps because of the size of the fine currently, there are people who believe, myself included, that it's not as much of a deterrent when it comes to potentially a violation that
Okay.
a larger fine would be.
And when we had asked the department if and when carriers were fined, I believe there was one incidence a few years ago. So if there's one carrier that was fined and then has since, resolved their practice, having additional fines, having a higher fine rate, what would that really do? You think that would just send a message?
I think it sends a message, but I think it also speaks to the fact that while maybe one carrier has been found in the last few years to have been in violation, there's a contention that I support that says that perhaps that's because the insurance department doesn't have the cumulative nature of the data that they should or could to be able to determine whether there is, in fact, have been more violations in the past. And also, one of the big provisions that I think in hindsight, I wish we had done differently in 2019 was that these carriers are shielded from their reports, meaning that they submit their reports blind. The carrier's name is not involved in it. So the members of the public right now that want to see if their insurance carrier is complying or not with parity, they can't actually see that information. This bill would change that, and I think that's a good thing.
Great. That makes sense. I did want to, a lot of the press conferences and the testimony that was submitted, people are saying that this is a separate issue. This is, separate from mental health parity, but I think something that we need to address, which is the workforce shortage. A lot of the testimony is, I can't find a mental health
Yes.
provider. I've made 20 phone calls, there's just not enough people in this space, which is kind of shocking because when the governor put out his proposal to get rid of licensing, I was looking at the numbers of providers and there's a lot in that space, but clearly not enough. What do you think we can do? You have the chair of the Commerce Committee here too. What should we be doing differently, in your opinion, to increase the number of providers?
It's a great question, Representative. And what I would say is, as you know, every year I put forward a Comptroller's Healthcare Cabinet Report. You attended the event that rolled out. One of the biggest recommendations of the Workforce Subcommittee of that cabinet, which is run by a leader from the healthcare unions and a leader from CHA, was that we do some serious investing in workforce development. I am particularly very fond of a program called Health Horizons, which was a pandemic dollar funded program that unfortunately is about to expire, that we used during the height of COVID and in the last few years to dramatically ramp up the number of nurses that we trained in this state. It's worked. The money went to fund both faculty at different nursing schools like Southern and Eastern and some of the community colleges, but also helped people enter the field of nursing by paying for their scholarships there. That program runs out of money this year and will end, and that's a big problem. But I would recommend, to answer your question, the best thing I think we can do is create a Health Horizons program for all healthcare fields, whether it's radiology techs, pharmacy techs, licensed clinical social workers, LMFTs, all the people that we know there are big shortages of, and really invest in the healthcare workforce. And I think if we can do that, it will help solve this problem from a different angle, which I think is important.
Great, wonderful. Any questions? Representative Pavlik Tomato.
Thank you, and thank you for your testimony. And just quickly, I'm just looking at the bill. What are your thoughts on the, I think there's an account that's going to be set up. Are you in support or not in support of, and it's a parity advancement account that would be within the general fund. What are your thoughts on that?
I believe that the account is important. I do think that sometimes accounts in the general fund tend to disappear. And so I would be in favor of that being a separate standalone account so that we could ensure that any money that does get into that account from fines from companies that were to be found for violating parity, we could actually ensure that those dollars go to actually advancing parity and not get swept into the general fund.
Yeah, I think we just spent a whole, several months working on all these funds and assessments that end up going on everybody's policy. And that's, we're trying to get away from that. So we're not increasing those costs. So I think with the right wording, it's possible, and I agree. But just one more question about data. So are you saying that you don't think the enough data or the correct data is being obtained, or?
I don't think enough data is being obtained, and I don't think enough data is transparent and available to the public, and that this bill would change that.
And I get the name, putting a name to data. I just want to make sure that whatever we're asking for, that it is being provided. And that's, of course, I think the most important part, because without that data, I'm not sure how far and really if we can analyze what we need to. So, but thank you for your
Agreed.
testimony. I appreciate it.
Thank you.
Any other questions? Representative Meskers.
It's good to see you, Sean.
Good to see you
Thank
too.
you for your testimony today. I'll just, I guess, highlight the term I always get uncomfortable with is parity. And I don't think it refers in this bill per se, but as the controller, I've been lobbied by various groups on parity on providers of service. And sometimes the word parity is used to bring the cost of the service to the highest priced provider, which then spills over into the insurance and costs. So I know this isn't the case in this one, but when we go forward in legal stuff, as my controller, when you see parity, make sure that we're talking about the equality of service, and make sure that when it's an economic parity, I'm kind of more inclined to go that the parity would work better if we go to the lowest common denominator on pricing, so we can deal with the best outcomes. I think that's an issue I've kind of figured out in the capital. Sometimes when we refer to parity, it's like raising everyone's price. And I'd like to lower everyone's price and get access on a more broader scale. So, but I appreciate your testimony on that. Thanks.
Thank you, President.
Representative Nuccio.
Thank you, Madam Chair. So, thank you, Sean, for coming and talking about this. And I have some just general questions in regard to the mental health piece of this. As I'm sure you're aware, there's two different sets of filing, NQTLs and QTLs, and the QTLs are basically an NAIC standard form. So what is it about the form that the nation is using, do you think, is not comparable enough for what we should be doing in Connecticut?
I don't have the exact language in front of me, Representative, but my understanding is that the biggest thing that I and other people have a complaint about is that it's anonymous, that the filing is anonymous.
Well, I believe it's part of the market conduct exams here in Connecticut. In other states, it's part of rate review and a couple of different things. And the market conduct exams are published on the DOI's website.
But there's specific filing with regard to the 2019 law, which this law before you updates. That is what my focus is today, is that that information has been shielded from the public, and the carrier's name and information is not on the filings that the 2019 bill created. There may be other filings out there that you're speaking about, Representative, that attest to some of this information, but the bill before us today is about amending that 2019 law, and that 2019 law shields the carrier's information, which prohibits, in my mind, the people and the public from gaining access to what their carrier is doing.
Okay, so the 2019 law, wasn't it pretty much a copy of the federal, the 2008 law?
It was an update on the 2008 law, and the whole point of that was that in that 10-year period, we learned more than we knew in 2008. But I can't, again, speak to the exact specifications of what the federal law is versus what the 2019 Act was.
I think they're pretty much the same, because the federal law is the framework, and then, every state pretty much just adopted that. So I would think from this perspective, if it's just a matter of releasing the names, I don't see anybody would have a problem with that because it's already out there, right? Like the Department of Insurance has have them, the Department of Labor is doing these reviews of the ERISA plans, and, across the board, the fine part, again, just raising it, I don't know that it's going to do what I think everybody thinks it's going to do, because in the history of the mental health parity here, we've only had one violation, and it was a network adequacy violation in, I think, Fairfield County. And I think what people don't realize about that is when there's not enough providers in a network, the network adequacy piece of it means you can go to an out-of-network provider and get your same cost share benefits that you would if they were in network. I think the bigger issue that we really have to conquer with mental health parity was, my first year up here, I had a task force to see, why do we have so many providers that don't want to be in network, right? So how can we bridge between the net providers and the insurance companies to get more providers in network? And I had a bill that, again, didn't make it through this year. I've spoken to plenty of providers who say that part of their issue is documentation, doing work that they're not paid for. And that's part of the reason why a lot of providers do not want to be in network, because of the onerous documentation that they have to do, which is different than what a medical doctor would have to do, right? So actually equalizing that and either giving them a paid amount of time to do the paperwork, or I've pushed back and said, if insurance companies are requiring this information, show me how you're using it. How is it helping make better decisions? I think that's the kind of work that we really need to be doing on mental health parity, is getting more doctors to participate in network for people who are on plans, which whether it's Medicaid, Medicare, or not, I think there's like 30,000 people who don't have insurance in the state of Connecticut. And then making the parity of reporting requirements. This fine, while I get like, it's a big flashy number, but when you don't have people who aren't there within, they're in parity, you're not going to realize the savings. And I think we have to do the real work to understand how to get providers in network and how to make their jobs better for them. Because if you're doing 2.5 hours of paperwork for your 4 people that were just there, that's 2.5 hours that can't see people, right? So, I'm always looking for ways to make accessibility and affordability. And I respect that this bill has been honed down from what it originally was. I just don't know that, it's kind of legislation that looks like it feels good, but I don't know what we're going to actually get for change to help providers in that. So, I respect the work that was put in, but I'm looking for a partner to actually sit down and say, how do we get more providers here? And how do we get them in network? Because as Representative Wood said, when you look at the amount of people who have licenses in the state of Connecticut, they're not all providers in network. When they can get $300-400 out of network, how do we get them to move? And how do we make this so they can see more people? So thank you for coming, though. I appreciate it.
You're welcome. Thank you, Representative.
Thank you, Comptroller Scanlon.
Thank you, everybody.
Next up, we have Commissioner Deidre Gifford.
Good morning.
Morning.
Senator Cabrera, Representative Wood, members of the Insurance and Real Estate Committee. I'm Deidre Gifford, Commissioner of the Office of Health Strategy. thank you very much for the opportunity to testify this morning on two bills that you have before you, Senate Bill 10 and House Bill 7115. Both of the issues that I'd like to speak about this morning have to do with healthcare affordability. I'm pleased that the first witness actually did a much better job than I could do talking about the real world impacts of our high healthcare costs in Connecticut and some of the impacts to small businesses. We know that nearly half of Connecticut residents have delayed or gone without care due to cost. A third are struggling to pay their medical bills. We know that 10% of households in Connecticut have medical debt, which is higher than the national average and higher than our surrounding states. So I think we're all in agreement that we have an issue with healthcare affordability, and we're all trying to work together to figure out a path forward to make healthcare more affordable. I'd like to speak to two sections in Senate Bill 10 that tackle some of the elements of our high healthcare costs. First of all, in Section 9 of SB 10, a proposal works to reduce price variability. OHS is in support of the intent of this provision. And as you know, we've worked together with the legislature and the Office of the Governor to reduce facility fees. We think this provision would build on those efforts to ensure that the prices charged for healthcare services don't vary either by the site of where the service is delivered or within a geography. We know that unexplained price variation can be a factor in driving higher healthcare costs. And providers and insurers should be able to justify the reasons why prices vary for the same procedure, either between locations or within the same geography. There may be very good explanations for price variation. For example, if the provider provides higher quality care, if their health outcomes are better, if they provide medical education, if their labor costs are higher, all of those things can contribute to higher inputs. But sometimes and very often, price variation is not explained by those factors. And so OHS is in support of the intent of that provision. Section 11 through 17 of SB 10 speaks to looking at affordability in rate setting, insurance rate setting. This proposal would require CID to consider whether proposed insurance rate increases are, quote, unaffordable, in addition to their existing criteria of review, excessive, inadequate, or discriminatory. Per the proposal, a rate would be considered unaffordable if the commissioner determines that the rate or amount is inconsistent with the Connecticut Healthcare Affordability Index or some other index agreed upon by the commissioners of CID and OHS. CID would also be required to have a 30-day public comment period on all the documents and materials provided with respect to the rate increases. We agree at OHS that affordability should be a factor when considering premium rate increases. We've offered testimony in this legislative session on the governor's proposed bill 1253 that would also allow CID to decrease an insurer's proposed rate by up to 2 percentage points if the rate increase exceeded the cost growth benchmark. So we look forward to working with this committee with CID and others on how to approach this issue of affordability. I'd also like to just offer comments on 7115. This is an act concerning revisions to the healthcare cost growth benchmark program. As you know, you all enacted the cost growth benchmark program in 2020 that sets targets for year-over-year increases in healthcare spending per person. We've set benchmarks from 2020 to 2025, and we're in the process of proposing new benchmarks for 2026 and beyond for the next 5-year period. The first 2 years that we reported, the state did exceed the cost growth benchmark, although we exceeded it by less in the second year of reporting. OHS is about to release later this month or early in April our 2025 cost growth benchmark report. This bill proposes to strengthen the benchmark program in 3 ways. First of all, by requiring insurers to work with employers before they would decline to send us information needed for the benchmark. Since the benchmark's inception, all of the Connecticut insurers have rolled up into its aggregate numbers their cost measures, not by person, not by service, not by claim, but they've rolled them up into aggregate numbers, including their fully insured and their self-insured members. They've submitted those aggregate numbers to OHS since 2020. This year, for the first time, one of our insurers informed us that they would not be submitting the self-insured information. This proposal would require them to ask the employer before declining to submit that employer's data to OHS for the benchmark. So we think this is a way that employers can understand if their data is being withheld from this very important measure of affordability, and would engage the insurers in making sure that we're getting the most complete data possible to measure the benchmark year over year. So that's one provision. The second provision would allow OHS to establish policies and procedures throughout the benchmark statute. We have the ability to establish policies and procedures in some parts of our statute while regulations are pending, but not everywhere. So this would just apply it more broadly to the benchmark. The bill proposes that we study performance improvement plans for the benchmark program. We proposed implementing in sometime in the future performance improvement plans last year. I think the legislature felt that that was premature. So we thought having OHS perform a study on how performance improvement plans are working across the country, what our options are, would be valuable information both for us and for you, so that we could consider performance improvement plans for the benchmark in future years. Finally, I'll just quickly say that we seek to strengthen our ability to compel participation in our June hearing, which is part of our statute that we hold a June hearing every June. Strengthen our ability to compel participation by entities that exceed the benchmark or significantly contribute to exceeding the benchmark. As you know, the current statute requires entities to participate. The statute says they shall participate in the hearing. The first hearing, we had one pharmaceutical manufacturer decline to participate in the hearing. We invited them. They said, we won't be coming. Last year, all 3 pharmaceutical manufacturers that we invited to participate in the hearing declined to participate. So last year, we proposed extending OHS's subpoena power, which we have under other parts of our statute, to this hearing. Some of the members of this committee and others in the legislature felt that that was too broad of an authority. So what we've done this year is we've significantly narrowed the subpoena authority that we are requested, which would just be to address for those who fail to attend the hearing. So those who, like our hospitals and insurers who have voluntarily participated in the past, no subpoena would be involved. If an entity is invited and fails to come to the hearing, OHS would have the authority to issue a subpoena. That language isn't in the current version of the bill, so we look forward to working with this committee to understand how we might be able to require participation in this very important hearing, which really shines a light on what the drivers are of increasing healthcare costs and helps us engage in really important conversations with the entities that are contributing to the benchmark. Thank you again for the opportunity to testify. I'm happy to answer any questions that you might have.
Thank you very much, Commissioner Gifford. So when you had asked for the subpoena power, the reasoning was that there were 3 pharmaceutical companies that would not participate. Senator Cabrera and I did have a meeting with those 3 companies, and you know, there was a willingness to participate and talk, but they felt like they weren't being heard. In some examples, there were meeting requests being asked for OHS that took a year for OHS to respond to. So would you be willing to have a meeting with some of these players and members of the committee to talk about how to improve the benchmark process and their participation?
Representative, we're always happy to meet with stakeholders. I don't know the meeting requests that you're referring to, so if you could give us the specifics, we'd be happy to offer any explanation. When we asked the pharmaceutical companies to participate last June, they felt that the definition of participation was that they could simply write us a letter. They also disputed the fact that they were contributing to the high cost of healthcare. They didn't think that OHS's definition of a significant contributor was sufficiently justified. So we shared data with them about how we derived, how we arrived at inviting these particular companies. It was because they had expensive drugs that we had data demonstrating that had contributed to the higher cost of healthcare. So we're happy to discuss with this committee or with any stakeholder ways that we can improve the benchmark process. But the legislature put a hearing into the benchmark statute and said that entities shall appear. It's clear to us now after 2 years that if we don't have any enforcement authority, entities will not feel compelled to participate in the hearing.
A lot of what we're hearing from a lot of the people that are participating in the benchmark is that there's a misinterpretation of data, not enough data, a lot of confusion around how OHS may have derived data. It seems to be the same thing over and over again. And in fact, one of our previous hearings, we have, I think the hospitals were participating, and I asked each of them, about the process. And a lot of them expressed a large, there's a large room for improvement there. When we do have these discussions offline, there's that story keeps happening of like, here's the data, here's the story, we're just not on the same page with OHS. So I think our last public hearing, we put in a bill to do a third-party audit of the benchmark to kind of put this notion to bed that, what are the flaws in the benchmark? Where are the places to improve? And let's get this back on track. But you submitted testimony in opposition. Are you opposing a third-party audit, or are you opposing the language that was in that third-party audit?
A few things, Representative. First of all, I've said this before, and I'll just make clear again that OHS is always interested in partnering with entities that have questions about our data. We are very transparent about the way we collect, what we collect, how we analyze it, and how the results are derived. We have created an entire web page now on the OHS website around data transparency. We've also created several dashboards where entities can actually use the same all-payer claims database data that we use to derive some of the information about cost drivers. They can go on and use those same dashboards and come to their own conclusions. We've also offered to do expedited data use agreements with entities who request data to do their own check. We're happy to work with parties who want to check our work. That just makes things better. So we have no challenges at all in hearing feedback on the data. I think the issue is we do dozens and dozens of analyses at OHS. And to hear the data, it's not all that helpful, because which data are we talking about? The bill that was proposed that you referenced was aggregate rolled up data that I was speaking about earlier. That data comes from the insurance companies based on their claims. Our concern with that bill was that first of all, that would another state agency would be doing the auditing that isn't responsible for the benchmark program, but also that an outside auditor would really not have the capacity, short of requisitioning all of the insurance companies' claims data, of actually auditing those rolled up claims. So I hope I've made clear that we have no issues with working with our stakeholders. As you know, Representative, because we sent you the letter, I think we have an 11-page response to specific data questions that have come to us from the Hospital Association. We've walked through each one of those things. We spent a good amount of time over the summer and fall of 2024 working with CHA on each one of those specific issues. Our responses are available on our website. It's why we developed this whole data transparency website, because we understand if we're going to be characterizing an entity's cost growth, they want to be able to understand how we arrived at those numbers. So we're doing tons of work on that. We continue to do that work. But I will say, I think we've resolved the vast majority of differences in the way that CHA and OHS are approaching the data. And on some things, there's a policy decision that OHS has made that the hospitals disagree with. But we hear these same things in all the states that are doing benchmark work. And I think it's less a question of the data and more how the data is maybe being used or interpreted. But we're happy to continue to work on any specific further requests that come from stakeholders. We're happy to hear. I don't, in the particular instance of the pharmaceutical companies, we laid out in a lot of detail for them how we arrived at the decision to invite them, and they just simply didn't agree with our strategy.
Right. All right, thank you. The last question I have is that you started your presentation with SB 10 would help lower costs for small businesses, and I'm really confused by that statement. I see major costs in this bill, addition to the stop loss policy, addition to stronger health mandates that would be very costly. Our first person up here was talking about just the very few options in the marketplace for small and medium-sized businesses. And I'm just not seeing how SB 10 lowers costs and provides more options for anyone. I don't know if you can, that's just my take on it.
Yes, thank you. I was referring specifically to those sections, Representative, that I mentioned. I think that the cost variation is something that we are looking at OHS and a lot of states are looking at, and that is addressed in the bill. Unexplained variation can be a driver of higher costs. So that's one section. And then the other sections that I was referencing have to do with the ability of CID to consider affordability in their rate review, which we also think could help lower the cost of health insurance.
Thank you for your testimony. Any questions? Senator Cabrera.
Thank you, Madam Chair. Dr. Gifford, thank you for being here. Thank you for your commitment to helping us work on lowering healthcare costs. You mentioned some of the mandates that the legislature put in place and the pharmaceutical companies not responding. Could you walk me through a little bit when you say that? What was the nature of that? Did it come in an email? Was it a phone call? And then also, what were there some of the reasons given for not meeting with you?
So I have members of my team here and they may want to add. So we invite the entities to appear at the hearing via letter. And the letter explains the rationale that OHS uses to arrive at the invitation. Those are actually also in statute, Senator. Either they exceeded the benchmark or they significantly contributed to exceeding the benchmark. In the case of the pharmaceutical companies, it was they were invited because they were identified as significantly contributing to the state exceeding the benchmark. We identified particular products made by those manufacturers that had had increases in prices or on which the spending was very high in the state. And we sort of ranked those. And then we identified the manufacturers and invited them to participate. So we received letters back from the manufacturers explaining that they disagreed with our methodology. And I don't want to misspeak, so you all should tell me if I get this wrong, but I believe what the justification was, our letter serves as our participation in the hearing. So another thing in our bill allows the Commissioner of OHS to specify the form and manner of participation in the hearing, because that isn't, it isn't in the statute. So we would be clearer that participation in the hearing generally would involve oral testimony, but without any way to compel entities to be at the hearing, we now have evidence that some will choose not to participate.
Okay, I think I understand. And I think what we could do going forward, and we alluded to it here, I think we should have a conversation with you and your staff and others on how we can find a way to reconcile this. But I really appreciate you taking the time walking me through that. Thank you.
Thank you, Senator.
I do see other hands raised. I know that the commissioner does have to leave for a funeral. Would everyone mind taking questions offline to her office directly? If that's okay? Okay, thank you. Thank you for your time.
I do apologize, and I
Yep.
appreciate your
No, we understand.
indulgence. I do want to get to that.
Yep.
Thank you very much.
Thank you.
Appreciate the opportunity.
Is Senator Looney coming? Senator Jason Perillo. Oh, he's at the funeral.
Good morning. Senator Cabrera, Representative Wood, the rest of you. All of a sudden, right? You people. No, seriously, thank you very much. We appreciate the opportunity to testify on SB 10. I've spent my career in healthcare the last 10 years in mental health and addiction. And the issue of parity is something that I've witnessed firsthand, and I understand just how important it has become when it comes to access to mental health care. But I'm hardly an expert, but I'm here with someone who is. I'd like to introduce Dr. Andrew Gerber. He is the president and medical director of Silver Hill Hospital in New Canaan, and he can speak to this far more effectively than I can.
Thank you so much, Jason. Good morning, Senator Cabrera, Representative Wood, and members of the Insurance and Real Estate Committee. As Jason mentioned, my name is Andrew Gerber. I'm a licensed child and adolescent psychiatrist in Connecticut, an associate clinical professor in the Yale Child Study Center and Department of Psychiatry, and president and medical director of Silver Hill Hospital, a private nonprofit hospital in New Canaan, Connecticut, that works with people of all means and accepts insurance. I'm also secretary of the Connecticut Psychiatric Society and a volunteer member of the All Payer Claims Database, or APCD, Data Release Committee, which you just heard about. My group is in the Office of Health Strategy and is responsible for evaluating applications for the use of this important state database. My background in training are in clinical care, particularly of children and adolescents, psychiatric research, and hospital leadership. Thank you for the opportunity to speak to you today. I'm here because my role as a clinician and as a parent, I care deeply about the mental health of the people of Connecticut, particularly our young people. I became a psychiatrist because I know that we can help these individuals with state-of-the-art treatments. But my heart is breaking because every day I meet with and hear about patients with mental illness and addiction and their families who suffer terribly because they are not receiving the treatments that we know to be effective, inexpensive, and efficient. We are living in the midst of a mental health epidemic. I've heard many people say that this is a complicated problem with no clear solution, but I'm here to argue that that is not the case. To me, there is one overarching explanation. Stigma against individuals with mental illness and addiction is alive and well. The most striking example of this is what we're here to talk about today. that we as a society allow our healthcare payment systems to treat people with mental illness and addiction as pariahs instead of patients, despite the fact that we know conclusively that these are brain diseases that are present in one form or another in all of our families. We have conclusive findings from our own Office of Health Strategy in Connecticut and from reputable research based on national data that government programs like Medicare and Medicaid and commercial insurance plans, both employer and insurance funded, are less likely to reimburse care adequately for mental health and addiction as compared to physical health, less likely to have adequate provider networks, and more likely to deny claims. As a result, providers in even a state like Connecticut, with universities, training programs, psychiatrists, psychologists, and social workers second to none, are much less likely to accept insurance. I'll share one very important statistic. Mental health services in this country are 5 times more likely to be charged out of network as compared to physical health. Other states like California, Illinois, Colorado, and now Washington State are passing new laws to ensure that payers follow federal parity law so that their citizens can get better access to treatment. In 2019, as you heard earlier from the comptroller, thanks to members of this legislature, Connecticut started down that path with parity legislation. Today, we can and must do better with new and stronger legislation to enforce mental health parity. I'm proud to be a child psychiatrist in this state and a parent, and I implore you to help me improve the mental health of the residents of this state by supporting laws that ensure they are treated with care and dignity. Thank you for your time and consideration.
Thank you very much for being here. I hear you, but I want to ask, how does this language in this bill help the patients that you're describing here today? Because that's where I'm trying to figure out the connection.
Sure, no, thank you, Representative Wood, and that's an important question. I should start by being clear that I'm an expert in psychiatric care and in research. I'm not here to say that I'm an expert in legislation, but let me share a couple things. One is that the rates that are paid to my hospital and to the individual providers I know are insufficient to have people want to be in-network providers in this state. And around the country, it's true, but in other states are moving to change that. Our own hospital loses money, and we're a relatively small, medium-sized hospital that subsidizes the care that we provide with insurance only because we have the luxury of some patients who are paying privately. That shouldn't be, and it can't be in many parts of this state. So as I understand aspects of this law, and I defer to all of you who understand the legislation much better than I do, that if we can incentivize the payers to pay fairly, I'm not asking to pay, I think it was mentioned earlier, top dollar, that wouldn't make sense. That wouldn't be affordable. But to pay fairly as compared to physical health, to my mind, that then incentivizes psychiatrists like myself and other mental health professionals to take insurance, which we should be doing, which we want to be doing, and hospitals to provide the services they need. I believe that if we do that, some of the provider network issues that you mentioned earlier, and believe me, I'm all in favor of less paperwork and that, I think that's wonderful, but I think we have to pay fairly. And then the last thing I'll say just quickly is, and this is partly my role on the Data Release Committee and as a researcher, if we had the data to look at these systematically and to essentially say, okay, these insurance plans cover these things from a mental health perspective, I believe that would incentivize both employers and employees to engage in a free market where they make decisions and employers can say, listen, we can afford this plan for these patients, and you can make choices as employees and as employers about which plan to take. We can't do that now because we don't have the data.
I 100% agree with everything you're saying. What your issues are will not be solved with this bill. Paying providers more is not mental health parity. I would love for us to do something on working how we can incentivize to pay providers more, to be more in network. You know, maybe it's, if you take, you know, X, Y, and Z percentage of, you know, insurance, you get a tax incentive, you get your fees waived with the state, but we're not doing that with this bill. But I hear your issues and I want to solve that problem. So, I mean, there's homework for us to do here. And I think that's something we can do through the Commerce Committee. It's something we can do with the Finance Committee, but I want to solve problems that you're experiencing. I'm hearing the same thing. Representative Nuccio just said the same thing. Why would you be, you know, why would you be a network at $120 for reimbursement when you can do $300 an hour private pay? That's what we have to solve, which is not part of this bill. I just wanted you to know that. I'm not disagreeing, but I want to be helpful.
Representative,
Senator
if I
Perla.
could comment on that too, though. A solution that doesn't address in some way, shape, or form reimbursement doesn't really get us where we need to be. I mean, look, in the broader scheme of healthcare reimbursement, it's like the cost shift we see in hospitals, right? We know that Medicaid's going to get reimbursed at a lower rate. We know that Medicare is going to get reimbursed at a lower rate. In fact, lower than the actual cost of providing care. The only way it works is because commercial reinsurers, and Representative, you know this, because commercial reinsurers pay at a much higher rate. So that's the only way that works. So I think what providers are asking for, let's at least raise that lower barrier. Let's at least raise the floor so that so that providers can make it work. Because if reimbursement for mental health services is so low that there's no way to bridge the gap, then where do we start? And I understand, like you said, and I completely agree, Representative, there's opportunity for a more holistic approach and more holistic solutions that are beyond just reimbursement. But at the same time, that we do have to acknowledge that there is a significant problem and a disparity between reimbursement for physical health and reimbursement for mental health. That's not the only solution, but I think we have to acknowledge that it's part of the problem.
Absolutely. And you have my commitment to working on this in a way that will, you know, move us forward. And I just appreciate you coming and sharing your personal experience. Representative Nuccio.
Thank you for coming and sharing your experience on this. And I almost just called you Representative Perla.
Call me whatever you want.
That's going to take a while to get used to. You just mentioned the floor of rates, right? So I think a big piece of this is that mix, right? We know Medicare and Medicaid pays lower, and then commercial insurance pays higher to supplement those shortages, right? So I guess where I'm not clear is because I'm intimately involved with mental health parity. I can tell you about the federal law and everything, and it's some of the things that you said, being able to understand what people pay. It's simple. It really is. Like the federal law says you have to have equal or richer benefits for mental health for all services, right? So there's nothing that is not covered, right? If it's a lab and it has to do with mental health, if it's radiology, if it's inpatient, if it's, you know, specialization, if it's therapy, all of that is covered, right? The mental health parity law basically says you cannot have cost shares that are more restrictive than medical. It's about cost share. Nothing in the federal legislation talks about payment parity at all, right? And we know that's an issue. You know, I have a daughter she's a neuropsychologist. I get it. Talk to her on the reg. Trust me, get an earful of it on the regular, right? I talk to all of her friends. I see that. With the payment piece of it, though, the commercial rates are already higher than what Medicare and Medicaid is. So I'm not getting the nuance. Like I understand full-heartedly that we have to look at the Medicaid rates. It was like the number one thing, the first part of the Medicaid rate study that came out that said we were not paying adequately for mental health. Wholeheartedly agree with that. I would also argue that I don't think even the higher commercial rates are comparable for what we're asking for. But I don't want to go down the rate of saying you have to pay X amount and you have to pay X amount, because it doesn't end with mental health parity there, right? That goes now, you know, depending on the lobbyist and who their favorite legislator is, you know, dentists are going to get paid this much and this one's going to get paid that much. So where's the disconnect? Are you heavily in Medicaid, Medicare? Is that like where the issues are? Are we talking about bringing those rates up? Or the people who are paying privately, who will always pay higher, unfortunately, when it comes to mental health here. So where's the disconnect? What do you?
A great question. And let me tell you my thoughts about this. So we take all of the above, right? We have private, we have Medicare, we have Medicaid, we have commercial insurance, both self-insured and not. And as you say, there is a range. What's fascinating when you look at some of the data and the APC data is that the payers pay differently for different providers. They pay Yale differently than they pay Hartford Healthcare, differently than they pay anybody in the community. There's almost no rhyme or reason unless you imagine that these things have been over time negotiated for various very obscure reasons. And that's to me where the idea of the free market comes in. I believe in the free market. I believe that when you know how much something costs for the purchaser and the provider knows how much they're going to get paid for something, there can be that kind of complex set of market interactions that determines the rates that people are willing to pay for and do so fairly. But that's not the system we have. So we have a wonderful group of CEOs in New Canaan. We're blessed in New Canaan to have a bunch of CEOs living there. And our local community foundation pulled this group together because they care deeply about mental health. And what the CEOs said to me, and I hear this from our patient families all the time, is they have no way of knowing. They have no way of measuring how well the different plans reimburse mental health care. It's obscure to them. Even when they're self-insured and go and ask the insurers, they're told we can't share that data with you. And so to me, that's the free market not having a chance to do what it does best, which is negotiate these rates. I agree with you. I don't think government should set the rates. I think that would be inappropriate for a variety of reasons. But I think if we had the data, then the market could do its job.
So, okay, so you're looking at basically negotiated network contract rates, right? And they're different, depends, and that gets down to the size of your organization. Like I tell therapists all the time, psychologists, the single shingle is what's killing you, right? If we actually had an associated health plan where all the therapists could get together, bulk together, they would get much, when you're negotiating, your power is in numbers, right? A single person has no true bearing over how a network rate is going to be determined. That's, I think, kind of part of the problem of the nature of the therapists, like the single shingle. Like, how do we get them to bulk together to negotiate as a whole to get a higher reimbursement rate?
That sounds helpful. I will tell you that even as an organization that's a moderate size, we have about 400 employees. I have trouble negotiating with the insurance companies. We had an over 20% increase in our premiums. So I agree with you that one of the core issues here is affordability of premiums as well. But do we have the data to say, even as a psychiatric hospital, I can't tell my employees what kind of mental health benefits they're going to get because that's obscured for me.
Well, you should be able to tell them what benefits they're going to get. That's part of your benefit structure.
I can tell you the big title, but I can't tell you what the insurance is going to reimburse at the level of their individual illnesses. That's all kept for me. And therefore it's very hard for me to make decisions based on that, and it's impossible for the employees to make decisions.
I think I see where you're headed with that. And do you also look at the negotiated rates of the medical side, like how much because everybody's PCP gets paid something different, right? Because
I do. And listen, if it worked the way I'd hoped, all of this would be transparent.
Yeah.
But what I can see from the APCD data, I can't see it from my own data, but I can see it from the APCD data, is that the physical health rates are, if you pick any benchmark, are higher. Roughly speaking, if you use Medicare as the benchmark, this is on a national basis, this comes out of the Kaiser Family Foundation, physical health primary care visits are somewhere between 10 and 20% higher than the Medicare benchmark, and mental health and addiction are 5 to 10% lower. That's a big difference, at least as a national level. I don't know it at the level of the plan.
Yeah, I think that's the part of it all being together, right? And non-PHI and everything else, I get that. And listen, I've been saying the day one when high deductible health plans were introduced, I'm like, this is not going to do. You can't tell me that I can be an informed consumer if I don't have the information to inform myself, right? You're it's a black hole.
Absolutely.
So I understand what you're saying. I think there's some nuance in there that we could sit down and probably talk about it for hours, but I understand what you're saying. And we do, again, part of it is so much is conflated, right? From a mental health, if you talk about mental health parity, you talk about the 2008 law and the 2021 CAA amendment and everything else, it has nothing to do with payment. It has to do with accessibility. It has to do with, the cost share. So making sure that, if he charges me $100 and you charge me $500, I'm still only paying 20% of my co-insurance or a $5 copay for both of those regardless, right?
Yeah.
And I think that's what people kind of conflate when they start talking about payment parity. And again, I get it, I hear it, and I've tried 5 different pieces of legislation since I've been here to try to get people to pay attention to the fact that, we have to get more mental health providers in network because it's an accessibility issue.
Exactly.
It really is. It's I was just talking to somebody this morning saying, when I graduated high school, I know it seems like ages ago, but it wasn't the Stone Ages. I was looking for jobs and healthcare wasn't provided standardly at a company, but I was willing to take less money to work for a company that had healthcare.
Right.
Now healthcare is standard across the board, but accessibility is just, it's like you have healthcare, but doesn't mean you can get in to see somebody. And how do we fix that, right? How do we get more providers in network and in availability? And as you probably heard me say earlier, a lot of people tell me about documentation, unpaid time, unpaid hours.
Yep.
And I could be seeing a client instead of, and making money and seeing somebody rather than doing this. I'm interested in trying to find ways to get more providers in network. And I understand, in the field that you're in, like what are you seeing from an accessibility issue?
Well, I think you've summarized it quite well, actually. So what we see is a lot of providers in our area, and we're in Fairfield County, but we treat patients all
By
over.
the way, you guys were the one county that were out of
Yeah.
mental health compliance
Yeah.
because you did not have enough providers
Right.
in network.
In
one
network.
time. Exactly.
And that's
in
exactly,
network.
and you are exactly right,
Yeah.
because there is such a powerful incentive to not be in network because the rates are lower and because of some of the requirements, like you mentioned, like documentation. So I think we do have to address that. What strikes me, though, is that you have these employers, you have CEOs who are incentivized to provide good care for their employees and their families. Because what they say to me is, listen, I know my employees are more efficient. They do better for me if their mental health is good and their family's mental health is good. So they see a financial incentive to provide the kind of insurance that would be most helpful in keeping their employees well. But what then they say to me is, but I don't know how to do that, because when I shop around, I see this sort of high level descriptions of what the plans cover. And so I get calls pretty regularly from family members, and they say, Dr. Gerber, I was told that by my insurance company that this isn't covered. That can't be true. I have great insurance. And I have to be the one to say to them is, I imagine you do have good insurance in many respects, probably physical health. You could get a shoulder operation because you can't play tennis. You would get absolutely top care for a cancer diagnosis. But what you didn't know is that the care provided by that same great insurance plan for mental health and addiction is inadequate. They don't know that until it happens to them. And then I usually say to them, well, you've got to talk to people about this, because the next time you go out and look for insurance, you got to tell that insurance company that you need to know the details of that. And what they then come back to me and says, yeah, they won't share that information. And I think that needs to change.
Well, I think a couple of things. First of all, when somebody gets that phone call, you should tell them to call OHA,
Mm-hmm.
right? Because they help to negotiate it.
Mm-hmm.
And second of all, for these CEOs, right? The majority of these people, if they have administrative services only plans, they build the plan.
Right.
They say what can and cannot be put in there. They have the ability to go uncookie cutter all the time. So, it's educating people enough to say, make sure you're saying, I want to cover this, this, and that.
Right.
I started out in the insurance industry ages ago when I was a claims processor.
Ah.
And then I was like a manager of a bunch of people who process claims, which meant that I got the phone calls from the CEOs who would call up and say, my wife is going to get this done, pay for it.
Yeah. Yeah.
They have the ability. A lot of people don't realize. I tell people all the time, if you don't like your plan, go to your HR and talk to your CEO, because they're the ones who decide what goes in it.
Yeah.
Right. So I think there's a lot we could definitely talk about and learn from each other here. And I think there's a lot that we could do together. I hear what you're saying. I need people to care enough to want to figure out how to get these providers in network and how to get them to bargain together to get higher rates, because they deserve it. Thank you.
But we would love to partner with you to do that. I think. we're
He
on the
knows where
same
I
side.
am. He used to sit 2 seats from me, but now he doesn't even remember my name.
Wow.
Thank you, Representative.
Come to this,
Gil.
has it?
You started it.
We have a question online from Senator Anwar.
Thank you, Madam Chair. Thank you, Senator Perillo. Congratulations and your new important role. Looking forward to working with you, and also Dr. Gerber for your testimony. Dr. Gerber, if we were trying to understand this access issue, it's almost a chicken and egg question. The access is not there because the clinicians are choosing not to come to Connecticut and make it their home because the payment system in Connecticut has some challenges. Is that a fair understanding?
No, it's an excellent point, Senator Anwar. Thank you for asking that. So because of where we're located and also because of my own background, having trained largely in New York, I hear this regularly. New York has made some recent progress in this regard, and therefore providers have said to me that they are encouraged by where New York seems to be moving in terms of their own parity legislation, and they ask me the question of, is Connecticut following suit? And nothing would make me happier than being able to say to my colleagues and also people I'm recruiting to the state that Connecticut is keeping pace with other states in enforcing parity legislation such that payers are compensated adequately.
So the status quo in the state of Connecticut is harmful and arguably existential threat to institutions dealing with mental health.
Yes, I would agree with them.
And the other question I wanted to ask you was, this is now more about the patients and individual patient. Can you speak to us that when there is a prior authorization delay, and the patients with severe mental health is not able to get their treatment in a timely fashion, what happens to that patient clinically and long term? What are the challenges associated with the status quo of the delay in care for these patients?
Yeah, that's such an important question, Dr. Anwar. I'll tell you a recent story. We had a patient whose father called the hospital and said, my daughter has had treatment in multiple facilities. It has not been successful. She continues to struggle and is actively suicidal. I don't want her to have another failed hospital stay. I want her to come to a state-of-the-art program. We happen to have such a program, but that particular program, other parts of our hospital are in network. That particular program is out of network. He said, I need to know, I can't afford to pay that. I need to know that it has been pre-authorized by the payer, and he had excellent insurance. We called the insurance company. They said, A, it's going to take us 2 weeks to get you the prior authorization, and you need to admit her first before we can get the assessment necessary in order to tell you whether she's authorized. Called the father back. He said, that's impossible. I can't commit to paying the first 2 weeks, nor do I want to start her down a treatment that I won't be able to sustain, even if I scrape the money together for the first 2 weeks, until I know. So you had this kind of crazy chicken and the egg problem where this poor young woman was not getting the care she needs. And that's just an anecdote, but these situations happen all the time. Prior authorization doesn't happen in a timely way, and often the requirements about what is needed for prior authorization exceed what's possible to do before the person comes into the hospital.
Thank you so much. This is helpful. And another perspective is that we know that mental health and physical health go hand in hand. And if mental health is not addressed, the physical health deteriorates. There's a lot of data about it. And would that be more cost effective to address the mental health management through insurance companies so that the physical health would follow and move in the right direction? Because when you leave one part, then we are actually putting a Band-Aid on the physical part. Can you speak to that with your experience and your background?
Thank you, Senator Arward. It's such an important point you're making. As physicians, we see this all the time. Roughly 3/4 of the patients we treat at Silver Hill Hospital for primary mental health and addiction issues have serious physical health problems as well. And there are enormous costs, not just to them individually and to their families through pain and suffering, but to the insurance companies and to those who are on government plans, to the taxpayer, for medical care that is not being effective and received because their mental health and their addiction is getting in the way. So when we do this accounting, and I fundamentally agree with the points being made about we need to be economical. We can't just keep spending more and more in healthcare. We have to factor in how much these individuals are costing the system in terms of their medical care. And there's good data to support that when you give adequate mental health and addiction care, you significantly lower the physical health care expenditures and obviously save lives and make people much happier and healthier.
Sure. And perhaps this is a question either you or Senator Perillo can answer. I sometimes wonder that the insurance industry looks at their performance on a quarterly basis, and sometimes you lose the bigger picture when you're looking at things from a quarterly perspective because you're trying to make ends meet in the end of the quarter. But you step outside and start to invest so that you can front load the care, and then the long-term cost would decrease. Is that a fair understanding?
I can speak to that, Senator. Gone are the days, and I've said this before, gone are the days where you go to work for IBM when you're 22 years old and you work there for 40 years and get your gold watch. And from the day you started working there to the day you retired, you had Blue Cross and Blue Shield. So back then, the insurer had a vested financial interest in ensuring your health from start to finish. Because at the end of the day, if they insured your health from start to finish, the actual expenditure on your care would long term be lower. But with the marketplace being what it is from a job perspective, with the marketplace being what it is from a premium perspective, it's not unusual for employers to shop around every year, switching their payers. So with that in mind, honestly, and I understand the motivation, but the payer's just trying to get through the policy year, because you may not be a patient the next year. You may not be a member next year, a life they have to cover. So it does, to your point, Senator, become about just making it through the quarter, making it through the year, and keeping your experience down as low as possible.
If I could add one additional fact to that, which is the accounting done by the insurance companies also doesn't include all of the costs elsewhere within the system. So for example, we at Silver Hill work very closely with the Board of Education in New Canaan, because the costs to our schools has increased dramatically over the last, particularly since COVID, in terms of the mental health they need to provide. And that's got to come from somewhere. That comes from the taxpayers. When we think more broadly nationwide about the cost of the Department of Housing, to the prison system, all of these are incurring huge costs because of the inadequacy of our mental health and addiction treatment services. So I fundamentally believe that if you account for all those costs, what we're talking about in providing adequate mental health care and addiction care ends up saving us money in the long run. And we need to do the studies with the right data to show that.
Thank you so much. I appreciate both of you and your testimony. Thank you so much. Thank you, Madam Chair.
Thank you. Representative Pavlik-Tomato.
Thank you, Madam Chair. I had a quick question because we were talking about something you said about not being able to get the reimbursement rates for individual services. You were talking as an employer, correct? Or were you talking about as a physician in comparison to other providers?
I was talking about as an employer, but also as a hospital provider, because we can't see what plans. We can only see this from the global generalized rolled up data. We can't see what is being paid by different plans to other hospital systems. So we can't compare. There's no free market. We can't tell what what we're being paid versus what other people are being paid.
And I remember you saying that, but I mean, I don't know if we've really addressed that. And I mean, I don't know if, I guess if you're a hospital and you think you negotiated a really good rate, then would you necessarily want to get that information out there, or maybe not, right? I mean,
I think you're right, but that feels unfair to me. It feels to me that what's the best interest of the people of the state is to have all that be transparent, so that the hospitals can really compete with one another in a free market.
okay. Yeah, I guess it's something to think about as far as the different different relationships, right? Because they're intertwining and
Yeah, they are.
overlapping. So, but I do understand what you're saying as far as I guess when we're really looking at the rates and all these, like you said, the now school services that have to be provided. And I have always said that there are different costs that play into what ultimately what some place has to receive as a minimum, I guess. But I have heard and I have talked to different treatment facilities. I have one in my town, and they do know. They do have the rates. Now, again, this is, I believe, Medicaid though, but still, they do know the rates that other places in other towns get. And I know New Haven gets the most, and they know their rate, and it's significantly lower.
Right. It sounds like what you're referring to, and you're right. They know certain things. So if they know from the government programs, there are these, I forget the name for it now, but these percentages that you get for being in an urban area versus another area,
Right.
but they don't know it at the level of the individual services, which, and particularly in mental health, where you're figuring out, can I afford to give this care for this kind of patient or not? And this is what's going on in the hospitals. Unfortunately, they're making the decision, you know what, it's too risky, I better not offer those services. And we've seen a decrease in the number of available psychiatric beds in our region, which sounds completely counterintuitive given how much need there is, because hospitals find it too risky to open a service when they don't know that they're going to be paid adequately.
Right. Thank you very much. Thank you.
Any other questions from the committee? Thank you both for being here.
Thank you.
You very much.
Next up, we have Katrina Kane. She's not here. Okay, we have Ann Lyons. Nori Vega. Suzanne Kostick. Dr. David Haas.
Yes, thank you very much. Senator Cabrera, Representative Wood, and distinguished members of the Insurance and Real Estate Committee. My name is Dr. David Haas, and I'm past president and current legislative chairperson for the Connecticut State Medical Society. And on behalf of physicians and physicians in training of CSMS, I want to thank you for allowing me to testify in support of SB 10. First, I want to focus on sections 5, 7, 18, and 19, which address some of the most harmful and necessary barriers that insurers place between patients and the care their physicians recommend. Section 5 is a critical reform of prior authorization, a process that was originally intended for rare, high-cost care, but has ballooned into a routine barrier for even basic treatments, from medications to imaging to endoscopic procedures to common surgeries. These delays jeopardize patient health and consume hours upon hours of physician time and staff time each week. Section 5 makes a common sense change, placing a rebuttable presumption that the care recommended by the patient's physician is medically necessary. Insurers can still review, but the burden shifts to them to prove the care is unnecessary, instead of forcing physicians and patients to repeatedly justify medically appropriate and effective treatments. This section also addresses the growing misuse of AI in prior authorization. AI has promise in healthcare, but when insurers use algorithms to automatically deny care without meaningful human review, patient safety is at risk. This is not hypothetical, as we've already seen lawsuits against insurers for using flawed AI to wrongly deny care. Section 5 ensures that AI cannot replace a clinical peer review when patient care decisions need to be made. Section 7 addresses step therapy. This is the harmful fail-first practice that forces patients to try and fail insurer-preferred medications before they can access the treatment their physician recommends from the start. For patients with chronic or complex conditions, this is not just frustrating, it can be dangerous. Senate Bill 10 appropriately limits step therapy, reducing the time patients are forced to endure ineffective treatments. Sections 18 and 19 respond to an outrageous attempt by one insurer to impose arbitrary time limits on anesthesia reimbursement. This would have forced anesthesiologists to go unpaid and run if a procedure ran longer than insurer's preset limit, regardless of the patient's medical needs. This policy, thankfully, was withdrawn after national outrage, but without clear statutory protection, there's nothing stopping insurers from trying this again. These sections ensure anesthesia decisions remain where they belong with physicians, not insurers. And finally, CSMS supports sections 1 through 4, providing long overdue tools to enforce mental health parity laws that insurers have ignored for years. For these reasons, CSMS urges your strong support for Senate Bill 10. This bill protects patients, restores clinical decision-making for physicians, and ensures insurers play by the rules. Thank you for your consideration.
Thank you, Dr. Haas. Are there any questions from the committee? Representative Pavlik Damato.
Hi, thank you for your testimony. I do appreciate it, and I think it is helpful. I was wondering your position on Section 10. It eliminates stop loss. Any insurance company to deliver, issue, or renew have any type of stop loss insurance. Do you have any? I don't know if you mentioned that in your testimony. I don't think so, and what your thoughts are.
Yeah, I didn't mention that in my testimony. I'm going to defer. We're going to have later testimony and we can discuss that. The president of the State Medical Society, Khurram Guman, will be commenting. I think he's much later. So I'm going to defer to him to comment on that.
Okay, yeah, and if eventually, if you could take a look, from a practitioner's standpoint, I guess I'm weighing whether some of the provisions that you like in this, whether Section 10 would have a kind of outweigh or have a negative effect. You know, a bill maybe that has great things, but if there's something in there that is, I think, as catastrophic as that section, if that would kind of undermine the rest of the bill. But
I understand what you're asking about. I'm just going to defer to others that may comment on that.
Thank you.
Thank you, Representative. Any other questions from the committee? Seeing none, thank you, Dr. Haas, for testifying today.
Thank you.
Up next, we have Mr. Paul Bryant. Mr. Yanzo.
Yes, thank you. Good morning, Senator Cabrera, Representative Wood, and members of the Insurance and Real Estate Committee. My name is Paul Bryant, and I'm a physician practicing psychiatry at Yale, president of the Connecticut Psychiatric Society, which represents over 500 psychiatrists working in our state, as well as a resident of Woodbridge. I want to voice my strong support for SB 10, specifically the parts addressing mental health parity. While you'll undoubtedly hear from others who will highlight data and studies such as the Millman Report showing that mental health parity continues to remain a significant problem in our state, the truth is that you don't have to work in mental health field for long before this becomes glaringly clear. Not only are there more barriers to put in place to receive reimbursement and get patients the types of treatment they need, but it can feel nearly impossible for patients to even get in the door. Speaking from personal experience, I witnessed a family member who was in desperate need of treatment to be told that the only way they could access care was to start working their way through a list of potential providers and hope that one of them might be accepting patients. After making dozens of calls, nearly every time having to explain the painful details of their current health crisis to a voicemail, they received exactly one call back. Unfortunately, this situation is not unique, but an all too common experience of patients trying to find a provider covered by their healthcare insurance. The truth is that through work done by the Connecticut Psychiatric Society and the Connecticut Council of Child and Adolescent Psychiatry, an organization I'm also part of, we've discovered that many of the names on providers included on these lists that are provided by insurance carriers do not even have an outpatient practice in which they could see individuals seeking care. So while I've heard comments today that this issue is more of a workforce issue rather than a problem with mental health parity, I have to respectfully disagree. The additional barriers insurance carriers place on mental health providers leads to many of them to either not be part of panels or to only accept a certain number of patients from these groups. So while lower reimbursement of mental health care is an issue, the additional administrative burdens placed on mental health providers is at least as big, if not bigger. And this is what I think SB 10 could help with. SB 10 would make it harder for certain carriers to automatically deny claims without meaningful consideration, which should be a bare minimum, given that these decisions are going against those of physicians and providers who are actively treating patients. Steps like this will help decrease the additional burdens providers face in working with carriers. Thus, I believe this bill would assist in meaningfully improving the overall well-being for the people of Connecticut, and I'm appreciative of your committee for considering it. Thank you.
Thank you, Paul. Appreciate you coming today and testifying. Are there any questions from the committee? I don't see any online. Thank you very much for coming today.
Thank you.
Up next, we have Mr. Keith Passwater. Sue Halpin. Miss Sue Halpin. Sorry about that, Sue. I got the wrong name. Oh, okay. No worries. Well, welcome. Floor is yours.
Thank you. Thank you very much. Chairman Cabrera, Representative Pavlak-Tomato, Representative Ducci, and Representative Berry. I'm Susan Halpin, and I'm here today on behalf of the Connecticut Association of Health Plans to testify in opposition to Senate Bill 10. Senate Bill 10 has a number of sections. I'm going to run through them as quickly as I can. Sections 1 through 4 are the mental health parity provisions. I just want to say that carriers have been proud to be at the table on a lot of the mental health legislation that has passed over the last several years. Carriers have taken on the challenge and have increased access to mental health digital apps. They've increased access to telehealth services, but that's not to say that we don't recognize that the system is imperfect. And that it's under-resourced and that there's a national workforce shortage, as has already been discussed. We have a couple of particular concerns. One is the enforcement and accountability. We believe DOI already has the authority to enforce the law, and they do. We also have a problem with Section 2. It removes the language that blinds the identity of carriers. You saw already today a lot of confusion about what mental health parity is and what mental health parity isn't. We're very concerned that if you put names out there, it will feed into some of the very violent tension that we've seen over the last year. And we're concerned about safety and security of folks in the insurance industry when you put their names out there if it appears that they violated the act. So we hope you'll reconsider that. I just want to end that section on a note with the statement that the commissioner made in the last mental health parity report. He said, "It should be noted that insurers have maintained a high degree of cooperativeness and willingness with the department as we work to improve and advance effectiveness of the reporting." AI, the artificial intelligence provisions, I guess I just want to say that decisions remain the domain of humans, and the term used oftentimes is human in the loop. There are other committees that are working on these initiatives, and we would ask that it be dealt with in a comprehensive manner and not as a one-off in Senate Bill 10. One of our biggest concerns is, as you've heard us testify several years in a row when this legislation is considered, is establishing the rebuttable presumption for medical necessity and changing the burden of proof, and also prohibiting step therapy. These are extensively broad mandates. And we actually had a actuary take a look at these provisions last year when they were considered. He's going to testify a little bit later today. But I want to say that his findings suggested that if you're looking at the estimated impact to individuals and small groups, it was $38 million in year one, with a $363 million impact over 10 years.
Your 3 minutes are up.
Sure. Sorry, I'm only on section 8, whatever. Section 9, site neutral billing. We oppose the way that it is currently drafted. We think it will increase costs. And Section 10, stop loss requirements, I'm happy to expand upon if anyone wants to ask me a question. And same thing with the affordability of rate setting. With that, I'll conclude my remarks, and thank you for the opportunity to come before you.
Thank you, Susan. We appreciate it so much. Any questions for Representative Pablo D'Amato.
Thank you. So yes, could you explain, so section 10, what would be your testimony as far as the impact of section 10? And if you could explain probably in lay terms, what is that trying to do?
Sure. And I think you've got testimony from a number of brokers and other employers, written testimony that's been submitted that can probably describe it far better than I do. But it seeks to regulate the self-insured market, as I understand it, by restricting stop-loss policies that can be sold to certain employers that don't, A, have all of the ACA mandates and the state mandates, and that have attachment points that are significantly higher, more than double the attachment points that are currently required by the Department of Insurance today. So what does that do? It makes employers that are in the the self-insured market, they're going to have to assume more risk before they can have a stop-loss policy kick in. And they're going to have to cover that wide range of mandates that increase overall costs. So, you know, the thing that you see even in this bill is the industry's getting whipsawed, right? They're getting whipsawed between those that want more affordable coverage, which requires lower healthcare costs, which requires cost management, which requires investments in, you know, primary care, et cetera. And then on the flip side of that, there are all kinds of mandates that require additional services, additional treatments, higher reimbursement for providers. So, you know, there's really just this constant push-pull that the health insurers are trying to manage in order to provide quality healthcare coverage to consumers.
Okay, and then section 11.
Mhm.
Oh wait, let me go back. You had mentioned about, did you say advantage points, attachment points?
Yes.
Sorry, attachment points. Can you explain what that is exactly?
I will do my best. I've learned a lot in the last couple of days. An attachment point is when the stop loss policy kicks in. So if I have a group of, you know, 30, and Susan Halpin's claims, personal claims, individuals claims hit 20,000, right? Then the stop loss policy kicks in and covers the costs above that amount. So it's used a lot by employers that are growing, right? They want to offer good healthcare benefits in order to attract you know, employees, but they also want to manage their costs in a little different way, and they can tailor their benefits more to their actual employee base because they're not bound by all of the mandates that are, you know, in the current fully insured market.
So then what would be the effect then if this were to go into place as far as those employers that are self-insured?
Sure. And again, I think there are other people that can probably speak better to this than I can, but I think a couple of things. If you're seeking self-insured coverage, first of all, immediately you're not subject to all the assessments that are imposed by the state of Connecticut. You're not subject to the premium tax. So immediately you're getting a reduction in your healthcare costs when you move to the self-insured market. If you can't absorb that extra risk, because what it does is it moves the attachment point to $50,000. So in my example, now Susan Halpin, you know, where the stop loss used to kick in if I hit claims at 20,000, now it's only going to kick in if I hit claims at 50,000. So what's an employer going to do? They're either going to pay the extra costs to absorb that. They could go self-insured without a stop loss policy, which is a very risky, you know, situation for them to get into. And if they can't afford that policy and they can't afford a fully insured policy, then they'll go without.
Would they, or to the Access Health, would that be another option as well?
There are options at Access Health. They're rolling them out for small employers to go that route. But I don't think it's mature enough to kind of handle what would be the exodus of this market and what would be the impact. I think this is a very complex, complicated process. I can imagine a situation where this bill would pass and then you would hear the uproar from the community because they weren't, you know, it was hard to follow along with as it made its way through the legislature, but the impact would be very real and very immediate.
And then what would be the effect on the employer? I mean, would they get their plan be dropped or would they be assessed those? What essentially would happen and be imposed on an employer or and possibly, I mean, as an employer? I mean, I'm not paying for that out of pocket, right? I have to pass that on.
Yeah, and you know, you might see a change in benefit structures as a result. You might see higher deductibles, you might see more limited networks, you might see different cost sharing because you're asking by virtue of this legislation for the employer to absorb more risk. One thing I didn't mention that I think is a really, really important element of this is that there's a real question whether this violates ERISA. And, you know, for union plans or, you know, other plans that are out there, I think everybody is taking a look at this right now. And it may be one of those things that would end up at court. I can't say, but I think that we read it as really, really encroaching on the protections of ERISA that self-insured plans have. It's a backdoor approach to regulating ERISA plans.
And can you talk about Section 11 as well?
Sure. Section 11, we've seen this bill. The governor has a bill as well. You know, our concern about this is it adds a factor into a mathematical actuarial process that is subjective in nature. What's affordable to one person isn't affordable to another person. And it's very difficult to quantify. And what we believe will happen is it will simply, you know, slash rates, which passes additional risk on to carriers who have to remain solvent in order to deliver on the ultimate consumer protection, which is to cover the claims that are incurred. The department has a mandate that's in accordance with the Actuarial Standards Board. They look at rates on an actuarial basis to determine that they're not excessive, inadequate, because somebody could come in and lowball rates, right, to get additional members, or are unfairly discriminatory. So those are the standards by which the department looks at the small group and individual market and looks at the rates that the carriers submit and decides whether or not to keep them or not keep them. If I could go back 1 second to the other, to the stop loss piece, I also just want to point out there's a provision in the bill that also requires the commissioner to biannually reassess attachment points in accordance with CPI. That creates an incredible amount of volatility and instability in the market that really stifles, you know, the whole system and would be really detrimental, I think, to having those products delivered here.
Thank you very much.
Thank you, Representative. Any other question? Representative Nuccio.
Thank you, Mr. Chair. I was wondering if you could expound a little bit on the site neutral portion of this. My concern is the way that the language is written right now. There's nothing to say here that a hospital who owns outpatient facilities couldn't say that, well, our hospital rate is the better rate, so we're going to take the higher rate. Like, I don't see how this is necessarily going to incent them to pick the lower rate.
Right.
So I was wondering if you could expound a little bit on the site neutral portion of this.
Sure, and the industry has supported similar proposals. It's really about the language. They've supported it in other states, but the way that we read the language here is, you know, all boats rise, so to speak. So my husband has, I'm sharing PHI, but hemochromatosis. He has to get bled. That's the treatment. So he goes in and he goes into a hospital-based setting and he pays a certain rate. He can look online, by the way, in your cost estimator you have on your plans, plan websites, and look for a cheaper place to get that service. under this legislation, it basically says that whether he gets it in the hospital or he gets it in an outpatient clinic, it's the same cost. So what's the incentive? What's the intent behind the legislation is to lower the cost if I decide to go to an outpatient clinic, right? But we don't see that under this language.
So I think that's the piece that I think is missing too. You know, I've been here, this is my 5th year, and we've always talked about the fact that, you know, it's less expensive to go to a outpatient facility
Mhm.
to get, whether it's minor surgeries, procedures and stuff like that. So trying to drive people towards the lower cost options. And the way that I read this as written right now means I'm going to pay the same amount if I go to an outpatient facility as I'm going to pay if I go to Hartford Hospital, right? And I think this needs to be fine tuned because we should be looking for ways to lower the cost of healthcare and not make it more expensive. I fear the way that it's written right now, it's going to be, you know, let's all come up to the highest point. And if
Right.
Meskers was here, he would probably be arguing that same point. So it's a bipartisan argument. And then in regard to the stop loss section
Mhm.
of this, I think you kind of touched on it, but this is where I think people just need more education. What happens to the market if people just decide to stop having stop loss policies on an ASO account or a self-funded account, or even on, you know, a regular insured account? What happens if stop loss goes away?
Again, I'm learning this issue. It's been quite fast, but I think it, you know, employers are going to choose to either go without coverage, to accept a risk that they shouldn't be accepting, right? You know, you say, okay, we've 5 or 10 or 20 healthy people, right? We're a relatively young group of young people. You know, we're not looking to get a lot, you know, take on a lot of risk. We think we're gonna do okay. Our claims last year were, you know, under 1 million. So we're gonna go self-insured, but the stop loss, we can't get the stop loss we want because we're not covering all those benefits that are required. And then all of a sudden somebody has, you know, twins that are in the NICU for 3 months. That blows through it. And what does that employer do at that point? Because the employer pays the claims, right? Self-insured, you are paying the claims. You may hire an administrator to pay those claims from your bank account, but you're taking the risk as the employer, as opposed to in fully insured. That risk, which is why your prices might be somewhat higher, that risk is borne by the health insurer. So, you know, I think you'll see some real problems as if people choose to go without stop loss. You know, I don't know a lot about the stop loss carriers in the marketplace here you know, in Connecticut, whether passage of legislation like this would you know, change whether or not they offer policies here or not. I mean, that's something you would have to ask them. But, you know, I think it would have an incredible chilling effect on the market and healthcare coverage, you know, as you know it today. And, you know, what the alternative is to that is a breakdown. I think it's even more of a breakdown in the system.
Yeah, I would fear that, you know, stop loss is, I don't understand the attack on stop loss, I guess is what I'm finding here, is because, you know, the attachment points, in a sense, the lower the attachment point is what is really beneficial to the employer, right? Because these are employer-based plans. They're not
Right.
insurance plans.
Right.
They're employee benefit plans.
Right.
And a lower attachment means if I have someone who has cancer, I have someone who gets into a tragic car accident,
Right.
you know, you're looking at big claim costs here. When they hit that ISL or the individual stop loss limit,
Mhm.
it goes into the fully insured, which is a cost saving mechanism for the employer who is offering the benefit. Without stop loss, that means now my employees have to pay the full price of that treatment, which means rate increases across the board. I'm not quite sure exactly what this portion of the bill is trying to do, other than perhaps, I guess I really don't understand it, because you know, the stop loss product is a fully insured product. It pays premium tax, everything else. It is one of the only tools that an employer has if they want to offer an employee benefit plan to kind of contain those costs. So this is definitely, other than the part where it says, making the stop loss plans be applicable to the state mandates. My question around that too, and I don't know if you have any interpretation on this, is, a stop loss plan is an auxiliary plan, right? It's not the main employee benefit plan. So ERISA protects the employee benefit plan. Are we saying that if a person hits the stop loss threshold, then that portion of the plan is attributable? Like they would have to go back and cover state mandates, or are they trying to actually legislate ERISA, which is outside of the state's control?
I think our initial read is the latter, that they're trying to regulate ERISA. And to bring it full circle, you're talking about requiring a health benefit plan to cover all state mandates that, is in the self-insured market. The other sections of the bill that we talked about, the burden of proof, the medical necessity provisions, the prohibition on step therapy. If this bill passes in its entirety, those will all now apply to that health benefit plan that's now subject. We can't buy stop loss unless it covers all the benefits, so everything is intertwined and connected, but the costs associated with this bill are extraordinary.
Well, I think it's pretty telling that we have very few companies that are even entering our fully insured market in the state of Connecticut. We talk about the overly regulatory environment of electricity, and I would add, overly regulatory environment for the fully insured product. There's a reason that there are pretty much no carriers willing to participate in the state of Connecticut. And I think this would just compound it. And I'd be very interested to see how the courts read the overreach into ERISA plans from the Department of Labor perspective. But thank you for answering my questions.
Thank you.
Thank you, Representative Nuccio. Representative Barry.
Thank you, Mr. Chair. Thank you, Susan, for being here.
Thank you.
You did a great job addressing some of the concerns. I believe you got through like 9 or 10 sections. There are 18 or 19 sections of this bill. Is there another section? I just want to give you an opportunity if you wanted to talk about another section that you didn't get to.
Well, I appreciate that, and thank you. I think just if I could hit on, a couple of things in the burden of proof, step therapy, provisions. We've been chipping away at a lot of that legislation over the years. And, just last year made a number of changes to step therapy. We went from 60 to 30 days. In 2023, we did what we call one and done, which is you get a prior authorization for life-threatening conditions or chronic conditions, and that prior auth carries with you. You can't be subject to a second prior auth. So, and then we look at what the rate increases have been, and what is the correlation between some of the things we've passed and the rate increases that everybody is experiencing, right? And those have barely gone into effect, and now we're looking at taking it another step. Now we're going to go down to 20 days. And, there are other proposals where prior authorization and step therapy are being looked at, in the Medicaid plan because the costs are going so high. And, just to go back a little bit to the mental health parity, and, we see a lot of fraud, waste, and abuse and providers billing for services. And, prior auth and utilization review is one of the tools that carriers use to make sure their customers, their employers are protected from those. They're very minor, likely, but they can be big numbers, as you've seen in the press. So thank you for the opportunity to add additional comment.
Thank you, Representative. Any other questions from the committee? No. Thank you very much, Susan.
Thank you.
Appreciate it. Up next, we have Lauren Finke. Am I saying that right? Lauren Fink?
You are. That's so
Hi.
rare.
Hi.
I appreciate it. Hi, good morning. My name is Lauren Finke. I'm the Senior Director of Policy at the Kennedy Forum, founded by former Congressman Patrick Kennedy, co-author of the Federal Parity Act. We have sponsored and helped implement comprehensive mental health parity bills in states across the country. I thank you for the opportunity to testify today in strong support of SB 10, which will undoubtedly strengthen enforcement of Connecticut's mental health and parity laws. Connecticut has strong goals like the bipartisan 2019 parity law that was already mentioned today to make health insurance work better for its residents. But without added transparency and enforcement, it remains an empty and costly promise. The reality is that insurers continue to break the rules, denying necessary care and relying on weakened enforcement to continue illegal practices that put plan bottom lines over the law. A recent Office of Health Strategy report found 4 of the 7 major insurers in Connecticut exhibit warning signs of parity noncompliance in their reporting. On the heels of federal parity rules allowing for greater transparency in reporting, SB 10 returns clarity and teeth to the state's existing laws. SB 10 adds what the Kennedy Forum considers gold standards for parity reporting and transparency, aligning the state with federal parity rules. And I'll list a few things, but happy to talk about them if there are questions. The first is annual streamlined reporting from health plans to regulators on parity compliance, which is in accordance with the Consolidated Appropriations Act of 2021 and was codified in the federal tri-agency parity rules in 2024. It requires generally accepted standards of care to be aligned with clinical practice and requires medical necessity determinations to follow these same clinical standards. For-profit criteria often leads to unnecessary denials based on any number of non-clinical judgments. And their proprietary nature makes it impossible for regulators to assess trends in health insurance utilization review and parity compliance and to ascertain the validity of individual cases of patients who seek an appeal for a denial. SB 10 ensures criteria is transparent, fairly applied, easily reportable, ensuring plans utilization review decisions are aligned with the clinical standards of care, joining the ranks of Georgia, Illinois, New Mexico, and California who have already put in place these standards. SB 10 also clarifies that utilization review must be based on the same medical necessity criteria, and that those conducting utilization reviews specialize in the specialty of care that they are reviewing. This process, known as peer-to-peer review, is important for ensuring fair utilization review processes. SB 10 also allows regulators to work with plans on strategies to mitigate found compliance issues and allows the imposition of civil penalties when plans are unresponsive, which we view as an important lever for ensuring plans are indeed willing to proactively work with regulators on found compliance issues. And I know that reimbursement rates and some things around that were discussed today, and I'd happy to talk more about that and how we view that as squarely in the original intent of the federal parity law. It was reassessed in 2013 and 2024 regulations and was also talked about in numerous reports from EPSA DOL, including one under the Trump administration in 2019, which talked about reimbursement rates. So happy to chat more about that in comments. Without all of these streamlined efforts that I just talked about, consumers will continue to face barriers to needed care, which we believe will lead to higher levels of more costly care and raising the cost of health insurance for all, and particularly in the Medicaid side as well. Ensuring transparent and equitable behavioral health access is a top priority, and for these reasons, we support SB 10. Thank you for your time and consideration.
Thank you very much for your testimony today. Are there any questions? Representative Wood.
Hi, Lauren. Thank you for joining us today. In your testimony, you have said that the insurers continue to break the rules, denying necessary care and relying on the weakened enforcement to continue illegal practices. Can you tell us what rule breaking and illegal practices that you're seeing?
Sure. So I will say that I'm relying on accounts from advocates and folks in the state of Connecticut. So these are based on accounts. I haven't seen the plan documents or things themselves. What we often will see is around, I talked a lot about the transparency in NQTL analyses and different things on reporting. When we see denying necessary care, a lot of this is around the medical necessity criteria that is being used. So I mentioned the outlawed criteria, that criteria that was outlawed in a number of other states, which is the proprietary criteria, which is really impossible to open up because it's proprietary. So regulators themselves can't see or look into the clinical standards that are being used. This is famously kind of talked about in the Witt versus United Behavioral Health decision, where it was found that the medical necessity criteria that was being used was not based on clinical standards of care. Currently, that is actually legal in many states. And so the provisions around tying medical necessity standards to the generally accepted standards of care is sort of the gold standard for us, and we believe is really what was reinforced in the 2024 federal parity rules that were released, talked about and ensuring that those things are aligned with generally accepted standards of care. So high denial rates for mental health and substance use disorder care, or even if it's not a denial, but a lowering of what is covered. And so sometimes it's an example, clinical examples that you often will see will be high denial rates for inpatient substance use disorder treatments, eating disorder care, or shortening of those standards and things too, so that people kind of are forced in a loop. So those are just some examples of the clinical issues that can often happen. And I will say in our work in other states, what we have seen is that when these things are appealed, they are universal, or they are overturned in favor of the enrollee at a very, very high rate when you're using those clinical standards of care. And so I think that's a really important part of the bill to highlight, is that this would bring Connecticut into those standards.
So I was wondering if you can just answer the question more related to Connecticut. You referenced the federal law in your answer. You also referenced other states. Just tell us what's going on that you are referencing as illegal practices here in Connecticut.
I think what I was referencing on that is the weakened enforcement around these things. So a lot around, the transparency of reporting and what that really looks like for being able to understand where there are more illegal practices happening or where there are issues that are possibly coming up. It's very hard to do that without more of the reporting processes that have been found when used in other states to find a lot of these things. So I guess I should re-clarify. It would give the regulator more ability to ask the questions, to get specific answers from the plans on these things. The Office of Health Strategy report findings of those warning signs, I think, are really good, really good starting areas to think about where we're looking for better compliance. And I would also defer to folks on the call in this hearing who are speaking on the clinical issues that they are seeing. I'm not a clinician in the state. So I would refer to the Office of Health Strategy report, and I would also refer to some of the issues that we're seeing, around the non-transparent practices on the reporting side, which I can speak to.
Okay, because we did ask the Department of Insurance these questions, and we didn't get a response. Well, we did get an answer that there wasn't any illegal practices going on, but when you write something like that, it's really important for us to understand, what you're referencing there when you're saying there's illegal practices that are continuing to go on. I still haven't gotten an answer, but you're welcome to send the committee an email, if you're able to find some of those things, so we have better transparency ourselves as we hear this throughout the hearing. No further questions from me. Thank you.
Thank you, Representative Wood. Any other questions from the committee? Seeing them online. Thank you very much, Lauren, for coming today. Up next is Timothy Bellevue. Hope I'm saying that last name right.
Hi, good afternoon. Thank you, chairs and members of the committee, for the opportunity to testify in support of SB 10. My name is Dr. Tim Bellevue. I'm a resident of Stratford. My perspective on the implications of lack of mental health parity comes from my practice as a neuropsychologist for 30 years, the most recent of which has been at Yale, where I'm an associate professor, and my outpatient work is at the Yale Neurology Clinic in Milford. I'd like to bring attention to the importance of considering physical and mental health as very closely interrelated. I work with a wide range of specialists in our efforts to rehabilitate persons who have impairments due to brain injury or other neurological conditions. In our work, a team approach is needed to address a broad range of possible consequences of brain injury or neurological disease, and it's critical for our patients to have access to all of the specialists who are needed to provide rehabilitation as they rebuild their lives. For example, Cognitive assessments are needed to guide rehabilitation planning, and counseling is often a key component of optimal recovery. Another example is that depression is common after stroke. Nearly 1 in 3 people after a stroke have post-stroke depression, and it's associated with worse functional outcomes, increased disability, and increased mortality risk. Another example is for another group of patients, people with mild cognitive impairment or early dementia. There are estimates of concurrent anxiety disorders ranging from 5 to 30%. Another group of patients who've had a concussion, studies show that over 50% experience anxiety or depression symptoms during their course of recovery. So in the process of rehabilitation, we need to treat the whole person, but inequities in reimbursement to psychologists and other behavioral health providers limit the opportunities for many patients to access necessary behavioral health care evaluation and treatment, the absence of which is associated with disparities in their functional outcomes. In short, among individuals recovering from brain injury or who have other neurological conditions, lack of access to effective behavioral health care is ultimately associated with higher long-term health care costs and is often associated with a lower likelihood of successful return to work. Although the 2019 parity law was a step forward, the lack of parity enforcement leaves patients and families on long wait lists for a limited pool of in-network providers, or be burdened by higher costs for out-of-network care, or to have no access to behavioral health care. Passing SB 10 would move mental health parity law from an aspirational goal to a law with consequences for noncompliance. I strongly urge the committee to pass SB 10 to help individuals in Connecticut to access evaluation and treatment that they need, regardless of whether their need is for physical or mental health care. Thank you for your time and for your consideration of my testimony in support of the bill.
Thank you very much for testifying today. Are there any questions from the committee? Online is seeing none. Thank you very much, sir. Have a good day. Up next, we have Mr. James Wiskowski. Did I say that right?
Yes, sir, you did.
All right, got one. Welcome. Floor is yours.
How you guys doing? I was gonna say good morning, but well, good afternoon. I just right there. I am James Rakowski. I'm the Hartford Police Union President, and I am here to testify in favor of Bill 7069 and Act concerning behavioral health assessments of police officers. I'm here to address a critical legislative failure that had unintended consequences and for the police officers of the state. What began as a legislative directive was handed down to post, and then it was handed down to the cities, and then it was handed down to the unions for implementation. With this, there were, without considerations of the magnitude of what this bill could do. And what we ran into was an egregious violation that stems from medical record access. Through the county exchange or through Epic or another healthcare system network, officers' private medical records were accessed, including reproductive medical records. This is a direct violation of policy and privacy for the officers and for their families. Furthermore, officers are subjected to behavioral health assessments under the Public Act. This law was very clear. These assessments were meant to be confidential wellness checks, not clinical evaluations. Yet officers were placed on fitness for duty based on these clinical findings with information that should never have been disclosed further than from the assessment. Officers were billed for these assessments that should have never happened. Yet, and they were billed for a process. They had no choice, and these behavioral health assessments were mandatory or still are mandatory. This is not a union issue. This is a fundamental violation of medical privacy, trust, and the very laws that are designed to protect all of us. If these violations are allowed to continue, they set a very dangerous precedent for every profession where mandated health checks and assessments do exist. We need immediate legislative action to reform the oversight and implementation of the process to ensure that directives are not blindly handed down without local input. To ensure strict protection for medical privacy so that officers' records cannot be accessed. No right to disclose confidential medical information, including the statements made by the officer to the clinical psychiatrist or psychotherapist, absent of the exceptions made in CGS 52-146 or their consent.
Your 3 minutes are up. If you could please summarize.
Ensure the clinician who does the behavioral health assessment is required to explain to the officers their rights of privacy, disclosure, duty to intervene prior to the beginning of the assessment, and mandate financial responsibility for required assessments so that officers are not personally burdened with the cost of this compliance. Appreciate your time and any questions you might have.
Thank you. Thank you very much for testifying today. Any questions, Representative Wood?
Thank you for being here today. Did we do a good enough job? Did you look at the language? Are you comfortable that we are protecting, the officers going forward and making sure that that data is private, or do you have any suggestions for improvement?
I am concerned with the networks that we've all been dumped into through legislation and the protocols of those. So when this was legislated and put into post and then put to the cities, and then the cities had to get healthcare providers, and then the cities were concerned about it, clearly because it's law, to have something done. And if you go from municipality to town, they're all different. So what framework do we have to make sure that someone who doesn't know what questions can and can't be asked in these assessments are actually not being asked, or their medical records aren't being accessed, because there is no clear framework of what's going to happen if it does. The checks and balances system in this is just not there yet. I do like the language, but I'm still concerned that there's a loophole there, that what happens when we don't know? Like, I don't know what can and can't be said in that. It has to be vetted a little bit better.
Yeah, we ideally wanted to have mental health providers that specialized in law enforcement, but we couldn't find, a group of that. So we changed the language to say a provider that the law enforcement officer would choose. So someone that they're comfortable with. But we can always, make improvements to that. It also says that there's written right into here that the medical records, will not be shared, and would not affect, or it says in here, it would not result in an evaluation for fitness of duty. So we tried to take the worst case scenario stories that were shared with us and make sure that's protected, but there's always room for improvement. So I would just ask if you and others could share this with your networks and let us know if we need to make additional changes that you're satisfied with. That would be really helpful. And for those that weren't aware of some of the stories that happened, very personal information was shared. I think it was faxed over in some cases to the police department's fax machine and shared with many, many people who should not have seen that. I mean, violated HIPAA, above and beyond. So we want to make sure this language works for you, because we do want to make sure that you're able to get your mental health assessments, your behavioral health assessments in privacy. And it's not something that you have to worry about the rest of the department, being witness to that.
I agree with you. And maybe the word assessment, and I'm not looking to change verbiage, but it is more of a screening to make sure that these police officers, myself included, get the help that we need. And I think it's important for me, or for any officer, and there's plenty of clinical studies showing that if say I was a minority and I'm a female, that who am I more comfortable talking to? That's very important. So if we're looking to make sure that the men and women that are serving have access appropriately to the people they're comfortable talking to, or what not even if my therapist, say I am going to therapy on a regular basis, why can't my therapist sit there and go, yeah, I'll do the behavioral health assessment for James? Not a problem at all. And I think that's an important part to keep in there, that let me pick, or if not pick, maybe the cities and the unions and healthcare provider come down and say, select who we're going to actually have there. So there's a broader selection of people that we can go through. Like when we have our fitness for duties within a department, the union and the city get together and we select those psychologists and therapists together going, okay, we're both comfortable with this going forward.
Yeah, that makes sense. We're also happy to add, an informational, kind of sheet on what to expect in behavioral health assessment, if that's something that you'd feel more comfortable with. So open to improvement here, but thank you for sharing a story. I'm sorry that the implementation of this had such negative effects, and we're here to fix those problems. So thank you for sharing.
Greatly, greatly appreciate your time.
Thank you, Representative Wood. Representative Barry.
Thank you, Mr. Chair. Thank you, Sergeant Rutkowski, for being here. And thank you for bringing this bringing this issue to our attention. Can you just talk a little bit about the process? Who chose the provider for these assessments for the city of Hartford?
I don't know. I don't know what provider. I believe it was within our network. So the city defaulted to our healthcare network to push this forward.
So you were told what provider to go to?
Yes.
Okay. And can you just elaborate a little bit more? You said that in certain circumstances, the officer was required to pay.
Yes. So if you think of this, that the billing system, the city is required to pay for this bill. Municipalities and towns are not really, or sometimes behind. And when you're clicking through the assessment paperwork in the beginning, you agree to pay for all bills. So if the city doesn't pay the bill, by default, what you had to click because you were mandated to be in the health assessment now generates the bill to you. So if the city doesn't pay, say there's some sort of clerical error somewhere. Well, if that bill doesn't get paid by the city, you've already agreed to pay through it on your own accord. And we've had that pop up numerous times.
Okay.
Where it's been in collections.
Interesting. Can you explain why it's important to keep these assessments or screenings, like you said, separate from fitness for duty evaluations?
The fitness for duty for us is if we are deemed not fit for duty, there is immediate separation paperwork. And what I mean by separation is they move to terminate you based on the fitness for duty evaluation. And if you're looking to get people help, say I have PTSD or say I have an ADA and I'm currently working through it and I go to this assessment and the evaluator looks at me and goes, oh, well, you clearly have some issues, and then wants to notify my provider. Well, that's private healthcare information that they shouldn't have access to. So if there are in one of those networks where my information is being divulged, they'll know that. And if I'm okay in that assessment because I've sought help, well, now I have the option of I don't have the option of that information being forwarded to my employer. And then my employer, again, Representative Wood, where you said it gets sent all over the place. That's not fair. So that fitness for duty is for us, our livelihood. And if I'm trying to be the officer that I need to be for the community, and I'm trying to get that help for myself and my family, why should I be penalized for it? Because I don't think that was the nature of this bill. Like I agree with the health assessment. I think it's important for us to all have that check.
Thank you. And thank you again for being here and for sharing the story. And thank you for all that you do for the city of Hartford. And I wish you well. Thank you.
Appreciate it. Thank you.
Thank you, Representative. Any other questions from the committee? No. Todd, thank you very much for coming today and for sharing your story. We appreciate it very much.
Appreciate your time. Thank you all.
Thanks. Up next is Kathleen Brown. I think is online. Nope. Okay, moving on to Tracy Hubert. No, she's not here either. Okay. Keith Passwater, is he coming? I see it. Hey, how are you?
I'm well, thank you, Mr. Chairman and members of the committee. My name is Keith Passwater. I'm a fellow of the Society of Actuaries and a member of the American Academy of Actuaries, where I serve in the capacity of chair of the General Committee of the Actuarial Standards Board. And I'm honored to share my comments with you today on behalf of the Connecticut Association of Health Plans regarding Senate 10. My comments will be in relation to utilization review, burden of proof, step therapy, affordability as a rate requirement, and changes to stop loss requirements. Section 5 includes a requirement that for utilization review, there shall be a rebuttal presumption shifting the burden of proof for medical necessity to the utilization review company from the healthcare professional providing the service subject to review. In our estimates, this change will result in higher overall employer and individual healthcare cost in Connecticut of $75 to $100 million each year. In regards to step therapy, as committee members are, I'm sure, aware, the intent of step therapy is to ensure patients' conditions are treated efficiently and effectively. Senate Bill 10 creates very significant restrictions on the applicability of step therapies. The step therapy exclusions in Senate Bill 10 will increase benefit plan pharmacy cost $15 to $20 million per year in total across individual and fully insured group business. I'll also comment on the affordability as a rate requirement. Section 16 includes a requirement that filed rates from the actuary must be affordable. And whether the actuary believes those costs are affordable is not actually a permissible factor in the work of the actuary certifying rates, according to the actual standards of practice promulgated by the American Academy of Actuaries. My concern is not with affordability in that focus in the terms of my comments. Concern is that Senate Bill 10, Section 16 would require in some circumstances the commissioner to reject rates prepared in conformity with the standards of the American Academy of Actuaries. In practice, such an action will imply that the actuary must resubmit affordable rates, which then do not comply with the American Academy of Actuaries standards. That would force the actuary to do one of the following: submit rates that are either insufficient to cover costs, ignore the commissioner's guidance, which is clearly a waste of energy and everyone's time, or submit no rates at all, effectively withdrawing the insurer from that product market and thereby reducing choices. Finally, I'll comment on the changes to stop loss requirements. Approximately 75% of Connecticut groups who offer employee health benefits self-insure those benefits, as you may well know. As a result of self-funding, these employer plans are exempt from state health mandates, which have added significant cost to fully insured plans offered. Self-funded employers commonly purchase so-called stop loss insurance to protect against very highest claim costs that could jeopardize their businesses. By altering permissible stop loss products, Senate Bill 10 would effectively force some of these self-funded groups to pay substantially higher fully insured health benefit premiums. While the merits of state health benefit mandates are beyond the scope of my comments, I just want to point out that some employers, most notably small locally owned businesses, will be forced to spend substantially more on health benefits as a result of Senate Bill 10. Some of these small employers, as a result, will ultimately determine they can no longer afford to offer health benefits, leaving the employees and dependents exposed to the potential of having no coverage for health conditions. Alternatively, these small employers could accept the higher stop loss requirements. And if they do,
Could you please summarize?
and if they do, those higher stop loss requirements would expose them to potentially an additional $200,000 of annual cost, which could very well jeopardize your business. Thank you for your time.
Thank you very much for your testimony. Representative Pavlik D'Amato.
Thank you very much for your testimony. So did you give, I think you mentioned a number, what was the expected cost of some of the provisions and possibly the stop loss provision that's in Senate Bill 10?
I don't have an estimate for the stop loss provision, except that if the stop loss requirement were put in place, that by raising that stop loss minimum requirement, a small group could be required to pay as much as $200,000 of additional health claims if they had a bad year. Did you want me to step through the other ones? I don't need to neglect the other ones.
Oh, okay. So that was and that goes to the attachment, right? The increase as far as the attachment goes.
Yeah, that's right. I mean, it's just simply that they're accepting more risk themselves And our point is just that's going to jeopardize some small businesses operating.
Okay. And so were there any other provisions that you didn't get to in your testimony that that you wanted to comment on? Any other sections in SB 10?
There are potentially other sections, but I'm not prepared today to comment on those. And so I'll just have to defer that because we haven't had time to spend on that yet.
Okay. And then as far as the rate, I think it's in 11, the rate, rate language.
Yeah, and it's in 10B1.
Yeah, if you could go over again what you said as far as that impact on rates and policies.
Yeah, so as I understand the bill as it's proposed, this would require the commissioner to establish an annual index of what is an affordable premium. And then the rates that are filed by an actuary would have to conform to that, along with the classic requirements of not excessive, sufficient, et cetera. My point is just that in the actual standards of practice, affordability is not one of the permissible adjustments that an actuary could recognize. Now, from a public policy perspective, that may be a valid consideration. And my point is not to challenge that. It's just to say that an actuary, and the regulation, the bill would require an actuary who's credentialed by the Academy of Actuaries to certify those rates. That actuary is actually not permitted to take affordability into context. And the reason is not because actuaries don't get it that things are expensive. The reason is because the actuary's duty is to ensure that that insurance operation or that risk model they're representing will put out sufficient rates. The notion being, which could be debated, that the marketplace tells that insurer, hey, these rates won't work, they're too high, what have you. But the actuary is not permitted to put out rates according to some other parameter, such as affordability.
Right, and I have talked to actuaries about that issue and other bills and laws that we have enacted and the conflict that they face. So basically, they're not able to take the word affordability and it doesn't necessarily fit into a straight formula, depending on, I guess, somebody's definition of affordability and what the parameters are. And I don't think that this bill goes into the detail of that, how it's supposed to be applied. So I guess I would ask the drafters of the bill, yeah, okay, well then how are they supposed to apply this? And I think that's in like around line 562 is what I'm looking right now. So should this go to the floor, those are things I'm going to ask, and I know I'm not going to get an answer to it. So again, we're just going to be back here doing the same thing over and over again. So thank you for your testimony. I appreciate it.
Thank you, Representative. Representative Wood.
Hi, Keith. Thanks for joining us today. Wanted to get your take on the requirements in here on utilization review, the step therapy language, the burden of proof. Where does Connecticut, if past this, where does Connecticut land in comparison to other states? Are we an outlier? Is this where other states are moving? Do you have any feedback on kind of the national picture?
Very, very limited. So I'll try to limit my comments because I certainly am not an expert on all states. But most states I'm familiar with are focused around transparency and compliance with those transparently presented utilization review requirements. And so, I carry it. I think the bill has these components to it, which would be consistent. I think then the flipping of the presumption is the thing that would be distinctive. I don't know many other states that have that in place today.
And why is that? Is that just because it's a cost to, the customers of these plans, or is it just because it's hard to implement?
I guess I'm not sure why various, legislatures haven't passed that. I would offer this observation that it's difficult for a third party. And I think this kind of goes to, I try to be nonpartisan. I think this goes to the very crux of the matter. It's hard for a third party to make a determination as to appropriateness when they're not actually with the patient as the delivering clinician is. And so the sentiment would be, and it's certainly, there's a lot of public debate about this, and I appreciate that, that it's really the clinician who's presented with the patient is with the patient who ought to be the one who is providing support for why this is medically necessary and the appropriate course of action.
Okay, so a little, you're kind of pushing back on the approach here. To me, I read through a lot of what's in this bill and then kind of chuckle at the affordability part of it because it's greatly enhancing the cost to many plan owners in the state, and then saying, but if you can't afford it, we're going to give the insurance department the ability to, cap it. So we're drastically increasing costs across the board, whether it's, additional health mandates in here, going after stop loss policies that many small businesses rely on, and then saying, oh, by the way, if you can't afford it, we're gonna put a cap on. So it's just a big contradiction, across the board, when all the small businesses, all the medium-sized businesses that have testified here today are saying the same thing. We don't have options. We have extremely high cost of care, and a lot of us are stuck in high, deductible health plans. I just don't see how this bill is helping to solve any of those problems. That's just really a comment. Okay. Thank you very much for your time, Keith.
Thank you, Representative Wood. Any other questions of the committee? Seeing none, thank you very much for coming today and testifying.
Thank you. I appreciate it.
Have a good day. Up next is Victoria Reyes. She's online, I think. Not here. All right, moving on to Kevin Hubert. Nope, not here. Gary Winzenred. I hope I said that last name right.
Close enough. Winzenreed.
Close enough. Okay, thanks. Floor is yours, Gary.
Thank you. Co-chairs Cabrera and Wood, vice chairs Berry and Anwar, and ranking members Pavlak, D'Amato, and Huang, and all esteemed members of the Insurance and Real Estate Committee, thank you for the opportunity to provide this public testimony. My name is Gary Winzenreed. I'm the president and CEO of Corda Healthcare Innovations. We have been blessed to be involved with the Connecticut CLEAR program, which stands for Community and Law Enforcement for Addiction Recovery, for the past 4+ years. Our company provides training methods, evaluation, and technology in support of these CLEAR teams to enable more efficient operations, support continuous improvement, and to collect data on program efficacy. I am here today in support of SB 10, specifically regarding compliance with relevant parity laws for mental health and substance use disorder benefits. Cordata has been involved in programs similar to CLEAR in many other states across the U.S. since 2017. These programs have been designed to define at-risk individuals, create advocacy and trust, and help them to access treatment interventions and to stay with these treatments to completion. For some disorders, like opioid use disorder, treatment and supports are needed for as much as 15 consecutive months to support long-term recovery due to the nature of the disease's impact on brain function and the associated recovery times. Improving financial support for these long-term treatments in mental health and addiction is a necessary additional step to improving outcomes. While this may seem at first glance to be costly, data from Montgomery County, Ohio shows exactly the opposite. In Montgomery County, we've been working under the Department of Public Health, providing services for mental health and substance use disorders for over 5 years. This work includes a partnership with a data sciences company that has interfaced all the medical record data from the 3 major hospital systems in the area and the criminal justice data from the city and county organizations. They recently did an interesting evaluation of the deflection work in the county. The premise was, for every person our deflection teams had contacted and engaged, could we look at the healthcare and criminal justice costs the 12 months before first contact and compare that to the healthcare and criminal justice costs for the 12 months after. The results, just published in late 2024, and more completely described in my written testimony, are astounding. Most importantly of all the results, death rates went down. These programs save lives, period. The data also showed a strong relation to reduced arrests, fewer interactions with law enforcement, less violent crime in these populations. These programs make communities safer. Most importantly, in relation to this bill, healthcare billable costs went down by between $17,000 per person per year to over $40,000 per person per year. 65% of this population are Medicaid recipients and only 8% are uninsured. So over 90% of these savings will directly and positively impact carrier costs, primarily Medicaid. If we accomplish similar results by investing in diversion across the state of Connecticut, this data says the state would likely save $500 million or more in Medicaid expense alone without reducing enrollment. We're very proud to be a part of the CLEAR initiative in Connecticut. I just wanted you to know that better coverage of mental health and substance use disorders only seems costly. Done appropriate, completely, and with evidence-based practices, as this bill requires, expanding mental health and substance use interventions will actually save money. Thank you for the opportunity to testify.
Thank you, Gary. Any questions from the committee? Seeing none, thank you for being here. Next up, we have Paul Vance.
Good afternoon. I wore the boot for sympathy. I'm not actually injured. Yeah. Thank you. My name is Paul Vance Jr. I'm here on behalf of not only the CBA, where I serve as the vice president, but also as an attorney in Connecticut and an owner and operator of a small firm in Northwest Connecticut. I'm here in support of House Bill 7079. I think that association health plans would help lower the cost and deliver higher quality healthcare, cover a great number of people. And I think it's very important, especially in a state that relies on small businesses. Although we don't always think of lawyers and law firms as small businesses, they're not the mom and pop shops that we think of. In fact, of our nearly 8,000 members, nearly half of our membership are either employed or operate solo or small firms. That includes people all over the state. That includes firms that are owned by one, two. I heard someone earlier talk about a single shingle. So I'm here to not only represent a single shingle firm, which I used to be a part of, but I now currently own and operate a small firm that has somewhere between 12 and 15 people who would love to be able to take advantage of healthcare that is more affordable, that would cover all of us, and so that we don't have to rely on either spouses or having plans that are simply unaffordable. In my firm, I can give examples that we run the gamut. We have people that are still on their parents' health plan who are attorneys. We have people that rely on their spouse, including myself. And we have others who just choose not to because they make enough money where they're not deemed eligible for Husky, but they don't feel like they make enough money to be able to live, support a household, and also have health insurance. So we have people choosing to go without. So with that being said, I would love support of this committee for House Bill 7079. I'm happy to answer any questions.
Thank you, Attorney Vance. I mean, I can't think of a better, recruitment and retention tool for all businesses than being able to offer healthcare.
Sure.
We hear it kind of everywhere we go that, we're not able to compete. We're not able to hire the best, unless we are able to offer, employee benefits and healthcare being the front and center. I love that you guys are here testifying on this bill. We have tried for years to implement a pooling plan that would, allow small businesses to form a pool and to purchase like a large employer, because the large employers don't have, the flips and the ups and downs, and they're able to, spread out the risk. I was just wondering, we're here today listening to some other bills here that would essentially drive up the cost of healthcare in this space that we regulate. It just must be hard sitting there saying, we're just looking for more options, and here we are, putting forward less options. I mean, this one bill we're hearing about today would take a tool that many small employers are using, which is a level funded plan backed by a stop loss policy, and now saying we're essentially going to make this unaffordable for you. So you know, I hear what you're saying. I want to provide more options. I want to focus on lower costing health insurance coverage for small businesses. I'm thankful that you're here testifying on this and letting us know that you're still out there and that you're still willing, you know, to be a player. And we're gonna keep trying. So thank you for being here, Representative Meskers.
I would suggest, as a lawyer, I imagine in good standing, I would suggest probably that your group reach out as well to our committee, our law committee, to advocate. It's not because it's a purview issue. I think it builds support if different people begin to see the same thing. And coming from, I should say, co-religionists, lawyers to the law committee, they probably will have more credibility if you're trying to lobby. And I'm thankful to see you here. But we have to, it's a process of building support and having our membership, being the House membership, understanding the import of the bill. So it's good. It's obvious to us, many of us on the insurance committee. It's less obvious for other people. And so coming from someone who decided to take the bar might give them more credence than me, who decided to go into banking, I suspect. So I would say, don't be shy about advocating or suggesting within your group that there's advocacy to the members who live in their district, and advocacy to the committees where they would normally expect to be heard for their profession. So people say, well, hey, what are these association plans? We have to build that groundswell to make it happen, I think. But thank you.
Thank you.
Representative Pavlik Tomato.
And I agree with Representative Meskers. I was going to say something similar, that reaching out to having your employees advocate and reach out to their legislators, because if they're getting emails and they're hearing about it, then they know it's an important issue. And yeah, a lot of people ask, what can I do? And that's, I think, an important part. Getting one email means that really it represents probably a bigger group of people. But that's, some representatives and senators say, oh, nobody contacted me about that. I know the chambers are doing a good job too, but coordinating with other groups as well. I think everybody needs to really band together in order to have more options rather than less options, which some of this legislation works directly opposite and is just going to make it more expensive for all of us. So thank you.
Thank you.
Thank you and happy healing.
Thank you very much.
Next up, we have Paul Desan.
Good afternoon, and thank you for the opportunity to testify. I'm a psychiatrist in New Haven and a specialist in the psychiatry of the medically ill. As a consultant, I work with a lot of patients. In the case of both inpatient and outpatient services, sometimes psychiatric care is approved easily. In other cases, there's onerous prior authorization or there's denial and time-consuming appeals. This continues to be a significant problem and obviously differs from medical care. It's come up several times today that there's a problem having sufficient providers in Connecticut. Well, one reason that mental health providers don't participate in insurance is this onerous barrier of excessive documentation. Obviously, mental health parity is complex. This bill alone doesn't guarantee parity for Connecticut, but I think it is common sense that giving the insurance commissioner as many tools as possible to enforce parity is a good idea. Shifting the burden of proof, imposing fines, raising the standards for reporting, these are all common sense provisions to me. The citizens of Connecticut are struggling to get appropriate mental health care. That's obvious. And I strongly urge this committee to provide as strong tools as possible to ensure parity in Connecticut. Thanks very kindly.
Thank you, Paul. Can we, or is there anyone, or is there a bill out there that is working on some of the onerous documentation that you're talking about? Because I keep hearing that over and over again. And, you know, if that's a problem, we want to be at the table to help solving it. But is that being discussed maybe in the Public Health Committee? Do you know?
So I personally am not an expert in healthcare legislation, so I'm afraid I can't answer that.
Okay, we will do our due diligence on that because you're hearing the same topic over and over again, and we want to be here to solve problems. So appreciate you highlighting that for us. Any other questions from the committee? Great, thank you, Paul. Next up is Debbie Osborne, followed by John Rich.
Good afternoon, Representative Chairman Wood and other distinguished members of the committee. For the record, my name is Debbie Osborne. I am the Executive Director of 4 medical specialty societies in Connecticut. I'm here today to share some data, which is very alarming, and the reason I'm here today. 4 years ago, my organizations represented close to 1,000 physicians. Today, it is under 600. The question one has to ask is why? And the reason is our physicians are taking early retirement, they're burned out, they've entered models because they can't find physicians to come and join their practice in private equity. And the administrative burden that is being placed on them on a daily basis has caused the #1 reason why physicians are retiring early. So last week I went around to some of the practices and I asked physicians to come up to the Capitol and to advocate for patients. And I was disheartened to hear that not only can they not advocate for patients any longer, they can't advocate for themselves. These folks are small businesses. Many of them belong to CBIA. But they ask the question, if I'm not being paid and my reimbursements are going down, where is the money in healthcare actually going? The USA Today reported on the profitability of the insurers, many of which are in Connecticut. United Healthcare represents about 15% of the market. Aetna represents about 12%, and Cigna about 11%. United is the 4th largest company in the United States. They had profits, revenues of $371.6 billion. If you look at recent reports, in 2022, these same companies paid $170 billion to shareholders in dividends. So, Chairman Wood, when you talked about the cost and the added cost and what this is going to do, why is it we're not looking at the shareholders and how much money shareholders are getting from consumers who are buying healthcare, paying premium dollars, getting rejections and denials on prior authorization, not paying the physicians, but shareholders are benefiting? So I wanted to raise that question to this committee today and say, let's look at the profitability of these insurers. Are they really hurting? Are our doctors hurting? Are they leaving the state?
Your 3 minutes are up. Could you please summarize?
Yeah, we have more cuts ahead of us nationally. Doctors are going to face another 3% on the additional last year 3% cut in Medicare. The administration is now calling for $800 billion to be cut from Medicaid and Medicare. Physicians who are left in the state are not going to be able to service our seniors. They're not going to be able to participate. But what we can do is make it easier and release the administrative burden from the insurers who do have the money. Thank you.
Debbie, thank you. If you have any final things you want to summarize, I know you had you got cut short. Is there anything else that you wanted to add?
You know, I'm just very concerned about the amount of doctors that are leaving. You know, for the past 3 years, I had talks on burnout. I had talks on suicide. I had talks on despair. I'm trying to bring optimism back. And many of you saw us up here last week. We did a fire screening, skin screening for the firefighters. We're trying to build the community back. But if I don't have the members, if they're leaving and they're retiring early, which, you know, 4 years ago, my average age that my doctor retired was 67. Do you know what it is today? 61. I had ENT doctors talk to me at 56 saying that they're retiring because they just can't do this administrative burden. When you have 90% of your prior authorizations denied and you have to use more administrative staff to try and collect the money that you've already been promised, something's broken. So thank you.
Yeah, thank you for bringing your members up for that. That was really special to do for the firefighters. And even I see stuff in my towns all the time where there's, I live in a town with a veterans home, and doctors and nurses will come in for the day on their own volunteer time and give free medical services. So there's a lot of good work that's being done. Definitely concerns us. We have up here the chair of the Commerce Committee who, you know, these are all economic development issues. I mean, having 1,000 doctors a few years ago to 600 of your members now, that's a big number. It's glaring. So we appreciate you sharing that with us, and let's continue to work together on, you know, finding a solution. We want to make sure we have a great health system here, you know, filled with wonderful doctors and nurses, and to have those numbers go down is very scary. So thank you.
I'll just say I've been doing this for 30 years. I've never seen it as bad as it is now. So we need to do something better, and we need to support the doctors. And all I say is let the bill go through. See where it takes us. If the insurers are saying, I'm going out of business, then we re-examine it. But give the doctors this leverage to keep them in practice right now. Thank you.
Thank you. Any questions? Representative Delnicki.
Thank you for coming forward. We've had a number of conversations about this. And you're highlighting something that's been troubling me for years, because I've been attending the health insurance public hearings since 2017, when I first came up here. And the mere fact that the level of profitability is sky high, yet the patient care is not necessarily there, and the providers. And that is such a big problem. And at some point in time, it's going to have to be addressed very, very, trying to think of the appropriate adjective. It's going to have to be taken care of, period. Because I don't know how you stay in business. I don't know how you can continue to do what you do and provide the level of services that you do.
You know, I make it a point to call my members and to check in on them and to see how they're doing. I had 6 ophthalmologists that were solo practitioners that had no ability to attract another physician to take over their practice. They were worried about their patients. Where are they going to go? They ended up joining a private equity group, which lasted less than a year, because these businessmen thought, oh, there's so much money in healthcare. All you have to do is read USA Today, how many billions of dollars there are in healthcare. Yep. They ended up going bankrupt. One, because they didn't know how to do the billing, but secondly, because they were getting all of these denials and they didn't know how to, you know, get these denials through the system. These 6 doctors are now out of practice. They were given a 30-day notice saying that, you know what, we're closing shop, we're filing bankruptcy. They had taken all of their medical records. They had no ability to contact their patients anymore. One of them joined another solo practitioner. That practitioner just yesterday told me they're closing their doors. They can't do it any longer. And they're in Bridgeport. I am down to, I think, 4 ophthalmologists in Bridgeport now servicing. I mean, these numbers are scary. And, you don't see me up here testifying very often, but it is my last. I don't think I could sleep at night unless I told this committee what was going on and how many doctors we're losing from the state. Thank you for the question.
I appreciate you coming forward and your candid answers as what's going on here, as to how things have to be addressed. Very important.
Thank you.
Thank you, Debbie. Next up, we have John Rich, followed by Margaret Watt.
Good morning, Representative Wood and distinguished members of the committee. I'm Chief John Rich from the Ledyard Police Department, and I'm here today representing the Connecticut Police Chiefs Association to be heard on some concerns we have with the language with raised bill 7069, which would allow law enforcement officers to choose their own mental health provider for periodic behavioral health assessments that are required under Connecticut General Statute 7-291E. I'd like to point out that CPCA and its individual member chiefs have worked extensively on officer well-being, and we prioritize the importance of the mental health of our officers. Law enforcement officers are routinely exposed to traumatic events due to the very nature of the profession, and the stress that accompanies the duties of a police officer is unique. As officers are repeatedly exposed to tragic events and threats to their own safety. So ensuring that Connecticut's law enforcement officers are periodically evaluated by qualified mental health providers is crucial to supporting them in the performance of their duties. CPCA supports and respects this evaluation process and the documentation as outlined in the bill. And our members have seen positive results from the strong message of support that these evaluations communicate to our officers. While CPCA continues to support periodic behavioral health assessments, we have concerns with the language of the bill that would allow for officers to choose their own mental health provider outside of the department. Such a practice would introduce a variety of issues for our members, including the introduction of multiple unvetted providers who may or may not be competent to evaluate the mental health needs of public safety personnel. Additionally, department vetted providers who have worked with our departments are likely to have familiarity with our officers, and as such, they're likely to have a feel for the baseline mental health status of individual officers, allowing them to recognize readily signs of distress, including symptoms associated with post-traumatic stress. As chiefs of police and administrators of heads of law enforcement units in Connecticut, it's critical that CPCA member chiefs maintain the right to select the providers who perform mental health evaluations on our officers, and we understand the responsibility and importance of supporting the health and wellness of our officers as they serve the citizens in our communities and in our state. I'd be happy to answer any questions that you may have.
Thank you, Officer Rich, for being here. Chief Rich. Is it Chief?
It is Chief Rich, yes, thank you.
All right, thank you. So we did ask questions earlier to some of your colleagues that came regarding some improvements to the bill. Do you have any suggestions that you'd like to see in here, or did we get it all?
Well, I think the main point of concern that we would have, I think, in CPCA is like how to implement a variety of providers who may or may not work with public safety personnel regularly. And one of the things that we're concerned about, obviously, if we like to, I personally like to try to vet the providers that I would recommend my officers go to if they had any other problem or any personal problem that's outside of this process, because that's very much alive in our department. We recognize and encourage our officers to seek treatment and seek assistance. We're trying to smash that stigma that's going along with this in our profession for decades. And so I would be more than willing, and I think the organization would, to provide input and be a stakeholder in the conversation as it relates to improving the language. Because it could get pretty unwieldy if we had 5, 6, 10 different providers and trying to deal with each of them and their rates and scheduling. And that's the point of concern that I have.
All right, that's helpful. So it'll be on us. We'll make sure that we reach out to follow up on working on better language. Any further questions? Representative Barry.
Thank you, Madam Chair. Thank you, Chief Rich, for being here. How did your department implement the behavioral health assessment requirement?
So we engaged one of our regular providers who has done pre-employment psychological evaluations for our candidates, our police candidates, and that provider came up with a set of parameters and a proposal, which we reviewed and agreed to. So then we had the budget for the expense that's associated with that, because this is a requirement of the officers, individual officers' continued employment, including my own. So as such, I was a little surprised to hear of Sergeant Rakowski, his testimony earlier about the involvement of insurance companies, et cetera, medical records being moved back and forth between places, et cetera. We have a pretty streamlined process here. So we bring the provider on site. We're a small department of 23, so we are allowed to do, by statute, up to 20% of our department a year. So it's 5 assessments every fiscal year. We bring the provider on site. We schedule officers. We usually get a list of volunteers before we try to mandate it. And anyone who hasn't gone, they know that this is a requirement under the bill. And I usually get a full slate of 5 for the day. The provider comes on site. He meets with the officers individually. They're scheduled in 45-minute blocks. And then the provider gives a copy of his the confirmation that the officer attended the what we call a mental health wellness check to the officer, as well as provides one to me. We keep it segregated into the medical file, if you will, associated with each officer's personnel records that obviously, as you all know, are not subject to disclosure. And we, as of this point in time, we haven't run into any snags or any complications. And we worked it out early on in the first round with our union, and the union president and myself both volunteered to go first so that we could have a collaborative effort on implementing.
Excellent. Do your officers have to provide their insurance information when they have these assessments?
They do not. They do not. As we do them on site, again, we get an invoice from the provider, and we pay it through our department's operating budget, and we budget for it every year since it's been required.
Okay, thank you. And I want to thank you again for being here. And I want to thank you for all the work that you have done for officers' mental health. You really are making a difference. So I thank you for that. And have a good day.
Thank you.
Thank you, Chief. One more question from Representative Maskers.
Yes.
Chief, thank you so much for your testimony. And people walk up to me and say, thank me for my service. And I'm really not protecting anybody, or protecting people in a much different way. So I want to thank you for your service. It's a question about, it's an issue about disclosure, and I understand the concerns. This is a question, given the preponderance of sentiment over the last 5 years, and the difficulty of the profession, are you seeing an uptick in issues? I mean, the profession's under tremendous reputational strain because of the perception in the market. And I just worry about the people who protect us. And I'm wondering what insights, without disclosure and with confidentiality, are you seeing the pressure reflected? Are you seeing it that it's, I know the job is becoming more difficult. Do you think your troops and people in general are handling it well?
I do think they're handling it well, but and thank you for the question. It's a really important point, and it's wider than this conversation. It really goes to recruitment and retention and the difficulties that law enforcement officers and departments around the nation are experiencing. This is kind of a dearth in applications, and so we're all competing for the same candidates, if you will. And I think that's just a different issue here, but. Generally, as far as on the ground health and support of the officers that are working in our agency and in our region, I think a lot of this gets vetted out with effective communication and listening. And like we just really want to continue to encourage our officers that, and regardless of the storm that's happening outside, you know, we have a mission, and our mission is important. And we provide service to everyone, regardless of what their opinion is about us, our profession. When they need us, they call. We are going to respond. And so we try to keep it mission focused, and that seems to have calmed things down here, especially, you know, from 2020 going forward. It's been a challenging time, and I did lose two different officers who just completely left the profession without actually retiring. We've had several retirements, and some of those were expected, and some were a little early. But bottom line is, in the most recent years, we have seen the impacts of just culture and opinion
Raising the
against the
threshold,
officers.
raising the pressure. Yeah. All
Yeah.
right. Well, thank you. Thank you, Madam Chair. No further questions. Thank you, Chief, again.
Thank you.
Thank you very much for being here, Chief Rich.
My
Next
pleasure.
up, we have Margaret Watt, followed by Megan Wallet. Megan?
Mhm.
Good afternoon, distinguished members of the Real Estate and Insurance Committee. My name is Megan Wallet, and I serve as the Director of Policy and Advocacy for YWCA Hartford Region. I'm testifying today to express our support for SB 10, specifically regarding its strengthened behavioral health parity requirements. As an organization committed to eliminating racism and empowering women, we understand that access to behavioral health care is a critical component of overall well-being and economic stability. The need for stronger parity enforcement in Connecticut is clear. Recent data from the Office of Health Strategy shows that about 1 in 5 adults in our state experience a mental health disorder, yet access to care remains severely limited. More than 1.5 million Connecticut residents live in areas with mental health workforce shortages, highlighting the significant gap between need and available care. This bill takes crucial steps to strengthen compliance with behavioral health parity laws by establishing clear reporting requirements and enforcement provisions for behavioral health and substance use disorder benefits. These measures are essential, as recent reports have revealed persistent issues in parity for behavioral health care. At YWCA Hartford Region, we know the community members we served often must choose between seeking behavioral health care and meeting other basic needs due to costs and insurance barriers. No one should have to decide between paying for behavioral health therapy or putting groceries on the table. This is an impossible choice, and it's particularly devastating for women of color and individuals from low-income households who already face systemic barriers to accessing healthcare. The enforcement provisions in this bill would help ensure that when somebody decides to seek behavioral health treatment, they won't face discriminatory insurance practices that make care inaccessible. We urge the committee to support SB 10 and thank you for the opportunity to testify.
Megan, thank you for being with us today. Do you serve the greater Hartford area? Or is it just Hartford?
It's the Hartford region.
Hartford region. And do you find that people have to, are there providers in the greater Hartford area, or are people having to travel far to access mental health services?
I can't speak specifically on like specific circumstances, but that is something I can look into and follow up with you on and send an email to the rest of the committee.
Okay. And do you bring providers in to the Y to make that connection, or is it just your testimony is really dealing with the sentiments of the population you serve?
Our testimony is really dealing with the sentiments of the populations that we serve.
Okay, that's helpful. Thank you so much. Any further questions? Seeing none, thank you.
Thank you for having me.
Next up, we have Eric George, followed by Grace Brangwin.
Representative Wood, members of the Insurance and Real Estate Committee. My name is Eric George, and I'm president of the Insurance Association of Connecticut, representing the property and casualty and life insurance industries. Here to provide strong support for House Bill 7117, which is the product of many years of work by members of this committee, members of the Appropriations Committee, other members of the General Assembly, my association, and others, to look at how the insurance fund has been utilized over recent years. The insurance fund, as I'm sure everyone here knows, its primary purpose is to fund the operations of the Department of Insurance. And I want to say from right off the bat, we strongly support the insurance fund being used for this. Also, everybody should know that the insurance fund is funded by assessments on domestic insurers. Over the years, the insurance fund has changed. Rather than just being utilized to fund the Department of Insurance, it has gone to other uses as well. And one of them that has grown over the years is the pay for the operations of the Office of Health Strategies. Let me say, I think the Office of Health Strategies is a very important office and that its goals and its mission are laudable. It is related to public health. There is absolutely no nexus between the work of OHS and the P&C industry or the life insurance industry. And over the years, as we've seen this grow, this has become more and more inequitable. This General Assembly agreed last year and formed a working group. I want to thank you, Senator Cabrera, Representative Wood, and everybody here, Representative Barry, for your work on the working group. This working group recommended that the Office of Health Strategies be paid for via the general fund, because the benefit that the Office of Health Strategies provides is for every person in the state of Connecticut. And it is much more appropriate as such to be borne by the taxpayers of the state of Connecticut, rather than solely a small segment, in this instance, insurance carriers, specifically domestic insurance carriers and their policyholders. For years, premiums for auto insurance and life insurance and homeowners insurance have had to reflect the payment for this office. And again, I also want to reiterate, the office does phenomenal work, but it should be paid for via the general fund. The recommendations of the working group were to eventually, over 5 years, fully transition it from the insurance fund to the general fund. That is reflected in House Bill 7117. I had the privilege and the honor to work on that working group. I would like to thank all of the members of this committee, the members of the Appropriations Committee, the governor's office, all of the executive branch agencies who did all of the work on the working group. And I wanted to thank everyone for really taking an effort that has been years in the making and bringing it this far down the road. So I'll pause there. You have many other people after me. I'm happy to answer any questions that you might have.
Thank you, Eric. Who ends up paying the assessments?
Domestic insurers. So if an insurer is not domiciled in the state of Connecticut, they do not pay. It's domestic insurers, and then that is paid for by the policyholders of those domestic insurers.
So it's a direct pass through onto.
It's not a direct pass through per se, but ultimately the policyholders will be paying for that and have been paying for that through it's impacted on their premiums.
And what's the total cost per year?
So for the only thing that we're talking about is the Office of Health Strategies. It's about $14 million a year.
Okay. And if the recommendations were phased in, would that essentially save people money that have
It would
insurance
save
plans?
policyholders of those domestic insurers money, and it would, in my opinion, I've always taken this as a principled approach. If an agency or an office is for the betterment and the benefit of everyone, it should be borne in the largest, spread across the greatest number of payers. And in this instance, what we have is the general fund that's paid for by all the taxpayers of the state of Connecticut. And that is the most appropriate way for it to be funded. It's always in times of deficit that we see maneuvering of certain agencies and programs from the general fund to be put, I could have used another word, put into other various funds. it's not an equitable decision. We understand why it happens, but we think that we need to right that wrong.
Yeah, just looking at the time frame, it looks like during very difficult budgetary times under former Governor Dan Malloy, it looks like a lot started to be moved over to the insurance fund that is not related to insurance. Is that the correct
Those dates
timeline?
do line up.
Okay. You know, considering that this is a bill that would essentially save people who have insurance hundreds to thousands of dollars, I would have expected to have more support from some of the agency heads that were here, but we didn't hear that. And recently in the governor's budget, there was over $1 million increase in the insurance fund, which again is borne by you know, payers of you know, insurance. So I think it's really high time that we share this message with our colleagues that, you know, the insurance fund is here. I mean, I didn't know anything about it until we went through this exercise. And there's a lot being borne on those of us that have insurance plans. So thank you for your work on that. Any other questions from the committee? Great. Thank you for being here. Next up, we have Grace Brangwyn, followed by Michael Bergeron.
Good afternoon, everyone. With your indulgence, I'm Christopher Davis. I'm Vice President of Public Policy for Connecticut Business and Industry Association. If I could join my colleague, Grace Brangwyn, in testimony here today on 3 separate bills, but we thought it was appropriate that I was a member of the working group that on the insurance fund assessments to be here to testify on that bill in particular, in strong support, very similar support as the Insurance Association of Connecticut. So if it's okay with you, I'd like to testify along with Grace here today. And thank you all for having us here today. As I said, my name is Chris Davis. I'm the Vice President of Public Policy for Connecticut Business and Industry Association. So we submitted testimony in opposition to House Bill 7115 and would like to voice our support for House Bill 717, which I'm happy to answer any questions on as well. And we submitted testimony there. But really, we are here to testify in strong opposition to Senate Bill 10, an act concerning health insurance and patient protection. Connecticut's competitiveness is certainly challenged with high cost items like energy, childcare, housing, and certainly the high cost of health benefits for employers and their employees. In fact, CBIA's annual survey of Connecticut businesses found that member employers identified the cost of health benefit coverage as what should be the top priority for the legislative session this year. However, sadly, Senate Bill 10 does the complete opposite by significantly raising the costs for employers across the state. And I'll turn it over to my colleague Grace to walk us through what those costly mandates are.
Thank you so much, Chris. Today, I want to briefly highlight a couple of sections that are particularly onerous to the business community. First, Section 5 of this bill creates a mandate on health plans by assuming all medical services will be medically necessary, therefore driving up premiums. Second, Section 10 creates 2 detrimental proposals that directly impact the business community. First, it prohibits insurers from selling stop-loss policies to self-funded plans unless those plans provide coverage outlined in the general statutes. This essentially is a mandate on self-funded plans which may violate ERISA. CBIA strongly encourages the committee to seek legal counsel to ensure this language is ERISA compliant. This section also increases the aggregate attachment point for small employers, resulting in a devastating financial burden. And I'd like to provide you an example of these increased attachment points in practice. Let's say I own a small manufacturing company that employs 25 full-time staff enrolled in a self-funded plan. Under the current aggregate attachment points, I am liable for $100,000 of medical claims before my stop-loss policy is triggered. But under SB 10, I am now liable for $250,000 of medical claims before stop loss is triggered. This is a 250% increase in medical risk I now have to assume as the employer. This example is just a microcosm of how this bill will affect the business community. And SB 10 may increase costs for a self-funded medical plan by between 20 and 70%. Finally, I'd also like to briefly touch upon Section 16 of this bill, which also requires the insurance department to take into account if a rate request is considered unaffordable. We are concerned that rates will be artificially set and will make it harder for carriers to stay in the market or attract more carriers to our state, essentially creating an unpredictable rate setting environment. At this time of high costs, our state needs to be encouraging greater competition, not setting policies that will dissuade carriers from offering products in our marketplace. CBIA opposes all provisions of this bill that increase costs for fully insured and self-funded products in our state. Thank you again for your attention to this issue, and we're happy to take any questions.
Thank you both for being here. Have your members weighed in? Have they seen the changes to stop loss that are part of SB 10, and have they given you any feedback on that?
Yes, a number of them have submitted testimony, written testimony here today, so I direct you to take a look at those as well. But it's really a great concern of many businesses across the state. You see the self-funded or level-funded market make up over half of the businesses here in the state using those types of products to reduce those costs that are very important to be able to hire more people, make those investments here in the state of Connecticut, while also still offering high-quality, low-cost health benefit coverage. If the provisions of SB 10 were to be passed into law, it would essentially kill that entire market of self-funded and level-funded products and force every employer to have some very difficult decisions, either go into the fully insured market, which is very expensive, which is why these products exist in the first place, force them to no longer offer insurance, which then obviously makes it very difficult to attract and retain employees, given the fact that we have over 75,000 job openings. I don't think that's really what the state of Connecticut should be doing or would want to do during these difficult workforce times. So we have had a number of employers reach out to us directly and submit testimony here today, expressing a lot of concerns about the provisions in this bill.
I did get some charts from brokers that kind of broke down different plans, and your reference, Grace, to the 20+% increase was definitely visible with those charts. Or like you said, you can go into the fully insured product, which is also very expensive and has very few offerings in terms of carriers there. So I do feel like our hands are tied when it comes to offering, options for healthcare. Do you see anything that we should be working on? We had a couple people actually come testify on a bill on a pooling plan, a MEWA or association health plan. What is it that your members are asking in this space? Are they saying like, we really need an option? I know CBIA came up with a captive insurance that you're offering members. Like, what are some other things that we could be doing to add options, to bring more diversity in the offerings to increase competition here?
We did see the testimony earlier today, and appreciative of the Bar Association coming on that bill and saying, we need more options, because, many of their members are our members as well. And we are very much aligned with that position, that the need for an association health plan type option here in Connecticut would solve a lot of the issues that these small businesses are facing. As you mentioned, our product can only go down to about 10 employees right now. So there's still that gap between 1 and 10 that is needed here in the marketplace, given the collapse of the small group market, both on the exchange and also in the private marketplace. So having ability and options available to small businesses, especially in that 1 to 10 range, is critical. And association health plans, some sort of other pooling option, is really a solution that is available to policymakers here in Connecticut by passing legislation that allows it. And it's one that we have advocated for a number of years now. We continue to advocate for because we do see it as a potential solution to some of those cost barriers that small businesses face in offering those types of health benefit products to their employees.
And, on some of your larger employers, and if you can't answer this because I'm asking you to talk about healthcare with your members, and I'm not sure how intimate, you are in that, but, large employers are the fiduciaries of their health benefit. They're supposed to be looking at the makeup of their population and covering services that would benefit that population. And each business is going to be different. So when you see something like this stop loss plus essential health benefits plus state mandates, it's almost like the market and the federal government is moving in a different direction. They're putting the tools in the hand and the fiduciary responsibility in the hands of the employer or the HR department, you know, or the CFO. So I just feel like some of this stuff is going backwards. It's like the employers, that's their responsibility, you know, and they're required by federal law to do that, or they could get in trouble. You know, they can get sued by their employees. So I was just wondering like what the large employers think when they see stuff like this. It's like, I, you know, was wondering what their feedback. We heard a lot from the small and medium-sized employers. That's like, this option is now gone for us. But what do the large employers say when you see a state mandate like that's basically telling them you have to do all these, you know, mandates?
Well, it's important to keep in mind too, that a lot of the large employers operate in self-funded plans as well. So this could potentially be a major impact to them and not just to the small and medium-sized businesses, depending on how they structured their stop loss, if they have it or not. Some may not, given the size of their employment. They might take on that risk themselves, but a number of them, certainly in that kind of medium-sized space, up to 250, 500 employees, somewhere in that space or even beyond, may still be taking advantage of stop loss as a way to offer an affordable, high-quality product to their employees. So by eliminating that option or creating policies that essentially drive that option out of the marketplace, it sends a terrible message to the business community, employers in general, but more importantly, the impact that this kind of policy would have on the employees of each and every one of these businesses cannot be lost. You know, it's often talked about the cost of employers to offer health insurance, but those costs are borne by their employees. So by taking away from them the ability to have a high quality, low cost product through a self-funded or level funded plan through stop loss, really hurts the pocketbooks of every single one of those employees across the state, whether they're an employee of a large employer that offers those types of products or a small business or medium-sized business that offers those types of products. So I think it's very important to keep in mind as a committee that by prohibiting those types of products to be offered here in Connecticut's marketplace, you are directly impacting and costing Connecticut's residents significantly more money for their health insurance.
One last question from me. Are you at all concerned with the message of some of these bills here to the actual carriers in this space? I mean, the carriers that we regulate in the state, we can count on one hand. Like I'm always saying, how do we get more carriers participating in this space? Because that would also help us with options. Do you think that SB 10 and HB 7115 sends a negative message like, you know, this isn't a great place to do business? Or, I mean, that's one thing I always have in the back of my head. Is this going to help us pursue that goal of bringing more carriers into the space?
No, as Grace mentioned, I would actually argue the complete opposite of SB 10, especially section 16 of the bill that takes into making an unpredictable marketplace for rate setting, which sends a very poor message to the carriers that, hey, you can come in to Connecticut, offer innovative products perhaps, but we don't know how it's going to be priced, so it may not be even worth your while to even make that an option. Or if it is, it may be something that is an option for at one point and then shifted away based off of the rate making decision making by the regulator based off of some kind of arbitrary decision on whether something's affordable or unaffordable based off of the language of the bill. So I think that sends a very poor message to the marketplace that, hey, Connecticut is open for business in general to different ideas and innovation, but also that if you do take that risk and come into the Connecticut's marketplace and offer those products to try to lower costs, that they may actually be something that ends up being turned down by regulators based off of the language in SB 10.
Thank you. Any other questions? Representative Meskers.
I'm a little confused about the structure of this bill, so I just want to work at it with you. If I buy a home and I buy insurance, it's to cover the risks, and the policy coverage and the risk I want to be basically shows up in a deductible. And it shows up that I want a $50,000. I don't think they sell those. I get a $5,000 deductible or $10,000, and it affects my insurance premium. If I'm a corporation, I understand we're buying stop loss insurance, which basically means that some percentage of my loss on that plan is laid off on the insurance, on the policy, that the first the risk factor is going to be borne by the insurance. I mean, that's what we're talking about. And now the bill is telling me you can't buy that insurance to cover your risk. So you've got to bear, instead of 150, 250,000 of market risk on your policies before you can even think about buying a stop loss. So now I'm telling the company how they can insure their employees' medical risk.
So it's important that it doesn't prohibit stop loss, and it's a clever way of saying it's not prohibited. However, if you want to even attempt to purchase it, it's going to cost you significantly more money to do so, which essentially kills the marketplace for that type of product here in the state of Connecticut. And to your point, yes, you are off laying risk, and it's not the first layer of risk. In fact, as Grace pointed out in her testimony, it's actually after a significant amount of money that the business, as the employer who gets the policy, would have to pay up front as their quote unquote deductible in your example, before even that stop loss goes in to kick in. So the reason why you would want to have a lower aggregate attachment point is so that you do not have to have that risk of out-of-pocket expenses be so high that it becomes unaffordable for you to be able to purchase that product.
So if I'm a small employer, unless I provide a level of coverage that is comparable to what, a state employee medical plan? Is that what we're saying? Is it the mandates? I mean, I can't get my stop loss without a significant premium unless I provide certain coverage. And now I'm mandating what the coverage needs to be. So I'm taking negotiation away from the employee and the employer, and I'm turning it over to the state saying, these are the requisites before you can buy a market-based stop loss. If not, you've got to take more risk.
Yes, essentially. And what you're saying too is that you have a working marketplace right now for these self-funded, level-funded plans that, although they are very, very expensive, they are oftentimes the best solution for small business employees to have access to high-quality, affordable care. If you were to raise those attachment points, make it unaffordable for their employer to then offer that type of policy to their employees, you're essentially regulating out of the space those types of products, and thus the ability for those employers to be able to offer those types of products to their employees.
So at a point where I've got a shrinking number of providers of those types of policies, I'm trying to make the policy more expensive and less attractive to the people who are looking to get it.
Correct. Under SB 10, that would be the approach.
That's, in all my career, that's the most innovative marketing strategy I've ever seen. Okay, thank you very much.
Representative Barry.
Thank you, Madam Chair. Thank you, Chris, and thank you, Grace, for being here. I have definitely heard from a lot of my businesses this week, and they have big concerns with this bill. Healthcare costs is always their number one issue and their struggle, and they're always trying to do the right thing, and bills like this sometimes make it harder. Grace, in your testimony, you said that the stop loss provision may violate ERISA. Can you expand on that and explain that, please?
Yeah, absolutely.
Thank
So just to put it into record, self-funded plans are not regulated at the state level. They're regulated at the federal level by ERISA. And obviously, you know, we're not attorneys here, so we do encourage the committee to seek actual legal counsel in regards to this issue. There have been numerous court cases that determine the doctrine that state laws are used, or that doctrine that is applied to state laws in order to determine if ERISA preempts them or not. So we do encourage the committee to look into those court cases.
Any other questions? Thank you both for being here.
Thank you.
Next up, we have Michael Bergeron, followed by Thomas Burr. Is Michael here? All right, is Thomas Burr.
Good afternoon, Representative Wood, Senator Cabrera, members of the committee. My name is Thomas Burr. I'm the Public Policy Manager of the Connecticut chapter of the National Alliance on Mental Illness, otherwise known as NAMI Connecticut. NAMI is the nation's largest grassroots mental health organization, and we're dedicated to building the lives or better lives for the millions of Americans affected by mental illness. For anyone on the committee who's not familiar with us, please go refer to my written testimony. I'm here today in support of the mental health parity sections of Senate Bill 10. NAMI Connecticut, which is a member of the Connecticut Parity Coalition, has been working for years towards having the healthcare insurance industry adhere to full compliance with existing and long-standing mental health parity laws. Too many of our members and people we care about with mental health conditions routinely cannot access the mental health care that they are already paying for. Due to the nature of these conditions, people usually just give up without appealing to the insurance companies for reconsideration, nor lodging a formal complaint with the Connecticut Department of Insurance. And while some may argue that due to the lack of complaints that this isn't a problem here in Connecticut, study after study confirms that this is indeed a real problem. I've included links in my written testimony that references several industry study reports that illustrate really how deep and troubling this problem is. There's a report on the Witt versus UBH decision, the Millman report, the Bowman report, NAMI's The Doctor is Out report, and our parity policy brief. Senate Bill 10 is an important step toward ensuring payment parity between mental health and physical health services in Connecticut. The need for better data and accountability is quite clear. The 2024 report from the Office of Health Strategy revealed that 4 of 7 commercial insurers in Connecticut are exhibiting warning signs of parity noncompliance and underscoring the urgency of continued oversight. Mental health parity is the law. It has been the law for over a decade now, and it should be adhered to. When it isn't, many people desperate for services will not receive them, worsening their conditions, which will then cost more to address. People lose time, some people lose their jobs, and some people lose their lives. And for some of the people, they will, if they can, switch over to the Connecticut Husky program, which is in essence a cost shift from private for-profit businesses to the state of Connecticut and ultimately the taxpaying citizens. This has simply got to stop. In conclusion, I strongly urge the Insurance and Real Estate Committee to favorably vote on SB 10. The bill will provide much needed improvements on parity compliance, enabling us to address the gaps and increase the ability for all individuals with private health care insurance in Connecticut to access the care that they need without facing financial discrimination and potentially life-threatening consequences. I should note that prior to my testimony here today, I did survey our members. 100% of them are behind us in what we've asked for today. And in fact, mental health parity has been continually one of our top legislative priorities for many years. And frankly, I wouldn't be here wasting your time or my time if this wasn't a burning platform issue. And I urge you, read those reports and please take action and pass this bill. Thank you.
Thank you, Thomas. If we pass this bill tomorrow, just walk us through how this is going to, solve some of the issues that you brought to us here today.
I think the reporting and having the reporting not be anonymous will be eye-opening.
Because it's going to disclose what?
Just how non-compliant the industry has been.
So current non-compliance under current law?
Yeah.
So the Department of Insurance is not following the law?
It's not the Department of Insurance. Again, as I mentioned in my testimony, people who are dealing with either their own mental health situations or one of their loved ones are people who are in crisis. They don't have time to be filing complaints to the Department of Insurance. They don't even know it exists. They are consumed with just trying to keep their heads above water and try to get through their day and hopefully try to access some care somewhere, somehow, so they can get better.
Yeah, I'm sorry, my question wasn't clear. I didn't mean to file complaints to the Department of Insurance. The department oversees the carriers and the mental health parity law. Are you saying that the department is not doing that now?
I don't think they have the ability to see the level of the problem.
Okay. I think like the level, like your boots on the ground perspective and the level of the problem and all that. I mean, you heard a lot of our testimony here. I mean, there's a lot of problems that people are bringing in their testimony that this bill is not going to solve, but we want to solve those problems.
And I
So-
understand that. I don't think this is the end all be all.
Okay, good.
But it's very incremental. Honestly, again, having been in this fight for a number of years, we can't ask for the whole enchilada right up front because we know it'll never get made into law. We feel this is a reasonable compromise to at least start exposing the level of what's going on. Maybe if the insurance industry is named publicly, maybe they'll self-correct, but at least we'll really finally see the depth of the problem.
Okay, I understand what you're saying. Thank you very much. Any, Representative Meskers?
You know, I want to thank you for your passion. As we talked about the Senate bill, I think that's the bill that also includes the issue about the stop loss. So there are aspects of this that are not particularly acceptable to me at this moment.
Yeah, I didn't really come here to address the stop
No,
loss stuff,
I
so-
wanted to appreciate the fact that
okay.
if we can segregate out or amend, it's not that I don't hear you or care. And I wanted to leave you with this thought in what I heard, which I think is very problematic, and I've heard it on the medical side with coding, and I've heard it on the psychiatric or mental health side with the hours involved in what we've got as a very big standalone profession or independently run practices, and people spending 2 or 3 hours applying for reimbursement. That's unacceptable. We've got to figure out how to streamline that process.
Agreed.
If you ask me, if I had to sit here with the first priority, I think if the problem is that people aren't filing complaints and the compliance ostensibly looks good, naming names is probably not going to get you a big disclosure. I think turnaround time on applications or denial of coverage or coding, I need to drive enough people who are providing the service to go in, what do we call it, in market, in network, sorry. I was just out of commerce, so my jargon is leaving me. But we want to drive people in network. We want to make the experience so that the care is not done out of network and with ridiculous or out of pocket, right?
Well, and you bring up a good point because I hear this all the time, and part of my job is not only just public policy, but I also facilitate a family support group once a month. And one of the reasons I do that, beyond just sharing my expertise, giving back to people who help me when I need help, and my family needed the help, was to understand what they're seeing out there. And when it comes to these networks, and I didn't touch upon it in my written testimony because this is such a big thing. The networks, we call them shadow networks. I can't tell you how many times people have said to me, they come into the support group and they said, you know, my loved one's in the hospital. They're getting out in 2 weeks. And then a month later, they come back, say, yeah, they're out, but now they were supposed to get a script filled and they need to get an appointment with a psychiatrist. And we got the list online of the network for the insurance provider, and they start making phone calls. The first person is no longer in business. Now, why is that still on their website? Second person, they take insurance, but they don't take that insurance company's insurance. Again, why is that on the list? Third one, oh, we have an appointment. We'll see in 8 months. Well, I've got a 2-week script. I need to see someone in the next 2 weeks or at least 30 days. And they go through the list, 12, 15, however many names of providers that are supposed to be out there providing this healthcare, and they don't have an appointment at the end of it. And I hear that again and again and again.
I can tell you without taking the committee's time, my doctor graduated out of the system because he sold his practice and he wasn't board certified. I had to scream and run around to find a doctor in network with my state policy plan. So, and that's on medical. So I appreciate that. I would suggest, if we don't get to an agreement where you want to get to on this bill, and where we'll see where we'll go, I would suggest that the qualification for complying with the law, we may need to figure out how we want to address coding, the response time. You know, if we're not measuring the adequacy adequately, we're not rating people in the right way. And if they're not delivering service, or if they're driving people out of network, or they don't have providers and they live, you know, we've got to address some of those root issues. And that is an issue that, you know, we're hearing that, you know, somebody testified, it was like, he said 2 or 3 hours to apply for reimbursement for psychiatric mental health treatment.
It's a big reason why the providers get out of the network.
If he's charging $400 or $300 or $250 or $500 an hour, he's just lost $1,500 worth of income in applying to get his 500, which is why he says, at that point, the equation works out to be, I'm better off taking $250 out of system where it's cold hard cash than spending 4 hours to get my 500. And that may be part of the equation, is how and that's the kind of thing we may need to look at. I would suggest that when I look at the market drivers, that might be the driver we could fix more.
And that would be a start.
Okay.
Yeah, I mean, certainly, when it comes specifically to mental health, and I believe it's the Millman report, the rates of out-of-network access to services, because there's nothing available in our network, is like 10 times greater for mental health services versus physical health services. And that's why we talk about parity.
And
It shouldn't be that way.
And it has to be either a comparison of the dollar reimbursement rate or the hours worked to get reimbursed. And I'm assuming you're gonna use, like, I think the by fire example speaks what I really wanted to say. So no further questions, Madam Chair. Thank you.
Thank you.
Thomas, thank you for joining us today.
My pleasure.
Next
Good
up,
luck.
thank you. Next up, we have Monica Nugent, followed by Dr. John Satterfeld.
Hi, good afternoon. Can you guys hear me okay?
Yes, welcome.
Thank you. Good afternoon, Senator Cabrera, Representative Wood, and members of the Insurance and Real Estate Committee. My name is Monica Nugent, and I'm a Public Policy and Advocacy Associate for the Connecticut Nonprofit Alliance, or better known as the Alliance. The Alliance is a statewide association of community nonprofits. Community nonprofits provide essential services to over 500,000 individuals and families in Connecticut every year, improving the quality of life in communities across the state. The Alliance urges you to support Senate Bill 10, an act concerning health insurance and patient protection. While this bill addresses several important areas, the Alliance wants to spend our time today specifically talking about sections 1 through 4, which focuses on mental health parity. As you've heard mentioned earlier today several times, there are several reports, including a 2019 Milliman report and a report from the Office of Health Strategy that shows that 4 of the 7 major insurers in Connecticut show federal warning signs of parity noncompliance. Without payment parity, individuals seeking mental health treatment often face higher out-of-pocket costs or limited access to providers, putting their health at risk and leaving them without the care they need. When it comes to community nonprofits provide behavioral health services to people across Connecticut. By their mission and their contracts with the state, they serve all clients and provide the care they need, regardless of the ability to pay. This means when a commercial insurer denies a claim, the nonprofit delivers the services anyway without being paid for the services by the individual's insurance. After years of the state budget not adequately investing in community nonprofits, they can no longer afford to subsidize these insurance plans. The Alliance supports SB 10, and we encourage the committee to support it as well. Thank you for your time and consideration. I'm happy to answer any questions.
Thank you, Monica. Any questions? Seeing none, thank you for being here. Next up, we have Dr. John Satterfeld, followed by Sam Helmer.
Hello, Co-Chairs Wood and Cabrera, members of the Insurance and Real Estate Committee. It's a pleasure to be in front of this committee again, testifying on behalf of the Connecticut State Society of Anesthesiologists in support of SB 10. My name is John Satterfield. I'm a practicing anesthesiologist in Connecticut, past president, Connecticut State Society of Anesthesiologists, and the current chairman of the CSSA Advocacy Task Force. I'm a longtime resident of Southington. Here is a very important headline from this past November. Anthem Blue Cross plans won't cover anesthesia for entire length of surgery that exceeds time limit. It's a cynical money grab. Any proposal to no longer pay for anesthesia care if surgery or a medical procedure goes beyond an arbitrary time limit, regardless of the length of the procedure, would represent an unprecedented break in the trust between a health insurer and their policyholders. Anthem's proposal arbitrarily set the maximum amount of time they would pay an anesthesiologist and is the latest in a long line of appalling behavior by commercial health insurers. Such behavior demonstrates that insurers prioritize the protection of their profit over their patients' health and safety. Of note, the Federal Government Accounting Office, the GAO, has evaluated Medicare payment to anesthesiologists, and in 2024, that assessment demonstrates a 24% decrease in real value of Medicare payment to anesthesiologists over the last 25 years, a 24% decrease. In stark contrast, in 2024, Anthem reported a profit of $2.3 billion, a 24% increase in just 1 year. Any policy establishing arbitrary anesthesia time limits would also demonstrate a diminished dedication to patient agency and safety on part of the insurer. In effect, if a patient has a surgical procedure which lasts longer than the arbitrary standard set by an insurer, then that insurer has absolved themselves of the responsibility to pay for the anesthesia that is required for the rest of the surgical encounter. This is wrong and simply unacceptable. The CSSA strongly supports Senate Bill 10 and specifically the language in Section 18 that opposes the establishment of an arbitrary time limit on the delivery of anesthesia care. Thank you very much.
Thank you, Dr. Satterfield. I was just wondering how that works. So did you get a letter from Anthem saying that they were going to not cover it?
The history of this is that actually a small private anesthesia practice in Connecticut, the administrator was looking through the Anthem policies and discovered that. And that was the first anybody in the nation who heard of that. And our national organization was quickly notified and identified that there were other states in the nation that were going to be subjected to this policy. So the first identification occurred in Connecticut. Our national society was notified, and then the state, our state society started advocating along with our national society, the American Association of Anesthesiologists, to prevent the policy from being enacted.
Okay, so small practice in Connecticut, did they receive a letter from Anthem? So how are they notified?
Interestingly enough, this administrator has a long history of identifying policies from insurers that adversely affect anesthesia groups. And because of her vigilance, that's how this was discovered. So we had no notification whatsoever. If it wasn't for her, we would have found out at the time that bills were submitted and that an arbitrary time limit had been established.
And how is that even possible if you have like an agreement with what's covered? Like, I'm just thinking of a large employer plan, or, how could you have benefits that are defined in that plan? And then I just don't even understand how that's possible.
It's a great question.
Okay.
We don't know either. We were shocked when this happened, and our national organization was as well. It just came out of nowhere, and I don't have a good answer for you. It's a great question.
Yeah. And did you happen to have any discussions with the Department of Insurance on this?
We specifically, I did not. We decided to approach it in a different manner, but we were prepared to reach out to the department.
Okay.
Absolutely.
Okay. So part of my due diligence is going to be, I'm going to talk to the department on how this is even possible, because I'd like to know, like, because this is pretty scary what you're saying. We will do our homework on it to prevent anything like
Thank you.
this.
I'd
from
like to
happening.
give you a specific example, if I might, about anesthesia billing. So every year, the AMA publishes a code book. It's called the CPT code book, current procedural terminology. So all medical specialties, surgeons, anesthesiologists, use the codes in that book to submit their procedure, what they're doing for the patient, whether it's a diagnostic test or even blood draws. There's CPT codes for almost all medical procedures that occur. Anesthesiologists have a code 00840, which is a code for surgery of the lower abdomen. It includes almost 200 surgical procedures, from as simple as an appendectomy to as complex as a radical prostate removal. And there's a wide variance in the times those procedures take. So anesthesiologists bill for a simplified procedure code and then have to bill for time, versus our surgical colleagues who can bill multiple, potentially their surgical team can bill multiple codes, but there are any number of codes that fall under our code 00840. So they may bill for an appendectomy, which takes 45 minutes, or they may bill for a prostate removal, a radical prostate removal. A patient has cancer that could take 3 or 4 hours. But our code covers both of those things. That's why it's so important that anesthesiologists are paid for the time it takes to do the surgery. And there should be no arbitrary limit set, because you just don't know how long a procedure is going to take, any given procedure.
Yeah, I'm sure that the data too is all over the place, because everyone's different. Everyone has different
Correct.
health,
Correct.
issues. So
Correct. And they have the ability to utilize specific codes. If their surgery is more complex than a simple appendectomy and it requires more surgery, they have a greater complexity code that they can use, and we do not.
okay. Can you just answer a question that's not really related to this bill, but just a lot of what we're hearing today? How are the numbers of professionals in your space in Connecticut? Are we level? Are you more or less? Like, how's been the recruitment and retention?
So I can speak from personal experience of my group. It's challenging to recruit in Connecticut. Our retention rates are adequate, but recruiting is a challenge, without a question. I am unaware of any patient in Connecticut that has been denied access to care because of lack of an anesthesia care team. There certainly is a shortage of providers, and all of us are working harder and longer to make sure that we provide care when the patients need it. But yeah, it's definitely a problem, not just for anesthesiologists, but you definitely see it for emergency room physicians, anesthesiologists, hospital-based physicians in general. It's becoming more and more difficult to recruit people to come to our state.
I'm sorry to hear that, but just work for us to do another time, and we're here to help with that.
And I just have to say, I'm deeply appreciative of what the committee has done and your willingness to listen to not only the issues of anesthesiologists and other physician specialties, but all the work and commitment you're putting forth to try to better the lives of your constituents and all Connecticut patients. It's very commendable. Thank you very much.
Thank you for your time today. Next up, we have Sam Hellmeyer, followed by Dawn Holcomb.
Good afternoon, Chair Wood, Chair Cabrera, members of the committee. My name is Sam Hollemeyer with the Pharmaceutical Care Management Association, otherwise known as PCMA. PCMA is the trade association for America's pharmacy benefit managers, who offer prescription drug benefits for over 275 million Americans. I'm here today to test in opposition to Senate Bill 10, which is an act concerning health insurance and patient protection. I did submit written testimony this morning, so I will keep my comments brief. But before I dive into our concerns with the bill, and I gave this same speech last week, no one is required to use a PBM. Plan sponsors choose to work with a PBM because of the purchasing power and tools that they offer to keep costs down. And in fact, PBMs are the only ones in the supply chain that do drive down costs. Additionally, PBMs do not set the price of a drug. That is alone set by the drug manufacturers who make the drug. So now to get into the specifics with the bill, I'm here to focus on Section 5 and Section 7 of the bill, but specific to drugs, not on the medical side. So let's start with Section 5 of the bill, which would require the burden of proving a medication is even needed. So as you all know, prior auth is used to make sure that prescription drugs are safe, effective, and safe and cost effective. But we think that this section would completely upend how prior authorization is currently done in the drug supply chain. So what would be a reason for a prior auth to even be used? Drugs have dangerous side effects, drugs that are harmful when combined with other drugs that can be used for only certain health conditions, drugs that are often misused or abused, and then finally, drugs that are prescribed when equally or more effective or affordable drugs should work. So there's the section on Section 5 I want to discuss. Now, moving along to Section 7 of the bill, another way that plans and PBMs can contain costs is step therapy. And step therapy ensures that the patient gets the safe, most effective treatment at a reasonably, usually generic, at a reasonably cost. Step therapy encourages trying proven more effective therapies before the more expensive brand name drugs that are used. We think that the bill would also make changes to the step therapy process and would completely upend how that is currently done. Every plan has an exceptions process to bypass some of these prior auth and step therapy if the PBM and the plan sponsor works with the prescribing physician on these specific drugs if the doctor deems that it is medically necessary. So finally, PCMA appreciates the opportunity to submit comments in opposition to Senate Bill 10. We don't think that the bill does anything to lower the costs of prescription drugs. And in fact, we think it would do the opposite and raise the prices that are currently being used. And I'm happy to answer any questions.
Hey, Sam, thanks for being here. Can you walk us through, I feel like I've said that 100 times. I apologize today. Can you walk us through what you were just saying regarding step therapy? So here's something that I hear often.
Sure.
Someone is using a name brand drug that they've used for 10 years and their insurance coverage has changed and the new carrier requires them to try a generic drug, but they prefer to use the brand name. Are you saying they could work with their doctor to bypass the step therapy process to stick with the drug that they've been using for the past 10 years?
Yeah, thank you for the question. So yeah, that can be done with the PBM and plan sponsor to make sure that the patient would stay on that drug. Yes.
Do you see that used often? Because I sometimes hear people, I don't think people know that that option is there for them, or maybe the doctor's not communicating that. But, even colleagues in the building, they're using a certain,
Sure.
cream or something like that. And then, the formulary changes or something. It's like, hey, can you try this generic? Well, I don't want to use that because I want to use the brand that I know and love. The
Yeah.
doctor they can work with the doctor on sticking with that.
I would agree with you. Yes, if they can work with their doctor. Now, in an instance where an insurance might change or a formulary might change, the PBMs do send communications to the patient to let them know that, hey, you're on this drug, a formulary might be changing. We recommend that you try this other drug. That could also trigger them to work with their doctor to start that step therapy or prior authorization process to stay on their current regimen. So the communication from the PBM is going out if there is a change, and if that is done, then they can work with their doctor and their plan sponsor and PBM to go through that process to stay on what they're currently using that might be working.
Okay. And, in some cases, I've seen the generic drugs be extremely lower cost, like 5 cents,
Yep.
for something that could be hundreds of dollars. What is the pushback on using generics with the patient population?
That's a great question. I don't know why folks aren't interested in taking the generic. It's unclear to me why. Obviously, it's much cheaper. But I guess if the doctor works with them and recommends this brand, maybe there's commercials that they're watching. I'm not sure. I think there's a variety of reasons why that might be the case. I can't pinpoint on exactly one reason.
Would you be supportive if we banned commercials?
Yes, I would.
Any other questions from the committee? Okay, Sam, thank you so much.
Thank you.
Next up, we have Dawn Holcomb, followed by Jamie Rodriguez.
Good afternoon and greetings to the esteemed members of the Insurance and Real Estate Committee. My name is Dawn Holcomb. I live in South Windsor, Connecticut, and I serve as the Executive Director of the Connecticut Oncology Association. I'm also honored to serve on the Connecticut Prescription Drug Task Force and participated in all 4 of its subcommittees. So I wish to offer my thoughts on Committee Bill 10, an act concerning insurance and patient protection. I do basically support the bill, but I do have concerns because it will only partially accomplish the aims with which it was written. I have submitted detailed testimony. I'm going to try, for the interest of time, to just hit the highlights, but would be happy to address any other information and via questions that you like. First, Section 5, lines 138 through 144, talks about medical necessity being defined by the treating provider. We have strong support for this section as long as a critical addition is made. Right now, the language says that the presumption is that healthcare service under review is medically necessary if ordered by a healthcare professional acting within their scope of practice. I believe healthcare service and prescribed medicine, the words "and prescribed medicine" should be added after healthcare service, because every single day, thousands of vulnerable patients in Connecticut are subjected to needless delays in care and treatment by the arrogance of corporate medical decision-making, second-guessing the professional decisions made by a physician and patient. The physician is most intimately knowledgeable about the individual patient disease and health status, and no utilization review company has that knowledge and should be making those decisions. The next section of the bill is about no adverse determination may be made without qualified health human review. And I'd like to suggest that that be modified to additionally and explicitly state no adverse determination of clinical probabilities shall be made without human clinical peer review who is then identified to the treating physician for direct contact regarding that adverse determination. The next section is under rebuttal of medical necessity presumption, lines 240 through 245. And I just have to say, what in the world is this section trying to say? The language makes no sense and needs to be clarified because I looked at it for half an hour and couldn't figure out what it was trying to say. The next section is prescription drugs, lines 284 through 286. This does not go far enough. This restricts patients being required to obtain drugs from a pharmacy. PBMs now are vertically and horizontally integrated and control drug pricing, rebates, site of service, prescription fill, and patient access to treatment. We need a patient choice for pharmacy rights bill. We don't need to nickel and dime and play games with these kind of simple little modifications about PBMs. I've included explicit detail in my testimony about how Oklahoma worded control over PBMs in their Patient Right to Pharmacy Choice Act in my testimony, and I'd be happy to address that further with questioning. The last section is the step therapy section, lines 290 to 293. It appears to modify that no insurance company may require the use of step therapy for a prescribed drug for treatment of disabling or life-threatening chronic disease or condition. We strongly endorse this change. It falls in line with other state legislative protections for cancer patients and support an expansion of the previous legislation that merely spoke to no step therapy for a patient who has been diagnosed with stage 4 metastatic cancer.
Your
And
3
my
minutes
last
are up. If you
section,
could please summarize.
okay, my last section is the equal site of care reimbursement for codes and geographic region. We do support that section. And with the suggested modifications in my written testimony and verbal, we support Bill 10 and have no comment on other sections.
Thank you, Dawn. It's always a pleasure to have you. You always provide really wonderful testimony that helps us. Can you
Thank you.
talk about the changes to step therapy that happened? I believe it went into place a couple of years ago from 60 to 30 days. Can you just share any feedback from that change?
Well, I'll tell you basically that when this goes back to who's making the medical decision making, the physician or some corporate entity or utilization review committee that has no knowledge of the patient, no knowledge of their actual health status or their specific drug. The physician makes the decision about and their recommendation for what the appropriate treatment is. Most of the time when step therapy is required, the physician has to fight back against it and change it, and it does get changed. But in the meantime, these vulnerable patients have gone through weeks or months, sometimes even years, of being forced to take something the doctor has already decided is not going to be appropriate for them. And so the step therapy for not having step therapy for a disabling or life-threatening chronic disease or condition is the bare minimum that we should be doing. I don't even think we should be doing the 20 to 30 days, but 20 days is better than 30. But you have to think about the obverse of that you're now telling the patient that they can't get what the physician feels is appropriate for their condition until they've done a dance and used some other drug that somebody that has no knowledge of them has said, we want you to do this. And odds are it's because those other entities have a contract somewhere that is making them money on that particular required step therapy, and they could care less about what it means to the patient.
John, thank you for that. That was really helpful. Any other questions? Seeing none, we'll move on to Jamie Rodriguez, followed by Brooks Goodison.
Hello, co-chairs Cabrera and Wood, ranking members Pavlik Damata and Huang, and the members of the Insurance and Real Estate Committee. My name is Jamie Rodriguez. I'm a licensed marriage and family therapist and the advocacy chair for the Connecticut Association of Marriage and Family Therapy. I'm here today to testify in support of SB 10. CTMFT represents over almost 2,500 marriage and family therapists throughout Connecticut employed in various clinical settings and treat Connecticut residents with private insurance, Medicaid, and as of 2024, Medicare. Mental health parity has been a concern of CTMFT for a long time, and this is not even my first time testifying in support of mental health parity enforcement. CTMFT and our members have attempted to work within the current system to improve mental health parity and improve access to care for Connecticut residents in many ways. Examples include we continue to work with the insurance carriers themselves and their provider and patient liaisons. We have utilized the Connecticut Insurance Department, logging multiple complaints. We have attempted to engage the Connecticut Healthcare Advocate in these patterns of noncompliance. A representative from CTMFT even participated in an insurance work group in 2021 that included insurance carrier representatives, legislators, and many patient and provider advocates. All of these previous and ongoing efforts have left the mental health community with little to no change in mental health parity, as mental health patients and providers continue to encounter barriers in accessing care and reimbursement of services. In fact, as recently as this year, insurances have reduced the rates up to 22% for systemic mental health treatment codes, such as couples, family, parenting, co-parenting, and more, as compared to individual treatment rates. This systemic disparity disproportionately impacts marriage and family therapists who are often sought out by family courts and other providers to address mental health treatment from a family perspective. In a time when mental health providers are struggling to cover business overhead while remaining as in-network providers, insurance carriers lower reimbursement rates for a valued and evidence-based mental health treatment. The purposeful and consistent barriers to care, as well as denial, delay, and reduction of reimbursement rates have continued to burden the mental health provider workforce. SB 10 presents a functional strategy to address these ongoing impacts of insurance carriers' refusal to comply with the state and federal parity laws. Though through SB 10, we are seeking compliance and reporting, transparency of noncompliance, as well as education around access to care. These patterns of insurance practices that negatively impact mental health patients and providers are clearly not in the best interest of the mental health patient, mental health community, or the state of Connecticut. These practices only benefit the insurance carriers themselves as a targeted goal of denying care and reducing reimbursement to mental health providers. The problems themselves are clear, and despite the efforts of many, the root of these problems still remain intact, and Connecticut residents are left without adequate mental health coverage. SB 10 will create a system in which these patterns of disparity can be, identified and resolved in larger systemic ways, rather than the current system of playing whack-a-mole one by one with individual patients and providers. CTMFT strongly urges the the Insurance and Real Estate Committee to pass SB 10 to ensure mental health parity is no longer just a promise, but a reality to all Connecticut residents. Thank you for your time and attention to this matter, and I'm open to any questions.
Thank you, Jamie. We have a question from Representative Pavlik Tomato.
Thank you.
Yeah, could you maybe go into a little bit more detail? Yes. You said that there were complaints filed, and I was just wondering generally what those were about, if they were services not paid for or covered, or what were those complaints? I think they were to the insurance department, but if you could clarify.
Correct. We often encourage all of our members that come to CTMFT with concerns around any of these mental health parity things to lodge complaints with the insurance department, one for a record and also for the hope that they are investigated and, resolved. So I can't speak to every single person that has lodged a complaint. That is our standing recommendation to members who come to us, and they often do report that they do and get little to no feedback as a result, or little to no resolution as a result. And if I can go into more detail of the types that complaints that we get, if that was more what you were looking for.
Yeah, kind of both, and maybe if you even want to send some of that. I'm curious to know if the department found that they, I don't know, weren't illegal practices, or I just, some of the information that I think that we've been discussing or finding out that I don't know, that there weren't complaints or there weren't violations found, let's say. So I think that's where I'd like to find out some more information. So yeah, if any data, maybe even as you as an organization can put together to provide some clarification for us, that would be very helpful.
Yeah, we don't require our members to provide us documentation of these reports. We're all CTMFT as a board, we're all volunteers and we're all actively mental health practitioners as well. So, we don't have a huge team, especially not a paid team, in the way that like CT Parity or NAMI or something like that would be able to, assign that task to someone. I can definitely reach out to the people that have reached out to me and ask if they would like to do so and pass that information on to you. But I know just for myself, the resolution when I have filed complaints, they have been like, oh, well, this is a he said, she said, we looked into it and they said that there's not a problem. Or this sounds like a contract dispute and, not something that we can be involved in. So there's very little, from what my perspective and my experience is, fact finding in that process. So again, I can ask our other members to provide that information, but we don't have it on hand as we don't have a department that manages that.
Okay, yeah, and I think it, and I understand, and I'm not asking specifically for like full documentation. I just think maybe keeping track, and that way, again, I would love to follow up and find out, okay, what happened here? Why wasn't this resolved, or if they think it was resolved, just because I want to make sure, I think all of those issues that the providers are facing are such a barrier, and, I definitely want to follow up. So thank you.
I appreciate your suggestion. We'll definitely look into that.
Thank you. Representative Meskers.
It would be helpful if it's not a tremendous burden. I'd like to revisit the comments about the reduction in compensation by 22% or 20%. You want to highlight that to me?
Yeah, sure. Thank you for that question. So I won't name the insurance company, but there wasn't a specific insurance company that put out a bulletin stating some rate changes and starting October 1 of 2024, and that identified there was a small increase in some of the individual mental health session reimbursement rates, but it was a 22% decrease in what is the code that we use, 90847. And that code is used for all family, couple, parenting, co-parenting, family reunification, divorce mediation. Basically, anytime you have more than one person and you're not treating one specific person, you use 90847, and that reimbursement rate was cut 22%. And obviously that hit marriage and family therapists hard. We are not the only therapists that do systemic care, but we primarily do systemic care. And I know from my practice itself, I really had to start thinking about how many systemic sessions can I have in a week and still buy groceries. So like I said, we're getting, hit financially so many different directions. And then we get a 22% decrease in our most consistent treatment code. And there's absolutely nothing we can do. There's absolutely no negotiation that is available to us.
Yeah.
It's either you are in network and this is your rate, or you choose to go out of network, which unfortunately so many providers are continuing to do.
If you'll pardon my interruption.
Yeah.
So that's basically, you were stealing my thunder. Because
I'm sorry.
No, don't worry. I'm trying to figure out, theoretically, if you believe in the free markets, you believe that the reduction in rate is because the market's getting flooded with practitioners who are using the insurance company and have decided they can reduce rates and maintain coverage. But if I've got people going from in-network to out-of-network and I'm reducing the costs, I don't understand how you're going to solve the problem of people going out-of-network if you can start reducing in-network service prices. That's why I was trying to get to the question. Like, it's, to my mind, if there are, an extra 20,000 marriage counselors or family relationship specialists, I can understand why you can say I can cut the reimbursement by 10%. But if people are leaving the network and I'm reducing the cost, I'm actually driving people outside the network. So that's concerning to me.
Absolutely. And as I stated in my testimony, there's only just about 2,500 of us in the state to begin with, which in comparison to some of the other mental health providers that, engage in more individual-based treatment codes and treatment modalities, it's a fraction. So to kind of hit us, we're the little guys and you hit us so hard, that doesn't seem to be fair either.
Yeah, okay. So yeah, if you haven't put that, just, make reference to the coding and the pricing, if you would send it to me.
I absolutely will.
It warrants a question about network and out-of-network service. Thank you.
Absolutely. Thank you.
No further questions, Madam Chair.
Jamie, thanks for joining us today. Next up, we have Brooks Goodison, followed by Dr. Stephen
100 groups that are that we administer for, and that encompasses about 50,000 employees. And we primarily serve small to mid-size employers with some large groups in there as well. And again, like I said, we're in Marlborough, Connecticut, and we are a self-insured employer, and we cover about 75 employees on our health plan. We have provided written testimony. I'll summarize some of that here with you today. We are strongly in opposition of the Senate Bill 10. We oppose this, the act concerning health insurance and patient protection. We believe that it will significantly harm the affordability of health plans for small businesses, specifically around stop loss, increasing the stop loss deductibles from what the state minimum is now of 20,000 up to potentially 50. And I think I've seen another version of a bill at $75,000. I mean, that's a pretty drastic increase, about 250%. And then also raising the aggregate amount of claims that an employer is exposed to. Those also threaten the affordability of healthcare, and small businesses be able to use this tool to provide benefits. I think that, based on when I read through the proposed legislation, there seems to be some comments I'd like to make around stop loss specifically. I think it's important to understand that there is no requirement for a self-insured health plan to have stop loss at all. And they could go without it. It doesn't change. My point being, the stop loss itself has no bearing on the benefits offered. The plan itself decides what the benefit is, and they hire a stop loss carrier to come in and cover that plan of benefits. And that gets into a little bit of the risk of preemption issue that had been mentioned in some of the earlier comments. So the benefits are different below the stop loss deductible or above the stop loss deductible. The plan is the plan. All the stop loss does is come in and provide financial protection to the employer trying to offer a competitive set of benefits to their employees. And when an employer is forced to take more risk by increasing that deductible from, let's say, 20, in this case, to 50,000, that just puts more financial pressure for catastrophic loss on the individual employers. And we know that that financial pressure of increased premium and increased rates is what pushed these employers into a self-insured plan in the first place. And ultimately, if it gets too untenable here, it pushes them out into an uninsured and no coverage situation. So another thing I think that's important to know, a lot of groups self-insure, not just because it helps them to provide more custom benefits for their people, but
Your
because
3 minutes are up. If you could please summarize.
sure. Again, we're opposed to it. I've written testimony, and I think it's important to say that employers do this to offer uniform benefits across state guidelines. That's another reason why groups self-insure. Thank you very much, and I'm happy to take questions.
Brooke, sorry about that. I forgot to have my mic on. The last point that you were saying regarding groups self-insure to provide benefits across, did you say state lines?
Yes, I did.
Okay. Can you explain that a little bit for us?
Absolutely. One of the main intentions of ERISA, which was passed in '74, was so that employers who had multi-state locations, let's say they're headquartered in Connecticut but have locations throughout the United States, they had a desire to offer a uniform package across all state lines, so they had uniform benefits for all their employees. And ERISA, allows employers to do that without having to have individual different plans for every state in which they operate.
Okay. And so in your mind, putting the stop loss provisions that are part of this bill in place, we might risk these companies just not having the stop loss and like being exposed to any sort of catastrophic event across their employee plan, correct?
Correct. When groups are making a decision about whether to go self-funded or how to renew a self-insured health plan, they're brokers, they're consultants, and us, they're very focused on how much exposure they need to understand their risk and their financial exposure of what it costs so that they can put parameters around their plan so that they can set budgets and employee contributions and plan design. And stop loss allows an employer to put that liability in a box that they can manage and live with through the course of the year. Yes. Very important.
Okay, so then that kind of goes to the raising of the cost, because if they have this additional risk that the stop loss isn't covering, the employer and the employees would need to make up the difference, correct?
Absolutely. Yes, that's the only other way to deal with it.
Yep. And I mean, I think when I'm thinking about this and you and I are talking, I'm thinking of the larger companies that have employees that are across state lines. They might be a regional player in like the New York City area with employees in Connecticut and New York and New Jersey. But the small employers that are finding very few options in the market that are now going to level funded plans with a stop loss, to me, this takes away one of the only options that they have left. Do you feel like, am I on the right path with that thinking, that this is, really putting those small employers that have very little options left, giving them even one less option?
Absolutely. No question. Very
Okay.
limited.
Thank you, Representative Meskers.
I was going to have a similar question with a different focus. I assume that for a lot of franchise companies that offer health insurance, that they're doing multi-state insurance as well. So I guess that would create the same problem for any of the branded franchisees. They'd have to develop a Connecticut insurance plan if they chose to.
Correct. Maybe for some perspective, if you'll allow me, let's say the vast majority of our customers are headquartered in, let's say, in Connecticut or the Northeast quadrant of the United States, if you will. But those companies that are headquartered there, they have employees, and there are franchises in that basket of employers. They have membership people, belly buttons, we call them, in all 50 states. So those companies have people working for them on their health plans that are on the plans, living and working in all 50 states in the United States.
So that requirement would either force them to segregate out the employees or be compliant to Connecticut regulation, even though they might be a small percentage of their entire employee base.
Correct.
Okay, thank you.
I have one last question just on that train of thought. Are we now potentially removing these books of business from Connecticut if we apply stuff like this? I mean, why have an insurance policy here in Connecticut if we have, you know, these sort of regulations on them? I mean, are we at risk of that?
Absolutely. I mean, the list of the uninsured grows all the time, and I give employers, any employer that, I mean, let me say it this way. We hire, and we have a health plan because we would like to attract and retain employees. And if we can't do that, we're out of business. And I think most employers, that's their goal. They offer benefits to attract and retain their people, their talent.
All right, this was really helpful. Thank you for joining us and bringing your perspective.
Appreciate the time. Thank you, everybody.
Hold on, Brooks, we have one other question. Representative Mesker.
Yeah, on the last iteration, so the regulatory framework I'm talking about with the stop loss, that applies to policies underwritten in Connecticut or policy holders in Connecticut, you know?
Well, the way that it stands now is that the stop loss policies aren't obligated to cover state mandates. However,
Here's where I'm going with it. I wanted to ask the specific question where I'm drilling to.
Okay.
The policies now are underwritten in New York, presumably across multi-state lines. Even if I effectively put this policy in place, would that drive the underwriting activity outside my state? So that, I mean, in other words, can you encumber this regulatory framework on someone who has a self-insured policy who's now writing it out of state?
I don't know that I understand the question well enough to give you a proper
I'm thinking,
answer.
do I buy my policy, if I'm a tri-state company, do I buy my policy in New York and will I avoid that oversight? I'm worried about moving business out of my state.
Right.
Simple
I think
underwriting business.
insurance carriers, stop loss carriers, they do ask where the company is situs, where's their corporate headquarters. So and we have seen situations with other issues where it might motivate a customer to move their headquarters to another state so that they have a different place to situs their stop loss policy. That happens. It's not common. This could create more pressure to make that happen, for sure.
Well, if it's a multi-state employer who's got that issue, the question is, where do they want what instrumentation to move their headquarters, to do underwriting and move a policy out of the state and taking it out of our jurisdiction altogether, right?
Right. And I'm not aware of any state that requires state mandates to be covered by a stop loss policy in all 50 states.
Yeah, that's my concern. It's not only the impact on the insurance market. This takes me back to my role in commerce. Is what happens if we lose the line of underwriting of stop loss policies and of companies being encouraged to geographically relocate if it's deemed as being too onerous. Thank you. No further questions.
Thank you.
Thank you, Brooks.
My pleasure.
Next up, we have Dr. Stephen Thornquist, followed by Christian Damiano.
Can you hear me now?
Yes, we can.
Good. Sorry, Zoom is being uncooperative today. Um, I was intending to be there in person, but unfortunately I was held up, and so you get me by Zoom. Sorry. Good afternoon, Senator Cabrera, Representative Wood, and the distinguished members of the Insurance and Real Estate Committee. I'm Stephen Thornquist. I am a past chair of the Connecticut Society of Eye Physicians and currently residing in Bethany, Connecticut. I'm also speaking on behalf of both the CSEP, the Connecticut Dermatology and Dermatologic Surgery Society, and the Connecticut Urology Society, in strong support of SB 10 and Act considering health insurance and patient protection. For too long, the patients of Connecticut have suffered delays and arbitrary restrictions on needed care in the service of protecting profits of insurance companies. Insurers have placed hurdles in front of patients seeking care and burdens on physicians seeking to provide that care. These practices have been putting patients' health at risk, creating burnout, driving physicians out of practice, and making it hard to recruit and retain our younger colleagues. We say this with authority because we are on the front lines for these folks and see the frustration and despair every day. This bill addresses some of the more egregious tactics insurers use and begins to level the playing field for patients and physicians. I'll just highlight some of the salient features. It puts some teeth into the reporting of compliance with our excellent medical health parity requirements. According to recent data presented to the Public Health Committee just a week and a half ago, 4 of 7 reporting insurers are in danger of slipping into non-compliance with the rules, but there is no current penalty for failure to continue to accurately report compliance. This bill will provide a small penalty to encourage good faith reporting of compliance and the ability to audit. It will finally even the playing field for physicians trying to care for their patients by shifting the presumption of medical necessity to the doctor caring for the patient, requiring the insurer to show the needed care was not medically necessary. Fighting unjustified denials to prove medical necessity is exhausting for patients and physicians and wastes valuable resources that could better be used healing and reducing burnout. The fact is we are seeing between 15 to 20% of our prime physicians retiring early. This alone should be alarming, but equally important is that the remaining independent physicians have few options for new partners or transition of care for their patients. Connecticut is currently the 47th out of 50 in retaining physician trainees into the state. They all go outside of the state. Why? Because the practice environment here is terrible. Sadly, many are forced to consider employment in large health systems or private equity, which have been shown to raise the overall cost of care. This bill will add much needed relief from some of the tyranny of step therapy, which requires a patient to fail lesser treatments before receiving the ones that the physician knows are more likely to be successful, but the insurer feels may be more costly than they prefer. This tactic shackles a physician's practice and delays proper treatment. In addition, it creates unnecessary layers of costly administrative work and forces collection of high deductible premiums by physicians who have not created these high deductibles. This bill further prohibits the error-prone use of artificial intelligence to deny claims and treatments and to determine medical necessity. We applaud the pushback on this misuse of a nascent but as yet developing technology. We would ask that you consider adding a requirement to disclose any use of AI in patient care decisions or interactions with patients or physicians to allow for a default option for human interaction. Additionally, SB 10 provides potentially life-saving prohibitions against arbitrary and dangerous limits on intraoperative anesthesia. We have begun to see these reckless attempts to hold on to even more of the patient's premium dollars by baselessly deciding not to pay for anesthesia after an arbitrary point, potentially in the middle of a surgery. There is absolutely no valid medical reason for such a decision. Yale researchers recently noted in the Journal of American Medical Association that insurers are directing ever larger portions of their premiums to shareholder dividends and share buybacks, not to patient care. Utilization of healthcare is not generally discretionary and is sporadic in nature, making insurance necessary to distribute the cost over time and population and not functionally discretionary. Patients pay for the insurance they need to cover.
Please summarize. Thank you.
SB 10 offers a lot of help to patients seeking the care they need and to physicians fighting to provide it for them. Please support SB 10.
Thank you. Senator Anwar.
Thank you, Madam Chair. Thank you, Dr. Thornquist, for your testimony. Dr. Thornquist, can you speak a little bit about, as an eye surgeon, if the anesthesia option that was being just promoted by at least one insurance company that they were going to stop the anesthesia, what would that do to the patient if the anesthesia had to be stopped?
Well, since I did pediatric eye surgery, it is I am required to use general anesthesia. Much of cataract surgery is not done under general anesthesia, and so there is a lesser impact on the cataract surgeries, except in those patients who are unable to tolerate a lighter sedation and require anesthesia. A cataract case would typically be shorter than the limits that most insurers have attempted to impose, but my surgeries on children sometimes often last an hour or more, depending on how complex they are. Depending on where they put their cutoff, I could be in the middle of a case and suddenly the patient and their parents would be required to pay full price out of pocket for the anesthesia for the remainder of the case. I'm not going to certainly pay attention to any arbitrary limit when I'm in the middle of a case. I'm going to finish the case as it is. But it's an unnecessary impediment to proper care and an unnecessary worry for patients and parents who already have enough to worry about when their child is under anesthesia.
Thank you. And in your career, have you seen such level of heavy-handedness coming from the insurance companies to just, in the middle of the situation, just come up with these new rules, make it more difficult with the prior authorizations or other mechanisms to restrict care? Have you seen the pattern change in the last few years?
Yes, it's gotten much worse. They've gotten much more intrusive. They put limits much more arbitrarily. There's many more steps required to reverse the decisions, and it takes a ton of time. My practice, I just recently retired, but my practice that I was in employs 7 people simply to handle this much, all of this stuff coming down from the insurers, the delays, the tactics, the dotting all the I's for them and crossing all the T's, the going back because they decided they just didn't want to pay that claim this time. And then on appeal, almost all of the prior authorization claims that they ask for more information on are in fact approved. And so, I mean, it's a ridiculous system. It just allows them to sit on the float for longer.
Thank you so much. And in this building, we worry about cost of healthcare. By having to have 7 people just work with the bureaucratic process created by the insurance company, did that increase the cost of providing care to the patient?
Absolutely. It's money we couldn't put into providing care to patients because we were providing care to insurers instead. It's a waste of time and money on everybody's part, except perhaps for the insurers. And I just want to get to one other thing. Representative Mesker was talking about keeping businesses in Connecticut. Physician practices are businesses. We employ over 105,000 people across the state. If you're driving us out of this state to go practice elsewhere, you're not only hurting the patients who are here, you're hurting the economy.
Thank you so much. Thank you for your testimony. Thank you, Madam Chair.
Thank you. Representative Meskers.
I want to thank you for your commentary. I assume you were suggesting to me that I need to pay attention to the issue because it would drive people out of the state business, right?
I mean, yeah, it is driving
Okay,
doctors out of
excuse me.
business.
I appreciate that. I want to assure you that my concern is keeping business in the state. And so I don't think you need to worry about that. I was going to say this, and it wasn't meant in levity, but I think the problem that I hear in the discussions in artificial intelligence is the fear, rightly or wrongly, that artificial intelligence is going to be used to create more barriers, more screening, more denial of care. And if we get to deploy artificial intelligence or look to permit artificial intelligence, it's logical to go the exact opposite route, which is I want to see that the applications through artificial intelligence are accelerated, that the approval or denial is accelerated, and that they explain the targeted goal on denial of care. Because I do believe that the issue of accelerating the approval of care and monitoring it, whether it's by, right now, the problem with human intervention is it hasn't been too good in terms of letting humans intervene in insurance approvals, because what we're talking about is denial of care, right? So I'm not sure if I want to use a machine or a person, but to make them responsible to create the right metrics to make sure that approval of care is not habitually denied, and make sure that that my medical profession isn't hiring 7 people. So we're at some point, you and I are more aligned than you think. I'm just not sure making the same problem you have of putting more people on the line to process a claim that gets denied. I probably have a number of people on the other side denying. So if I put artificial intelligence to make the system flow faster and the approvals go higher, I think we reach an area where neither the physicians are expending absurd amounts of money for processing claims, and the insurance company isn't using money to deny claims. So I'm not against. I'm more neutral on the use of artificial intelligence, but only from the extent that it's not utilized as another weapon or another method to deny coverage or deny accessibility. I think anything we can do to automate the process and that reduces the workload. And if you had been, I don't think you heard the prior commentary where I had people who were doing counseling, and it looks like, more counseling goes out of network, and that's concerning to me. And they commented on 2 or 3 hours to apply to get rejected or accepted for the services rendered. I mean, I don't need counselors who charge $200, $300, $500, whatever they charge an hour, to spend 3 hours applying to get reimbursed, because then they go out of network. So I'm looking at efficiencies, and I hear your commentary, which sounds like you were under siege at some level with 7 employees. I don't think that makes sense to me either. So
No, I would agree. I didn't mean to single you out. I was just, you had shown an interest in that, and I wanted to point out that we are a business too, and we have employees in the state, a lot of them. And frankly, we need to stay in the state too for many reasons, not the least of which is that it keeps business in the state. So
Well,
actually, I think we are well aligned.
No,
And
good.
I think that my issue with the AI in particular right now is that it's not ready for prime time. It hallucinates regularly. It depends very much, because all large language models are very dependent on the algorithm that has them searching through language, and also on what they're trained on. And the database they're trained on is absolutely opaque. All right. We don't know what the insurers.
I wouldn't disagree with the automation of the system to streamline and make more effective payments, to reduce the drain on manpower is where I'm going on that. But notwithstanding that, I understand the concerns about artificial intelligence. And you're right. I am as deeply concerned about your profession as I was about the other people who tell you about the regulatory framework that prohibits them getting paid and staying in the business. So I want to drive costs down. I want to get the providers paid. And I need the insurance companies to, if they're going to use technology, it's got to be to take the back office away from the applicant, or to resolve the back office issues. I don't want to hear from an eye surgeon who has to have 7 people processing claims. I can't imagine a more Orwellian experience. So I appreciate your commentary.
I appreciate your commentary as well. Thank you very much.
You're welcome.
Thank you. Thank you, Representative Meskos. Steve, how are you? Hope you're doing well. It's good to see you again. You alluded a little earlier on about your experience with prior authorization, and I'm sure you know when prior authorization came to be as a practice from the medical industry and insurance companies many moons ago, way before my time, it was seen and often operated as a cost-saving measure because of lots of waste in the system, if you will. What do you see now in terms of your experience with these tools? You and I have spoken before, and one of the oftentimes struggles I have is being able to deal with making things more affordable in the health insurance space, but also seeing tools that oftentimes do the opposite of what they are intended to do, which is efficiency and lowering costs. What do you see this in terms of how your experience is with artificial intelligence, and then also, your experience with prior authorization and your concerns with artificial intelligence that you began to discuss?
Well, prior authorization, as it has come to be practiced, is the opposite of efficiency in medical care. It is a way to slow down and delay care and to try to drive it into to basically it's the prior auth itself outside of step therapy is simply just a delay tactic. It doesn't I mean, at one point, if you look through the history of prior authorization, I think it was Blue Cross Anthem in Texas about 15 years ago, I want to say, actually realized it was costing them more to do prior authorization than they were saving from it. And they announced they were going to backtrack on it. And they got hit with such a backlash from the industry colleagues that they reinstated it again. It is simply a way of slowing care down, because if flow of money, if you're holding on to it longer, you can get more for it. You get more interest out of it. They do occasionally deny care that it was maybe not as efficiently planned as it was intended to be. But in point of fact, since prior auth approves 97% or more, depending on the provider, of the claims that are appealed when denied, they're obviously not doing a great job with prior authorization in picking out care that is quote unquote wasteful. And I think it's a real problem that we've begun to just try to make things that might be expensive for insurers something that we have to ask permission to do. The focus has been so long on trying to cut out, quote, waste or fat from the medical system. The problem is there isn't any. Certainly little when you started and none left. You're cutting muscle and bone now. And all you're doing is making patients suffer and wait and fear that something bad is going to happen until someone at the insurance company listens to enough Mother May I's to give them the care that they need. It's not fair to the patients. It's not fair to my patients' parents. And it's not fair to the system, frankly. It just wastes a lot of time. And it delays care that could be much more expeditiously given. I have never understood why inserting another person in the middle of a procedure makes it more efficient than just simply making the decisions and going with it. Don't even get me started on the pharmacy benefit managers, but I guess that's my point on this, is that it's not efficient, it is not effective, and since they reverse most of their denials anyway, maybe we should rethink the whole process.
Thank you.
As far as AI goes, I think it could streamline the process if it could be shown to work. The bigger problem there is, again, frankly, even without the AI, the criteria used for making their decisions are not clear, not published, and not reviewable. It's very hard to figure out why they said no. They are starting to report some of that now, but even then, it's often sketchy. We don't know what their algorithm is for making a decision, and that would be nice to see.
Got it. Thank you, Steve. I appreciate that. I think Senator Anwar still has his hand up again. Senator Anwar?
Thank you so much, Mr. Chair. Thank you again, Dr. Thornquist. I think your earlier conversation wanted me to highlight and ask you some clarifying questions. It's no secret that Cigna Insurance, which is an insurance company that is in Connecticut, has a Connecticut presence as well. And this was identified that they were denying claims every 1.2 seconds. And if you were working in the current era where the AI was being used for denials every 1.2 seconds, would 7 people be able to take care of your ability to function as a healthcare facility? And how many more people would you need if that was going to continue?
Probably at least another 7, to be honest. I have to tell you that because now it's denial on steroids, right? I mean, it is just supercharged. And this is part of the problem with AI is theoretically, those AI decisions are being reviewed by someone, but every 1.2 seconds, how can someone competently review a new case every 1.2 seconds? They're not reviewing them. And that's a real problem because I don't have an AI system to appeal it with. And that's not coming down the pike that I know of. So I have to spend actual human hours and actual reasoning power trying to figure out what it was they decided, why they decided it, and then appealing back. So it's actually putting all the work onto the practices and the patients. And this can be devastating for a patient who's been told they need a procedure and now they have to wait. I mean, think about being told your child has to wait longer for a needed procedure because someone at the insurance company decided that they wanted to hold on to the money longer. I mean, that's a pretty difficult thing for patients to put through. Now, don't get me wrong. I mean, insurance is business too, right? They deserve to make a profit, But at some point, if the industry's making over 140 billion a quarter, maybe they could spend a little more time on patient care and a little less time on denying it.
So, and can I just push you back gently about one of the statements that you made was that, look, the insurance companies will improve on the AI technology. If we do not, even if we remove the AI out of the picture, the criteria that the insurance company has used for denial has been increasing. And when the clinicians fight them, they are able to win them because they do not have legs to stand on. In overwhelming majority of the time, it's a delay tactic. It's a denial delay tactic. And so when they're without technology, they were moving in the wrong direction. Now with the technology, with the algorithms that they have, the PXDX and the algorithm that we've heard about, that is going to not make it better, even if they learn, because the purpose is not to do legitimate evaluation. It's basically denial and delay tactic that is being used, at least historically.
No, I would agree with you. And I wasn't meaning to imply that the insurers should develop an AI that's better for their purposes, because it's already bad enough. The problem is that AI itself is prone to errors and hallucinations. And until until the base system is improved and someone who's not simply trying to drive their profit up is designing the system, until those algorithms on which the decisions are being based are publicized and transparent and known, so you can understand why they're making a decision. Until that happens, then AI is just speeding up an already bad process. And I agree with you on that. I wasn't meaning to imply that I want the insurers to develop better AI. I want AI to develop more and be better before we start employing it in life-saving or life-denying roles.
And last question, if we do not intervene at this time, and the denials continue at a rate of 1.2 seconds, would that be the end of legitimate healthcare if there's no intervention made?
Well, then practices are going to start to be spending a lot more time and money on getting claims processed and appealed than they can on patient care. And that's an inversion of the way patient care should be delivered. I mean, you want more care for patients, more readily available at a lower cost. Stop increasing the back office costs. Stop increasing the overhead. Start making it easier to practice, not harder. And then you'll start seeing more physicians per population, and also just better care for everybody. And if we're not spending hundreds of thousands of dollars on getting paid, we can spend that money on delivering care.
Thank you. I agree with you. This is almost an existential threat for healthcare, as AI is not being used for the right way by one industry specifically. But I'm sure this is the industry I see, but I can tell you that perhaps other industries will do similar things. But I wanted to thank you for your testimony. Thank you, Mr. Chair.
Thank you.
Thank you, Dr. Anwar. Are there any more questions from the committee? Seeing none. Thank you very much, Steve. Good seeing you.
Thank you, Judge.
Up next, we have Christian Damiana. Hey, Christian.
Good afternoon, Senator. Representative Berry. Thank you for having me today. My name is Christian Damiana. I'm the Public Policy Manager at Mental Health Connecticut, which is a direct care and advocacy organization. I'm privileged to lead the Connecticut Parity Coalition, which is a group of more than 25 member organizations working to improve behavioral health equity in our state. Our members span everyone from the Connecticut Psychiatric Society and Psychological Association to the Connecticut Nonprofit Alliance. So we're a very broad group. And we're here today in support of SB 10, specifically sections 1 through 4. I would encourage you to please read my written testimony. It's 6 or 7 pages, but it goes into a lot of the things that have been talked about during today's hearing, many of which I think do need to be addressed. I'll start by talking about that there was very broad support for parity reform in this state. Our original plan, which was incorporated into Senate Bill 10, was endorsed by Comptroller Scanlon, who you heard from, the Attorney General, 63 state legislators. So that is 1/3 of all of your colleagues, a bipartisan group, and also the Connecticut Hospital Association. So very broad group in support. I'm glad to address what you've heard today. I think one thing that has come up a lot is that CID has said they have not identified violations of Connecticut's parity laws. I'm not disputing that they haven't identified them, but I think we need to talk about why that is. It's because of shortcomings in the annual NQTL reports and a refusal to look at data outside of those reports that signify potential parity violations. And so it's not just my opinion. Insurers are violating the law. And someone who I think might be influential said that recently, which was Attorney General William Tong, and he said, the insurers are violating the law. So not my opinion, not our coalition's opinion, but the state attorney general's opinion. Now, how are they violating the law? There are many different recent studies that signify potential violations of parity. The most important of which I know you've heard about a lot today, is the Office of Health Strategy report, which showed that 4 insurers in Connecticut are meeting federal warning signs for parity noncompliance. And those insurers are Anthem, Cigna, Connecticut, and United Healthcare. And what meeting warning signs means is that they're systematically underpaying for behavioral health care as compared to medical and surgical benefits. And that is something that serves as a warning sign under federal regulations of a more egregious legal parity violation that would need to be investigated. And so we're asking, knowing that there are these warning signs occurring, please do an investigation to determine why. And it's not just us asking that. In the OHS report itself, OHS said that there needed to be further criticism, further investigation of why it is that 4 of these insurers are not in compliance. Now, I know that you heard today from some people that payment parity does not lead to a legal disparity. That is incorrect. It is baked into the federal regulations, the federal law, the state law. Very plainly, a payment parity violation can become a legal parity violation. And so that's something that I think is very important, and it's substantiated in quite detail in my written testimony. But one thing that shows that is the 2024 parity regulations issued by the federal government, which list out the NQTLs that might constitute a parity violation. And 2 of them, I think, are particularly relevant. The first, network compensation, which specifically includes determining reimbursement rates, and then also ones for methods for determining out-of-network rates. So literally, payment parity is baked into the federal regulations, the 2008 law, the 2013 update, the 2024 regulations, and Connecticut state law. Yet, we should ignore that 4 of 7 commercial insurers in Connecticut may be violating our law because it's not contained in these NQTL reports. Another thing that folks have mentioned is that there is an existing authority for the insurance department. That's true, there are 2. The first is for them to fine $1,000 for violations of group plans, not much of a deterrent. And the second is a general penalty for them to fine $15,000 if they violate any law in the title. And I think all of us know that a $15,000 fine is meaningless to insurance companies who are continually reporting billions of dollars in profits each year. So it's clear.
3 minutes are up.
Thank you.
Please summarize.
So we're just asking you to take action to build on what was a unanimously passed effort in 2019 to protect people's behavioral health access and make sure that we're following the law as it's written in Connecticut, as the legislature intended for it to be followed in 2019. Thank you.
Thank you very much for your testimony. Any questions? Representative Barry.
Thank you, Mr. Chair. Thank you, Christian, for being here. So earlier we heard from Mr. Burr about attendance, getting appointments, and how would this bill help with that situation that he detailed earlier?
Thank you, Representative. So I think it relates sort of like you have these payment parity violations, which are leading to inadequate networks, which is a legal violation, an NQTL violation. And those inadequate networks are the reason that folks are, in part, one of the reasons folks are having trouble finding providers. And so this is one part to make sure we're following what our federal and state really anti-discrimination protections to make sure that people can access the care that they're already entitled to.
And you were talking about payment. That's already in state law?
So yes, payment parity leads to a legal NQTL violation under the federal statute, the federal regulations very explicitly, and also Connecticut state law, which is something that the Attorney General has attested to and something the state comptroller has also confirmed.
Okay, thank you.
Thank you.
Thank you, Representative Barry. If there's any questions online, I don't see any. Christian, thank you so much for coming today and sharing your expertise with us.
Thank you,
Appreciate it.
Senator.
Up next, we have Liz DuPont. I'm not going to attempt the last name. How are you? Good. Thanks for joining us. Floor is yours. Floor is yours. You're welcome.
Good. Okay. Good afternoon, all the distinguished members of the committee, both here and remotely. I am Liz DuPont Deal. I am the Associate Director of the Connecticut Citizen Action Group, or CCAG. Thank you for the opportunity to testify before you again this year and for your consideration of SB 10 and concerning health insurance and protection. For once, I'm not including links to studies or reports in my written testimony. Today, I want to focus on how extremely broken and dysfunctional our healthcare system has become. CCAG has recently hosted meetings with citizens over the last year to hear their healthcare experiences and to share some of the trends behind what too many of us are experiencing. In 2021, when 5 health insurance companies tanked a public option here in Connecticut that would have included thousands of small businesses and nonprofits in the state's health insurance plan, CCAG began researching and reporting on their excessive greed and profiteering. Over the last 50 years, market forces have been the driving forces in how our systems have developed. And by market forces, I mean stock market forces, not market forces. Hospitals, pharmaceutical industry, and for-profit health insurance industry like to all blame each other. The truth is that each of them have morphed into entities none of our grandparents would recognize, diverting billions of dollars from healthcare to profits for shareholders, stock buybacks, executive pay, lobbying, and marketing. Most of them are utilizing significant public funding to subsidize research and coverage, and this investment is only minimally, if at all, shared with the public. I also want to reference some testimony submitted by Deb Daphnes, a CCAG member and small business owner, who testified and said, basically, patients need protection from a system that is now designed to minimize care. Even people who have health insurance routinely struggle for routine and life-saving care, pitting them against their doctors as insurance companies routinely deny claims, utilizing AI to do so very often. News coverage and social media have recently exploded with outrage as people around the country have shared these stories. SB 10 contains many good provisions which meaningfully address some of the worst impacts of our greed-driven healthcare system, such as requiring parity and coverage of mental health and substance abuse treatment, shifting the burden of proof to insurance companies in denying claims, and including affordability as a consideration for the insurance department in granting insurance rate hikes. CCAG supports and will also ask that the committee further strengthen bans on claims denials and demand greater transparency around vertical integration schemes such as pharmacy benefit managers. I also want to take just a moment to acknowledge and address the opposition to SB 10 from business and ask that we consider it against the system of greed that drives our healthcare. No employer should continually have to absorb double-digit rate increases for continually declining coverages. My colleagues in the nonprofit world are bone weary from the annual struggle with rising premiums, which have forced their employees to pay in more and change healthcare providers when they don't want to. Nonprofits are employers, and as well as other employers would have benefited from the public option that the cynical insurance companies tanked. For more than 50 years, CCAG has worked to make Connecticut a more fair and just place. I testified today on behalf of our thousands of members and their families throughout the state. We want to thank SB 10's many co-sponsors for bringing these critical matters forward. CCAG and our members will continue to fight for quality, accessible, and affordable health care for all people. Thank you for your attention and consideration. I welcome any questions.
Thank you. Thank you for testifying today. Any questions from the committee? I don't see any online. Thank you so much for coming today.
Thank you.
Up next is Laura Hoke. Hoke. I got that right. Thank you, Laura. Hoke. Got it.
Senator Cabrera, Representative Barry, and members of the Insurance and Real Estate Committee, I appreciate the opportunity to testify today in support of SB 10. Specifically, I'm here to talk about the utilization management sections of this bill around prior authorization and step therapy reform. My name is Laura Hoke. I am the Associate Vice President of the National State Advocacy and Policy for the National Multiple Sclerosis Society. When someone is diagnosed with multiple sclerosis or MS, their clinician will typically prescribe them what is called a disease-modifying therapy, or a DMT. These are used to modify the disease course, to reduce relapses, and manage symptoms. Growing evidence indicates that early and ongoing treatments with these DMTs is the best way to prevent the accumulation of disability and protect the brain from permanent damage. Step therapy protocols transition medical decisions from a shared decision-making approach between the provider and the patient and toward a more standardized policy that focuses on cost-effective care. These policies may not take into account detailed conversations between healthcare providers and patients as they discuss the right medication for each person. Those considering factors could be efficacy, dosage, route of administration, and side effects. All this is why we are so glad that about 10 years ago, the General Assembly took the first steps in reforming the step therapy process. Now, SB 10 creates much needed next steps in patient protection, shifting the burden of proof in utilization management from the provider and patient to the health carriers helps to guarantee the decisions are truly being made in the best interest of the patient. At the time of prescription, the provider and the patient have already discussed at length the various options for DMTs and have identified what drug will work best for them. The provider has prescribed a specific medication because it is medically necessary. Forcing the provider to go back and offer additional proof delays treatment for that patient and takes time that we better spent treating additional patients who are not receiving care because of the time spent on these practices. If the health carrier feels that the drug is not medically necessary, despite a provider's indication otherwise, it should be the responsibility of that health carrier to prove their claim. This legislation additionally would eliminate step therapy for individuals living with a chronic illness that is either disabling or life-threatening. This would be a critical protection for people living with MS and other similar conditions, which, when left improperly treated, can be extremely disabling. Someone who lives with MS will have it for the rest of their lives, and they'll be taking DMTs for the rest of their lives. These medications are not interchangeable. When someone finds stability on a medication, it is critical to their health and safety that they remain on that medication uninterrupted unless that drug becomes contraindicated. The threat of facing step therapy as a result delays in treatment at any point in the MS journey could lead to serious disabling events. The society urges this committee to JF SB 10 to the floor of the Senate and protect those living with MS and other chronic conditions in the state of Connecticut.
Thank you very much. Are there any questions from the committee? Seeing none. Laura, thank you so much for coming
Thank you.
today. Up next, I think online is Stephen Gilbert. Gilbert, where's yours?
Yes, yes, can you hear me?
Yep, I hear you.
Yes, good afternoon, everyone. Thank you for the opportunity to speak. My name is Stephen Gilbert, and I'm an employee benefits consultant with Assure Partners. I want to echo what was said by CBIA and other consultants.
Stephen,
Most of Sector 10,
can you hear me?
Sorry?
You're coming in a little muffled. I'm assuming it is.
Sorry.
System. Try it again.
All right. Most of Senate Bill 10 will address problems in the state. Section 10, however, will not. Proposed changes to stop loss would substantially increase costs, limiting options for employers, specifically small group employers. This is very important. There's thousands of small group employers in the state, and about half of them are on this funding strategy. Small group employers will be left with a few difficult options. Pay the increased costs, which is expected to be around 20%, eliminate offering coverage and sending their employees to the individual market, or go to a fully insured plan. Over the past few years, there's been an exodus within the small group fully insured market, leaving only 2 carriers left, resulting in increased premiums. For most employers in the state, insurance is the second highest expense. This would potentially limit options for employers if they're looking for more. Thank you for your time. I'm open to answering any questions.
You came in and caught most of that, but just so you know, it's a bit muffled. So I'm sure you have some written testimony we can look over as well. I don't see any questions. So thank you for your testimony, and we look forward to seeing anything that you have that you can submit written. Thank you.
Thank you.
Senator Looney, how are you, sir?
I'm well.
You're right on time. Welcome, sir.
Thank you. Thank you. Thank you. Good afternoon, Senator Cabrera, Representative Barry, Representative Wood, Senator Wong, and Representative Pavlock D'Amato, all distinguished members of the Insurance and Real Estate Committee. My name is Martin Looney. I represent the 11th Senatorial District, parts of the city of New Haven, and the town of Hamden. And I'm here today to talk about Senate Bill 10, an act concerning health insurance and patient protection. 6 years ago, in 2019, we passed a mental health parity bill. As many will remember, in fact, we had a large celebration upon the passage of that bill. with former U.S. Representative Kennedy, Patrick Kennedy being here for the event, a former congressman from Rhode Island, talking about how transformative that would be. Unfortunately, in the 6 years since then, there has been a great deal of resistance to the implementation of that. And we hear all the time that there are still tremendous disparities between coverage for mental health and coverage for physical illnesses. So the bill has not been implemented in the way that we had hoped, the way that we had intended. There's been foot dragging and evasion. And what this bill will do is provide some penalties for noncompliance. So after the passage of Public Act 19-159, it was unanimous in both chambers, but we are hearing from healthcare providers overwhelmingly that the field is still not level. So sections 1 through 4 of this bill gives the insurance department authority to fine insurers per insured for a policy that violates a mental health parity law, or if the insurer fails to meet reporting requirements. So this is giving teeth to the law. It's unfortunate that we have to do this follow-up, but there has not been good faith compliance with the law we passed 6 years ago. Another important section of the bill deals with our continuing issues over prior authorization and utilization review. As we know, prior authorization is used by insurers, as they say, to avoid unnecessary costs, but has been used in many cases to slow down necessary treatment, provide a tremendous amount of administrative burden for physicians and their staff, and that leading to burnout of doctors leaving the practice. And so sections 5 and 6 of the bill creates a presumption that care prescribed by an attending healthcare provider is medically necessary, and it places the burden on the insurer to prove that a service or drug is not medically necessary. And this makes sense because of the fact that all of the information on which the decision is based is in the possession of the insurer, and they ought to be able to justify the reasons for a denial. Sections 18 and 19 prohibit insurers from placing an arbitrary limit on general anesthesia or other care that arises during authorized services. There was an uproar earlier this year when one insurance carrier talked about doing just that. Putting limits in terms of time that anesthesia would be covered for different procedures. As we know, complications and unknown issues arise in surgery, so that was really an alarming proposal that we think should be banned. Also, in 2023, the General Assembly narrowed the permissible uses of step therapy, reducing a permitted trial period from 60 to 30 days and prohibiting through 2026 step therapy altogether for drugs that treat schizophrenia, major depressive disorder, or bipolar disorder. But this fail first policy used by insurers should be scaled back even further, given the terrible suffering that some experience when forced to endure multiple 30-day steps. So Section 7 and 8 of the bill shorten the trial period to 20 days and expand the prohibition on using step therapy to drugs that treat any disabling or life-threatening or chronic disease or condition for any mental health or behavioral health condition. So one of the dramatic instances of this, a couple of years ago, there was a child suffering from juvenile rheumatoid arthritis. His treating physician recommended a drug. The insurer would not cover it, insisted that he go through a 60-day trial on something else that his doctor had no real confidence in. The child suffered greatly during that time, was bedridden, most of it. Finally, after that long period, he was given the drug that, or something close to the drug that the doctor had initially recommended, and within a week, the boy was much better, was back on his feet. Unfortunately for the insurance company, his mother was a reporter for the Wall Street Journal, so she was able to document everything that her son suffered by that step therapy requirement. Another section of the bill, Section 9, would establish site-neutral payment policies in Connecticut for evaluation and management, current procedural terminology codes. And what we know that in some cases there's enormous additional prices for providing the same kind of service at a different location. We know in many cases that certain infusion centers cost much less than having the same infusion provided at a hospital or other location. So we believe that site-neutral billing would be something that would provide great savings. When it was first proposed back in 2015, one of the arguments against it was that that it was something that had never been implemented anywhere. But since then, the policy has been included by Congress regarding Medicare in budget deals since 2015. So it's now an established practice in that area. And then we have the issue of fair health insurance. A success of the Affordable Care Act was requiring fully insured health plans to cover essential benefits. At the time, self-funded plans were generally used by larger employers, had better coverage, so the ACA did not require essential benefits be covered by these plans. But in recent years, many small employers are dropping their fully insured plans for self-funded plans. So Section 10 of the bill would permit any employer to use a stop-loss policy to insure against the risk of its self-funded health plan, but only if the plan covers essential benefits and state group mandates, and also the stop-loss policy meets newly revised attachment points. And lastly, the sections 11 to 17 of the bill will allow the insurance department to adjust a filed rate for health insurance based on affordability, adds affordability as a criterion for considering the appropriateness and suitability of a rate. So again, these are the components of this bill. It's an important initiative. I want to commend the committee for taking it up for consideration and urge your approval.
Thank you very much, Senator Lee. We appreciate very much your leadership on this issue. Are there any questions for the committee? No? I have, first of all, thank you so much for your leadership on these issues. We've heard lots of testimony today, and it always comes back, as you know, to cost.
Yeah.
And a lot of times, I think lots of folks are concerned about some of the things we're doing in SB 10 as increasing costs. I was wondering if you could speak to that a little bit and where you're coming out from this, and what would you say to that?
I think that anything that produces improved health outcomes ultimately is cost effective. And that if you improve the general health of the public, there is a cost benefit in that in the long term. And I think that's the view that we should take a long view on this, and that anything that enhances patient care, anything that makes physicians who are the experts in these areas more effective in the treatment of their patients in a timely way. We know that step therapy and prior authorization sometimes delay needed care. So the situation is actually more complex and more expensive to treat by the time the approved therapy is finally approved, but precious time has been lost. So I think that rather than being something that would be a cost burden, ultimately, if you take the broad view of all these things, there is a cost savings by providing enhanced appropriate care at an earlier time.
Thank you for that answer. I appreciate it very much. I don't see any other questions. Thank you very much for taking time out of your busy day to come join us.
Well, thank you so much, Mr. Chairman. Thank you for all of the important work that this committee is undertaking.
Thanks, sir. Have a good day.
Thank you.
Up next is Loretta J. Hi, Loretta. How are you?
Hello, Senator. Senator Cabrera, Representative Barry, Representative Meskers, and distinguished members of the committee. Thank you for this opportunity to testify in support of SB 10, an act concerning health insurance and patient protection. My name is Loretta J. I'm a special education advocate, and many of the families I work with have children with behavioral health needs. I have seen firsthand how the failure to enforce mental health parity laws leaves families without care, drains them financially, and harms their well-being. The committee already heard testimony that our residents are private paying for mental health care much more frequently than physical health care. And I'm pleased that the committee acknowledged that inadequate payment interferes with access to mental health care. However, I respectfully disagree with the assertion that inadequate access is not a legal parity issue. My written testimony digs into some of the reasons for this and includes some stats as well. The 2019 parity law requires commercial insurers to report on these problems. Now it is incumbent on us to make sure that the law is enforced. This winter, one of my clients and I contacted 27 in-network providers, but none was accepting new patients. Her daughter remained in a higher level of care longer than necessary at great emotional and financial cost. She deteriorated, experiencing suicidal ideation. In desperation, Her mother took 3 weeks off from work just to find a clinician. My clients are not unable to find primary care providers or specialists, just mental health providers. This is a legal parity problem. Another family seeking residential treatment for their child was charged a $1,000 admission fee that did not count toward their deductible or coinsurance, then had to pay another $1,000 when their child was readmitted. These unnecessary financial burdens add to families' distress, but there are no admission fees to enter a hospital or a physical rehab facility. This is also a legal parity problem. Insurance companies also impose arbitrary restrictions, such as denying coverage when a family has 2 therapy sessions on the same day. For instance, a child's individual therapy and a family session, each with different service codes. We would never tell someone they cannot see both a cardiologist and an ENT on the same day, yet insurers impose this barrier on mental health care. This is again another legal parity problem. The 2019 parity law was a bipartisan success, but without enforcement, these legal parity problems continue. SB 10 provides the tools necessary to hold insurers accountable and ensure families receive the care they are legally entitled to. I urge you to pass SB 10 so Connecticut residents are protected from this unfair treatment. Thank you.
Excellent. Thank you. Thank you for your perspective. Representative Muskers.
I'm familiar with the challenge because I faced the challenge of in-network providers. I've been running between various committees today, so I'll ask, I'm trying to conceptually understand in-network, out-of-network, and parity. So does it become the responsibility of the insurance company to maintain an adequate list of available mental health specialists?
Yes, it does. I think that
Okay.
Christian did an excellent job summarizing how the parity laws are existing already, but it does.
Perfect. I was literally listening to you and I was like, where are we going with this? And that was it. So the trigger on this is to put liability on the insurance companies that they have a robust list of providers who are actually available for service.
Yes, sir. I pulled out a bunch of my testimony and moved things around today because I didn't want to repeat what others were already saying. But the problem is that the lack of adequate payment, as well as the burdensome paperwork, the frequent denials for unjust reasons, are pushing people out of the system.
Yeah, I guess, so that would be, and this will be anecdotal and I expect in the answer. How would you, I'm trying to weigh that balance because I'm always worried about cost and premiums, right? How much of the out-of-network experience do you think is a numeric relationship to the reimbursement rate? And how much is it the fact that I might spend 2 hours wrestling with a reimbursement claim, and I'd rather go cash only or deal outside the network because I don't have to apply for the reimbursement? Would you have any rough guesstimate of?
Sure, I think it is both.
Okay.
In my written testimony, I have some examples where I've spoken with some providers where I've included information. I think there's a combination of people cannot pay their bills with what they are getting reimbursed. I think that Jamie Rodriguez talked well about the lower rate for family or more than one person for care. For example, I've spoken with therapists who they have one reimbursement rate if they just see the child, but if they want to see the parents for that child for parenting sessions or for a family session, they're paid up to $30 or more less than that just for the one child. The whole family requires lots more case management. It's much more burdensome, but they're paid less.
But without I heard that story as well. So that'll be on my mind going forward. But you couldn't quantify how much is the level of reimbursement versus the hours to get the reimbursement. I mean, I'm sending professionals out to collect dollars on during their work hours or hiring someone to do it on the work hours. And so I'm trying to quantify if we could improve the process is the reimbursement rate less of an issue? You know, I can't figure out quantitatively which is the bigger crisis of the two.
I think they are both equally, maybe, I don't know if it's fair to say equally, but they are certainly both significant.
I was hoping you were going to give me one to go to. That's why I asked the question.
We'll do some research.
I'm gonna, that's something I'd like to look into. I want to figure out how to attack the process to make it better, but I appreciate it. No further questions. Thank you.
Thank you, Representative.
Thank you, Representative. I don't see any more questions. Thank you for your testimony.
Thank you all.
Up next, Dr. Imakula Khan.
Hello, my name is Dr. Immaculate Khan. Good day to Senator Cabrera, Representative Wood, I believe I missed her, and esteemed members of the Insurance and Real Estate Committee. My name is Dr. Immaculate Khan. I am the Chief Nursing Officer for Silver Hill Hospital and a member of the Connecticut Nurses Association. For over 30 years, with many clinical teams across many work environments, I have strived to deliver optimal psychiatric care to the people of Connecticut. But our people need access to our systems of care. Thank you for the opportunity to testify in support of SB 10, which will strengthen enforcement of Connecticut behavioral health parity laws. The 2019 parity law was a bipartisan success. Congratulations to all who worked on that. But without enforcement mechanism, it remains an empty promise. I strongly urge the Insurance and Real Estate Committee to pass SB 10 to ensure behavioral health parity is no longer just a promise, but a reality for all Connecticut residents. Mental illness is a leading contributor to social disruptions, from reduced employee job performance and family conflict to extremes of suicide and other violent behaviors. We must accept the validity of parity in the identification and treatment of those mental health barriers that restrict individual opportunities to success. Mental health is a precursor to physical health. Mental enables physical. From conditioned athletes to employees juggling the demands of work and family, to recently diagnosed cancer patients, to the quality of one's mental health, and importantly, ready access to evidence-based mental health interventions, our society is underpinned by a foundation of mental health. Others have presented studies, and I've heard a lot today, an analysis which document the imperative of assuring parity of access to our mental health services. Parity will assure our mental health delivery system is properly structured to meet the challenges. Peter Drucker, a management guru and author, once famously said, "What gets measured gets done." The evidence is there. It is past time to implement solutions to assure that our reality includes parity of access. I thank you for giving me the opportunity to come before you. I thank you for your time and your consideration.
Thank you, Dr. Khan.
Thank
Any questions? I don't see any questions. Thank you for your testimony.
Absolutely. Have a wonderful day today.
Thank you. You too.
Bye-bye.
Next up, Gigi Kobenpoo. Okay. Jennifer June. Susie Craig. No. Karam Guman.
Good afternoon. Thank you, distinguished members of the Insurance and Real Estate Committee. Thank you for the opportunity to testify on Senate Bill 10. My name is Khurram Guman. I am the current president of the Connecticut State Medical Society. I'm speaking today not just on behalf of CSMS, but also on one of the few remaining independent physicians in the state, trying to keep my small practice afloat in an increasingly hostile environment. For practices like mine, Prior authorization and step therapy aren't just frustrating, it is an existential threat. Every hour my staff and I spend fighting with insurers is an hour we are not seeing patients, managing complex cases, or keeping up with the clinical advances. The administrative burden is relentless, and the systems insurers make us use are intentionally opaque and time consuming. Section 5 of this bill would finally shift the presumption of the medical necessity back to the treating physician, where it belongs. Right now, the process assumes that my clinical judgment is wrong until proven otherwise. I know my patients, their stories, their history, their medical other conditions, but insurers often using automated systems or algorithms who can't possibly know my patients routinely second guess my clinical decisions. Prior authorization is being increasingly weaponized through the use of artificial intelligence. Insurers are now using AI algorithms that automatically deny care based on financial models, not medical judgment. These algorithms do not account for the human complexity of my patients, people with multiple chronic conditions, mental health challenges, or unique medical histories. When these denials happen, my staff spends hours chasing appeals. We simply the time we have to spend on these, we simply don't have in a small independent office. And Section 7, which reforms step therapy, is equally important. Step therapy takes a decision about what medication is right for my patient out of my hands and hands it to an insurer's cost algorithm. Patients are forced to try and fail on treatments I know won't work for them, wasting time and in many cases worsening their clinical conditions. For someone with a progressive disease or worsening condition, these delays can cause real harm. I want to be clear. I know that this committee can only regulate the fully insured market, that is about 25% of my practice. But a 25% reduction in administrative barriers would make a massive difference in my ability to remain independent. Right now, every dollar I spend on extra staff to handle these burdens, every hour spent on appeals instead of patient care, it all adds up. Independent practices like mine are drowning under these pressures, and many have already forced to sell hospitals or private equity just so they can survive. If Connecticut values independent medical practices and the choice we present for our patients, real reform is essential. Prior authorization and step therapy have become tools insurers use to grind down independent doctors who don't have the administrative armies the large systems do. Section 5 and Section 7 of this bill, Senate Bill 10, are lifeline for independent physicians, and they are essential if you want to preserve independent care in Connecticut. I urge you to support this bill and to recognize that reducing administrative burdens is not just about convenience, it's about preserving access, choice, and the ability for physicians to actually care for patients instead of spending their days on the phone with insurers. I want to thank you for your time and your consideration, and happy to answer any questions.
Thank you, Dr. Guman. Thank you for being here and advocating for your patients. Representative Meskers.
Since I can't tell how long you were waiting to get to speak, and it's been a long day, first off, I'd like to thank you for your testimony. I think it's important that your voice is heard.
Thank you.
And I'll tell you, I don't know where I sit on all the bills, but probably the piece that, as with my hat of commerce on, that resonates most is if I tie you up and gum you up with denials and applications and drain your resources to do that, I'm really driving you into a group practice or hospital-led practice, and I'm losing both the entrepreneurial and the relationship that an independent doctor gives his patients. And I can appreciate that dramatically because that was many years ago in the history of my youth, is that it was a family doctor. And now I keep on getting switched to a practice where I'm told I can see somebody in, 10 or 20 weeks, and it can be a rotating group of people. So I appreciate what you're saying. So I'm not sure where I sit on every bill, but the idea that we're going to, And I'll repeat what I said before. I don't know if I assume you were working and not listening to my cherished every word that I said. I think the issue that we're using artificial intelligence solely to block with algorithms and not using artificial intelligence to actually lift the burden on the application process for to qualify for reimbursement. So I think, you know, if I could speed the process, limit the workload on your side of the fence, and get you a better answer and get an answer quicker, and provide through the insurance company the artificial intelligence that that accelerates the decision into a better place, I'd be happy. But I think I hadn't thought of it before. The fact that you have to man up, as they say, with office hours and people to get your application in, and now the next burden that's coming through is artificial intelligence. You know, in and of itself, intrinsically, I'm not opposed to artificial intelligence, but if it's just another instrumentality to deny claims, I'm not happy. So you've caught my attention.
So, Representative, thank you for your acknowledgement. And if I may use a couple examples, may not fully be applicable, but I'm trying to share a concept. So imagine a 16, 18-year-old takes his or her lessons for driving test, takes a written test, practices the road test, completed the road test, has a privilege of driving issued by the DMV. The teenager takes a job, minimum paying job, gets the insurance for their car, and now one day that young teenager is eager to drive his or her car to the, let's say, local creamery. But imagine if that teenager has to pick up the phone and call his or her car insurance company asking, can I drive to the ice cream place today? And the insurance company says, no, it's raining today, it's snowing today, you cannot drive today, go there next week. Fair enough. The teenager was patient, calls next week, is allowed to drive today, but they tell him, you can go today, but you can only get vanilla ice cream, not chocolate ice cream. And also, you cannot drive more than X number of miles per hour. Now, I'm not sure if this is completely analogous to the medical practice, but young physicians who are going to medical school training to provide the top-notch evidence-based care to their patients in the communities that they will be serving, I am not sure if they will be given the opportunity to keep those communities healthy. And you mentioned about family physician. I am one of those family physician even in today's world. My practice is in a small town of East Granby. Our practice has been in that same community for 46 years and counting. My partners who started the practice, one of them is still in practice. And every single day we have this conversation is about how do we stay afloat and how do we stay independent? Because I know my community, we even know to the point where we are family physicians, so we see newborn and up. So we see pediatric patients, grown-ups, and adult patients. We purposefully leave appointments open on our schedules for the same day around 3:30, 4 o'clock, because we know parents will pick up their kids and they may need same day appointments at that time as they're going from the school to home. We understand the needs of the community. We understand the needs of our patients, and we're able to navigate to meet their needs where they are needed. Now, if we continue to fight with all these noise around, but provide the clinical practice, as you alluded to earlier, this is unfortunately a ticket to leaving your independence and sometimes joining the other groups. And then the story, how it goes, like one thing leads to another. So I take pride in taking care of my patients, taking care of the community I serve. And we would like to continue to be those family physicians in that small community if we can. But unfortunately, these other administrative challenges are making it harder for us to practice every single day. So I want to thank you for your acknowledging the problem. And the second piece of the comment, I'll just expand on it. I am not against AI. However, I was recently at a national conference and the speaker said something that really resonated with me. AI will probably not replace humans, but it may replace humans who are not using AI. But unfortunately, the AI or the artificial algorithms are trying to do something that should not be there in the first place. You suggested that AI is denying very fast. Let's use AI to approve very fast. My question is, why is there denial in the first place? So we won't even need AI's application to approve it. They should only look at where it belongs. So AI as a technology may or may not be the answer for these challenges, because those challenges should not be blocking or causing a barrier between the physicians and their patients. So I think technology is helpful when it is used for the right reasons at the right place in the picture. So
Yeah, I appreciate, I'll tell you, the only thing I would not correct, but amplify, I wasn't suggesting any day AI to force through the system. It would be helpful to see AI help you fill out the application to apply for your compensation versus hiring 7 people or 6 people, however many people are in your office to do the paperwork. So just as a rudimentary system, it'd be great. I could go online and dictate and have an interactive process where I could fill out my request for compensation. So right now, I think if we use artificial intelligence as a screening process, it by de facto, whether it's accurate and perfect or imperfect, it's just to improve my ability to screen. And I would love to see that it works to improve my ability to process. That's really was my point. It doesn't seem like I'm investing in the right things. And if I have to pick winners and losers in any industry, the idea that I would burden my private suppliers and my independent doctors and family practices versus chains and not facilitate their paperwork so that I could keep them alive and independent in providing competitive services, that would be a goal I would have. I don't want to drive everyone into a franchise. And it sounds like we're driving everyone into a franchise, basically, relationship.
Again, thank you so much for acknowledging this again. And I completely agree with you. We do not want anything that drives us away from independent medical practice. And let me share another example with you, if you allow me. So albuterol is a medication commonly used for children, adults, for shortness of breath, patients with asthma. And albuterol is a generic form of a medication. And there is no, it's already a generic medication. But sometimes, or quite often, I have to even get prior authorization for this life-saving, important medication. And after, so many electronic clicks or telephone, whatever the system may be, even AI filling those, we find out that the 16 milligram dose is not covered, only 8.5 milligram dose is covered. Now, this should not even be something that we have to do. And again, this is something that is purposefully designed to delay. And again, I have no way of saying that what happens at the other end from the insurer standpoint. But as a practicing physician, if I send a prescription in for a child that is seen at 4 o'clock afternoon, it's a Friday afternoon, and I send the prescription in, just to find out that the child never got that prescription because the insurance company blocked it, denied it, delayed it, whatever we want to call it, because the milligram was not as what was approved, and the other milligram is requiring prior authorization. It's the same medication. There is no real, or I shouldn't say the cost. I don't know what the cost difference will be between 8 and 18, but the point is it's not a brand name monoclonal antibody that was just released yesterday. This is a tested and tried drug for many, many, many years. So I think there may be times where all of those things will make sense, but in majority of the practice of a primary care office as a family physician, we have to ask permission to do things that should not even be needed in the first place, let alone to make that process faster or convenient. I'm arguing that should not even be the case to do anything about it or
Right.
having to do anything about it.
Right, right. But thank you very much. Sounds like I'm in the wrong town for a good family doctor to take care of me, but I'll have to I think it's too many miles to come up for a visit, but I appreciate your testimony, doctor.
Thank you.
Thank you so much. Senator Anwar.
Thank you so much, Madam Chair. Thank you, Dr. Goman, for your testimony. Dr. Goman, we were just talking about that the denials of a rate of 1.2 seconds that we have seen, and then the insurance companies are using artificial intelligence to deny care, and then that delays the care, and then they defend it, but this is not defensible. But the impact to the practice and the existential threat to the practice, can you speak to that? How many more personnel would you need? What kind of technology would you need to be able to counter it if you were to use AI? And is this the future, and is this a sustainable future for healthcare?
Thank you, Senator Anwar. And I'm going to start with the latter part of your question. It is not sustainable by any means. From a physician standpoint, from a patient standpoint, from a societal standpoint, it is not sustainable. How long we can push it, I don't know the answer. But this is not a sustainable model. It is going to go down, crumble up in one way or the other. I'm not sure how long it'll take. To answer your question, how many personnel? So I already have two full-time humans, two full-time employees doing the prior authorization. Even for like a CT scan, even for like imaging studies, we need hours of their time to be on insurance portals to do all of that. So in my practice, I may not even have any more wiggle room financially to add more personnel to do that. And I will be unfortunately forced to take the other route, where I may have to close my doors. I may have to merge a larger group. I may have to take the pill that I don't want to take. So all of those unfortunate realities lead to lack of independent physicians in the communities. And at the end of the day, it's a loss to the community. At the end of the day, it's a loss to that patient, that family who has. We take pride in primary care by calling it like we are a 5 C's. We teach this to our students. We are most of the times first contact of patients, families with the healthcare system. And we take the continuity of care over not days and weeks, but years and decades. In my practice, we have 4 generations between different partners coming to the same practice. We provide the comprehensive care by connecting the dots. Like if I have a clinical question that's pulmonary related, I'm going to pick up the phone and talk to you. As a general personal rule in my own practice, I don't consult any consultant unless I can text them. Because when I have a question for my patient, I want to be able to reach my consulting physicians for help and guidance to manage this patient. So we provide complex, continuous, coordinated care in the context of the patient and the families and their beliefs. It is all a part of good practice, good medicine. And I worry about if we are unable to solve these issues, I may not have the luxury of adding 5 more people. I may be looking for a job by closing the doors of this small practice. So I think we are at this point where we either can do something about it in the coming weeks, months, and years to salvage the damage and go on the progressive path to maintain and then bring more people in independent practices. But unfortunately, the path we are currently on is just not sustainable, unfortunately.
Thank you so much for that. And the challenge with respect to the personnel that you need and also the number of denials, have you noticed that when the denial process is moving forward, it is very efficient technology, but when you are fighting the denial, it is archaic. You have to fax the paper. You have to be on the phone holding off. Can you see the disconnect in the industry? And is this because they are light years ahead in one and in the 1940s in the other?
Absolutely. I think it's I don't want to question anybody's intention, but I will say this is a design problem. It is designed this way to accomplish something that I'm not privy to know. So I think this is a not a person, it's a process issue. It is absolutely takes, quick response in denials, but it takes multiple attempts on paper, phone, and other ways to get to the right person. If you get to the right person and then have this approval process. So it is a multi-layered, I think a designed process where it is difficult to navigate, especially when you are somebody like myself in a small community practice.
Well, no matter how big the practice, nobody can counter every 1.2 seconds of denials. There's no human phenomena because on the other hand, it's not possible. And when you're dealing with humans, you don't want the computer to do the job for you. If you're on the clinical side, that's the issue. But thank you so much for your testimony, and thank you for putting a human face to the actual issue that is harming the well-being of the citizens. We all represent the humans that we represent in the state of Connecticut are represented by one senator and one representative, and we should not be part of the movement to deny their treatment, delay their treatment, and then try to have somebody try to defend their denials. So I think your testimony is very helpful.
Thank you, Senator. And I'll just add last comment. And even in today's world, if my patient calls my practice, there is no menu, press 9, press 5, press 0, press that, leave a message. They talk to a human person, a live human person every single time my patients call. And my staff also have been part of this community, part of this practice for years, and we know our patients in a way. Yeah, I'm going to hold your spot, come on in, or let me take care of it right now. There is no like computerized menu to press 9 for this and that. They talk to a human person because we value when somebody's calling their doctor's office, they already are in pain, they already have a clinical concern. We are only trying to make it easier for them. We shouldn't be making it harder for them. And unfortunately, sometimes these unintended consequences of these design problems, patients are the ones who suffer at the end.
Thank you. Thank you, Madam Chair.
Thank you, Senator. Up next, Susie Craig.
Good afternoon, members of the committee. Thank you for this time to speak. I know it's been a long day for everyone. My name is Susie Craig. I am Vice President of Workplace Mental Health for Mental Health America. I'm also a West Hartford resident. And for almost 8 years, I worked at Mental Health Connecticut, which, as you know, is head of the Connecticut Parity Coalition. I worked on the 2019 bill, as we all know, was unanimously passed. And I was hoping we wouldn't have to continue this conversation, but it's a 17-year conversation since that bill was designed to enforce the federal law. I appreciate that the discourse that's happened all day. I wasn't able to be on all day, but I do appreciate the discourse and the commitment for this legislature to really have the conversation about how we can absolutely make sure that parity is actually a success for Connecticut. So in my role at Mental Health America, I work with employers across the country, all industries, all sizes, and that includes Connecticut-based companies. So I'm not here to represent them. I am here to kind of represent the aggregate of what I have learned in working with employers. I have the luxury of working with employers. By the time they get to Mental Health America, they don't ask why, mental health is important. They just want to know what is, as an employer, as a business leader, what can I be doing to support my people? And a big part of that, obviously, is health benefits and making sure that people have access to care and it's the right care. I think, as I said, you have my written testimony. I just want to pull up a couple of points. One is, this is a product that employers are buying. They're buying health insurance. They're making a promise to their employees that insurance will be delivered on. So, when we talk about enforcement, when we talk about compliance, that is all we're asking the insurance industry to do, which is say, hey, you've created these products and now it's time to actually deliver on them. We're talking about 53% of the total population in Connecticut are covered under employer-sponsored insurance. So businesses are essential to helping our residents access healthcare. They're obviously concerned about costs. Everyone's concerned about the rising costs. But again, the employers that I work with, they understand that insurance is a part of prevention and intervention. It is an investment, right? So we're investing in the health of the people that are in their employment. And so in the long run, we're talking about an ROI situation. We're talking about investing in potentially preventing more crisis situations and higher healthcare costs. I think that's, I'm sure that point has been brought across, but I think it's important to reiterate. One other last thing I want to just kind of point out is, I think it's been brought up, this idea of shadow networks, which I think would define a little bit different than I'm about to define it. But what we're seeing with a smaller percentage of employers, the deeper pocket ones, the ones that have more resources to funds.
Your 3 minutes are up. If you could please
Okay. I'll just summarize this one last point. So they are taking care of, because of our broken healthcare system, they are taking care of the healthcare themselves. They are they're hiring their own therapists. They are working with companies that are delivering care directly to their employees, which means that, we are now taking healthcare away from others that don't have the luxury to deliver on that. I will wrap up because I know you have other folks.
Thank you. Thank you very much for your testimony. Are there any questions from the committee? Seeing none. Thank you very much for coming.
Thank you.
I think up next is Julie Schubert. How are you?
Well, thank you. I know it's been a long day, so I am going to summarize and not read my testimony. You have my written testimony. So I just want to thank you, Senator Cabrera, members of the Real Estate and Insurance Committee. We're really here to talk about our concerns on Senate Bill 10. My name is Tricia. This is Dan Diaz. We actually represent the Connecticut National Association of Benefit and Insurance professionals. So as brokers, as agents, we represent a number of employers in the state, not only small employers, but large employers, as well as nonprofits. So I'm going to jump right to the most concerning part in this bill is the language in the middle addresses self-funded plans and stop-loss insurance. So self-funded plans are subject to ERISA, which does impose strict rules and regulations, as well as many of the provisions of the ACA. And it also does cover essential benefits. So I've heard the language used about essential benefits. So one, I know the BUCAs that I represent, they cover all but 2 of the essential benefits that are in the ACA. And those 2 things, guess what? They're not covered in the fully insured market over 50. They are also not covered under the partnership plan or the state of Connecticut plan. So I just think to say that these things aren't covered or say that you need to cover them. They really are in there. And a lot of these carriers do cover a lot of the stuff that is state mandated. I will say I went into a deep dive trying to figure out how many state mandates there are. I could not find that list, but I know it is something that does add to the cost. The big part of this is when you change the individual stop loss for small employers. So right now we have plans, the individual stop loss is either anywhere from 20 to 30,000. To increase that to 50,000 and then move that attachment point from 2,000 to 10,000 puts so much of the expense on the employer to fund those claims, the exposure, that it's going to take them out of that market. It's going to price the carriers out of the market, and they're not going to offer those plans. So what are we going to do? We're going to limit benefits and limit opportunities for employers to do. So some of the things that I wrote down while I was sitting here was the innovation. Like, we'll lose innovation on plans. There's carriers that have plans that they're rolling out. They can only do it on a self-funded basis that has no deductible, only has an out-of-pocket maximum, and puts you, the member, in the driver's seat on what you're going to pay in copays. So I just wanted to hit home how important it is to have these self-funded plans available to all size employers. And then the other thing that I do have concerns about is the language on site neutrality. I think it's important that we have very strong site of service rules. We have been fighting those for years up here. So that's just another thing that I wanted to add. Dan, anything you would like to add?
Thank you, Senator Cabrera, Representative Meskers, and Ms. Barry for the time you guys have spent today. But we know it's been a long day. We've been here with you, and just want to say how much we appreciate your leadership here. As the sitting president of the Connecticut chapter of the National Association of Benefits Insurance Professionals, when this was brought to our attention, specifically the language in Section 10, I just want to try to simplify this and kind of give you a quick rundown on how we got here. The train for self-funded plans, especially in the small group, that strategy used to be reserved for large companies who could absorb that kind of financial risk. That strategy, mother being the necessity of invention here, or necessity being the mother of invention here, is really what happened is bringing that strategy downstream to the small group market was a result of being in the hamster wheel of double-digit increases year over year for more than a decade. I don't know any other product or service where you could increase your rates and be at 100%, literally 100% increase in less than a decade and be sustainable. So being part of that fully insured market and the it's been a double-edged sword being in this community risk pool, right? So self-funded plans have created an opportunity for small employers to remain competitive, because when you look at the costs of any employer and what they're spending, usually the number 2 cost behind your payroll is your benefits. So I'm going to simplify this as much as I can. If the language is not amended in Section 10 of this bill, you are essentially putting the nail in the coffin in the small group health marketplace. This used to be the world leader in insurance. That's not what we're doing here. You're going in the opposite direction. And in thinking of how this was actually written, it's almost as though when the language was written, the author believed that the self-funding piece of this, the aggregate attachment point, and increasing this would actually be transferring the financial risk from the employees and the employers to the insurance carriers, when in fact it's the opposite. You're actually, it's in a self-funded plan and level self-funded plans, the onus of the first part of the deductible and up to that attachment point is the responsibility of the employer. So you're literally taking the money out of the people's pockets who you're trying to protect. So that's as simple as we can put it for you, and what really needs to be amended here. While we would support in theory and actually circumstantially speaking, a lot of other sections of this bill, this one is a non-starter and will absolutely decimate the small group marketplace in Connecticut with only 2 remaining carriers. That's all I have to say, and I welcome any questions.
Thank you. Thank you very much for your testimony. Representative Meskers.
Yeah, I think I made my points and my concerns known before, so I'm just going to steal your brains for your legal expertise. In your reading of the bill, So I understand the reading of your bill is reference to policies in the fully funded market, right? Or,
Fully insured, yes.
Fully insured, sorry. Market in Connecticut for Connecticut residents. My concern, which doesn't thrill me, but that's editorializing. The question I have is, does it preclude Connecticut insurance firms from underwriting policies or change the stop loss that they're going to do away from the policies they write in Connecticut?
I'm not sure I'm following your question. So are you asking whether or not they would write them in other states? Or
Well, I
whether
have
it
two
would-
issues. One, I'm assuming either blissfully, hopefully, et cetera, that a majority of the insurance is written in Connecticut or as much as humanly possible. And so I have concerns about this having its impact on fully insured entities within Connecticut. Now I want to go on to the other side. What's the impact on my insurance industry if are they just prohibited from underwriting or creating and selling within Connecticut? Or would it impact their ability to underwrite, sell throughout? I don't want someone to move into New York to write policies. And I would worry indirectly whether that's either an explicit risk or an implied risk. Because if I've got a franchise, I'm thinking a multi-state franchisee, principally located in Massachusetts, New York, Connecticut. I told him he can't do a self-funded plan in Connecticut. Now, if he relocates and underwrites it and buys the policy in New York, can he underwrite and cover because of interstate commerce? I'm assuming he can offer that fully insured product, which
That's
Connecticut
exactly
and
what-
statute.
That's exactly what they're going to do. What they're going to do is if I have a multi-state company and maybe I'm domiciled here in Connecticut, I'm going to say, you know what? The other state isn't doing this to me. I'm going to domicile in that state. I can still cover my employees that are in Connecticut under my plan that doesn't
Which would be a
cover-
New York written plan, right?
Right.
This is the concern.
New
Okay.
York isn't the state I would choose.
Right. I know. I was born there, so be careful. But I wouldn't disagree. I wouldn't disagree with you. But my concern is it's a secondary concern of an unintended consequence. Even if I was in love with the bill and thought it was doing God's work in Connecticut, my concern is I don't want to drive the rest of my underwriting business that I'm doing over 50 states that might be underwritten and a policy written by a Connecticut insurance company. I don't want to force that to get written in another jurisdiction. That would be the concern.
Representative Meskers, if I could, I would answer your question with a question. Forgive me, but if your second highest cost behind payroll and you're a multi-state company, say you employ 1,000 employees, which some of my clients do,
Right.
and your second highest cost behind payroll is your employee benefits, and you were just added an additional 150% to your
one of your costs, right?
To one of your costs, and that's before you get into the gray area of whether or not you're stepping on ERISA's toes with the state mandates, right?
But you'd
At
write the
additional
policy
cost.
somewhere else. Yeah, is my concern, right?
Where would you move? I mean, is it more expensive to just, lease a new office and call it your headquarters in another state? And then what does that mean for the tax revenue here? Yeah, it's an implied risk and an unintended consequence. I think you're.
I was only listening in the conversation. I was worried about. I was trying to figure out how if I live in Connecticut, I write the policy, and I have to follow SB 10 in terms of the stop loss. Now I've got to carve out my Connecticut pool of employees and that type of insurance policy, or every employee.
So you don't. So what would happen is since they're buying in that state, I, as an employee, choose to work for them. I'm buying my benefits through them. I'm not subject to those Connecticut laws unless you imposed an individual mandate that said you as an individual
Right,
have
but
to have insurance
that's
that
where I
covers
was
all of
going. I'm basically going to get a ring fence, a multi-state. I try to get a group policy for my company. I'm going to have to segregate the Connecticut residents and employees with a new stop loss, and presumably the more eased or differential stop loss I'm going to apply. I'm going to run two different insurance policies ultimately, potentially.
Yeah, but this law doesn't do that. This law will just say, I, as an employer, I'm no longer going to domicile here in Connecticut. I'm going to domicile in a different
No, I
state
agree.
and offer
But
this.
the only better case scenario is not great is that I can't pool my employees in one policy. I have to have a different stop loss for my Connecticut employees than I do for the employees across the state boundaries.
But I do want to also reiterate something that my colleague here mentioned, and that is the innovation. Because what I will say is one part of the benefit, and I think it was an initially unintended benefit of having this strategy that was typically reserved for large groups that came downstream, is the innovation. And I have several groups that have $0 copays for office visits, for mental health. That was on a parity level, something that was already had been addressed by many of the carriers. Now carriers will go down to as little as 2 employees. So you could have a plan that you have more flexibility in choosing your out-of-pocket maximums. I've got one company's got a plan with a $1,500 out-of-pocket maximum. And it's only a gold level plan, but it's brilliant. And deductible's $500. And this is a small group that has like literally, I think, 6 employees that we're writing here in Connecticut. And they're a blue collar shop. I mean, this is unheard of. They get to do things like that because of the law the way it is. And if it were to change, we're now going to tell them they have to go back to the fully insured marketplace where they're going to pay 30% more right now. So
thank you. No further questions.
thank you.
Thank you, Representative Meskers. Representative Berry.
Thank you, Mr. Chair. Thank you both for being here and for your testimony. We've heard all day from businesses about the cost and what it's going to do to them. And you did hit on how much the impact it's going to have on the employers. What about the consumers? What impact will this have on the consumers?
Thank you for your question, Representative Berry. It will have a direct impact because they will be, when I say employers, inherently their employees are impacted by it, specifically in the out-of-pocket costs. Because again, before you reach that attachment point that we were referring to, what's included in that is the employees' co-payments, their deductibles, and their maximum out-of-pocket before it even gets into the employer's money. So they're actually on the front lines taking the first hit.
And if your premium goes up, your contribution's going to go up.
Thank you, Representative Berry. Any questions from the committee? Thank you.
Thank
Have
you.
a great evening. Thank you for coming.
Thank you.
Up next is, I hope I'm saying this right, Natnapir Sydney? No? All right, I don't feel so bad. Kimberly Ray. Is Kimberly Ray here? No, okay. Alyssa Tripodi. Nope. Okay. Batting 100. Christelle Arison. Okay, Kristen Pendergrass, you're up. If you're online, I think.
I'm here.
How are you?
Thank you, Mr. Chairman and members of the committee. My name is Kristen Pendergrass. I'm the Vice President of State Policy for Shatterproof, and I appreciate the opportunity to testify in support of Senate Bill 10. I am also submitting written testimony, so I will be brief. Shatterproof is a national nonprofit dedicated to ending the addiction crisis. We are based in Connecticut, where our founder, Gary Mendel, lives with his family. And Gary started Shatterproof more than 10 years ago after he lost his son, Brian, as a result of his substance use disorder. One of the main pillars of our work is to ensure access to quality substance use disorder treatment for individuals in Connecticut and throughout the country. Our quality treatment locator, treatmentatlas.org, helps individuals and families identify treatment facilities that meet their needs and includes all Connecticut treatment facilities as of October 2023. But we know that accessing quality treatment means more than identifying the right facility. You also have to be able to afford that care, which is why we advocate for behavioral health parity at the state and federal level. When it comes to substance use disorder, insurance coverage can truly mean the difference between life and death. An individual who is ready to seek treatment for a substance use disorder is likely in a very fragile position, as are the people who love them. And having to fight for insurance coverage of life-saving SUD treatment can mean that the window of opportunity to get care closes, or that a person cannot access the right care for them, or that their family has to make a dire financial decision. Shatterproof is a member of the Connecticut Parity Coalition, and we represent thousands of people in Connecticut and around the country who have been impacted by substance use disorder. We support Senate Bill 10 to ensure that behavioral health parity laws are enforced in Connecticut. thank you for the opportunity to testify on this important issue.
Thank you so much for coming to testify. Are there any questions from the committee? Seeing none, thank you very much for coming.
Thank you.
And I hope you have a good day. Kate Nelligan? How about Kevin McGee? All right, Kathy Flaherty. All right, Kathy, you're up.
Thank you, Senator Cabrera and members of the Insurance and Real Estate Committee. My name is Kathy Flaherty. I'm the Executive Director of Connecticut Legal Rights Project, and we represent DEMAS clients who live in the community to protect their civil rights. We are also a member of the Connecticut Parity Coalition, and I'm here appreciating the time to testify in strong support of Senate Bill 10, specifically sections 1 through 4. You've heard from my colleagues today about the problems with the 2019 law, which was a great start, but doesn't really have the teeth and the enforcement power that it to give to the insurance department that we really need to get the behavioral health parity that people in Connecticut deserve. And what this bill would do would improve transparency, increase accountability, no longer shield the names of insurance companies that may be violating parity laws, and really hope to bring it home that insurers, despite all they're doing, often provide barriers to care, because whether it's the inadequate networks, which result in long wait times, where there are reports that say nearly a third of people have to go out of network for care, or people are having their claims denied. We'd really appreciate the support of this committee for Senate Bill 10, specifically the sections on mental health parity, and I appreciate your time.
Thank you very much for testifying today. Are there any questions from the committee?
If I may.
Oh, Representative Meskers.
Look, I'm not going to ask a question because it's late in the day, but I want to acknowledge your testimony and your support for parity. I think I'm going to wrestle with the issue because I understand the intent. I think the idea of parity which is essentially secured accessibility, to use an easier concept for me to chew on, but it's access to care. That's what we were talking about, and so I appreciate your testimony. It does ring true. I have to go back and really read through the bill and make sure I'm comfortable with how it's mechanized to happen. But I like the idea of the parity issue. So thank you for your advocacy, and you were heard. Is I think most
Thank
important
you.
thing you did. Thank you.
Yes, you were. Thank you very much, Representative Meskers. I don't see any more questions. Thank you so much for coming today and for your testimony. And last up, but not least, is Mr. Brian Anderson from AFSCME. You're up, sir.
Thanks, Chairman Cabrera, Representative Barry, Representative Meskers, members of the committee. My name is Brian Anderson. I'm a legislative director for Council for AFSCME. Our union represents 2,000 municipal police officers, among other public employees. Our union strongly supports House Bill 7069. This bill is needed to shield police officers from having their health records released unnecessarily. Current state law says that police officers must undergo a mental health assessment every 5 years. It came to our members' attention that there was a police officer in one of Connecticut's larger cities who was questioned about a health matter not dealing with their mental health during a regular mental health assessment. The officer objected and the assessment was stopped. This bill would provide protection to all police officers so that their health details not dealing with mental health are not brought up or exposed during the mental health assessment. Please remember that the General Assembly passed a law that requires to get mid-career mental health exams. If they don't pass them, their career can be jeopardized. So at best, it's a stressful process for our members. As much as police unions and administrations have tried, there is still a stigma associated with mental health. Having an incident like this one just makes it tougher to build confidence among our officers in mental health treatment. We all know that mental health treatment can save lives, especially in high-stress professions like policing. Thanks to the committee and Representative Wood and Representative Barry for researching this incident and coming up with the bill to protect our officers. We appreciate it greatly. This bill helps protect those who protect us. I'd be happy to answer any questions.
Thank you so much, Brian, for your testimony today. Any questions? Representative Barry has a question.
Thank you, Mr. Chair. I just want to say, well said, Mr. Anderson, well said. Thank you.
Thanks for your help, Rep. Barry.
Thank you for coming today, Brian. I think that concludes our hearing, right? No more? Well, we'll call this meeting adjourned and subject to the call of chair. Thank you.